research and its translation into clinical radiation oncology. This includes innovative studies on cellular responses towards radiation, identification of biomarkers, and experimental therapy approaches. With this aim, let's start today's session and invite the dignitaries and learn from them. We are pleased to invite Professor Anil Kumar Mishra, Director of Institute of Nuclear Medicine and Allied Sciences, DRDO, New Delhi, and Professor Vibha Tandon, Special Center for Molecular Medicine, Jawaharlal Nehru University, to chair the session. Professor Anil Kumar Mishra, in his illustrious scientific career, has held positions as research scientist at University of California, USA, senior scientist at Institute of Health and Medicine Research, France, and visiting professor at Max Planck Institute, Germany. I request the chairpersons to chair the session.
Very good morning, dear colleagues. To start with, I will just like to share my views. And before I do that, Honorable Madam Vice Chancellor Janu, distinguished guests and speakers, participants, and Professor Tandon, very good morning. What I see in this session is that most of the people are my mentor, either my teacher, but I would like to really justify in my opening remark is that I'm very happy and delighted to see the program in radiation biology and clinical application, where I see my mentors and teachers, they are going to really do a deliberation and to give the talk and to justify really that what radiation biology means for the clinical application. I feel very proud and privileged to share that Institute of Nuclear Medicine and Allied Sciences was the first in the country to think about harnessing the peaceful use of atom for humankind. It means that if you talk way back in 1961, Institute of Nuclear Medicine in Mass, they thought of the medicine of tomorrow to think that if we do not harness today, we'll be certainly going to borrow it from some other nation, either from somewhere else. So this is the one thing that I feel very proud and happy that we are going to have very scintillating talk on radiation biology and its application, clinical application. What can be the more visionary people in way back in 60s and 50s when they think about it? I just remember one thing about Hiroshima. When it took place, then Gandhiji said that I would never like to see anything going to happen in the field of nuclear energy. Reason being is that it has really inflicted and damaged around the globe, either the people in the different part of the world. But today, I can say that if Gandhiji was alive, he could have witnessed the peaceful use of atom for clinical application, either the application that we have envisaged. And with this, most of the people, those who does either practice nuclear medicine in the country, they are the disciple, either student of Institute of Nuclear Medicine, Allied Sciences under the Ministry of Defense, DRDO. So it's a very it was tempting and appetizing that we have really thought about this radiation biology and clinical application to really see that how it is disseminated globally for the application that we think about by doing academic networks. What I see the point over here is to drive that once upon a time, there were two institutes and a very defined area that you can say that in radiation biology, in Mass and BARC at certain extent in GENU. I do remember the meeting was organized way back in 98, 99 of the application of radiation as the nuclear energy for human application, and the many discussion took place in the field of different type of disease of human origin. I feel so happy and proud today that barrier has crossed. It was a small cell somewhere in the institute. Now it has become a global. Global means that when it goes to institute like either university like Jawaharlal Nehru University, and to talk about this radiation biology and students and faculty that they are going to share. It means that we were able to really translate from a place, and it goes to be going to be a global. Reason being is that what we were working in a small cell, and now it has become a full grown up, either you can say branches out in the form of beautiful tree, and that is going to really guide each one of us today, and starting from the smart cohorts to very larger cohorts where many people they are going to work in this area, and they can understand the beauty of radiation biology. They can understand the beauty of nuclear energy, that how it can be used for the different application. Today, if you talk about any tools and technology in the disease, if you do not have this radiation, you will not be able to see that what is happening. Just few minutes back, we were discussing with Dr. Dwarkanath that to see even residual tumors, even micrometastatic lesion that we talk about, that we want to visualize it. It is possible only because of this radiation biology work. We knowing the markers, we knowing how we can tag it, we can really visualize it as early as possible. With this, you can imagine that coming from university to college to large population, and is going to really help to happen today or tomorrow, is going to be one of the medicine of ahead of tomorrow. Reason being is that you talk about modern medicine, either traditional medicine, they have to exploit this nuclear energy for clinical application. With this, I would like to introduce our one of the panelist speaker and chairperson, Dr. Sunil Dutt Sharma. You see that any radiation biology, either anything that you work in the field of radiation sciences, if medical physicists are not there, it's just like that you have got everything without backbone. So they are really backbone of the entire work that we are going to discuss today. And anything that you see and you want to treat it, they are the group of people, they really let us know that how you have to plan, how you have to treat it. So you can imagine that if you do not have the development, you do not have proper dosimetry, you do not know that how much dose has to be imparted at the site. So these are the group of people, they certainly guide us that how we can really treat the lesion, either the disease lesion, and trying to avoid that the lesion which is not disease, either the to avoid the healthy at the safe with the place that we are going to work, having in mind that if something that is going to kill is certainly a kind of danger, either kind of something associated which can be really troublesome. So radiation safety is the aspect that they try to see about this. I will be very happy to let you know that he has got excellent publication, more than 115 peer review publication, and more than 175 abstract in his credit. He's decorated with a very you can say that the award, that is the excellence award that we talk about in his credit, that is one of the very prestigious from Department of Atomic Energy that he got in 2013. And at the same time also he got the Deke Ganguly Felicitation Prize in 2014. Likewise, he has so many achievements to his career and to his credit. Besides that, he is the associate editor of Journal of Medical Physics, that is very known journal in the worldwide. And anywhere you work, that if you do not have the radiation safety officer, that institute, either instrument, either tools that you are using for visualization cannot be functional if they don't give us go ahead, either work and to do the quality control. And he has been the president of Association of Medical Physicists of India, MFI. With this, I give hand over to Dr. Sunil Dutt Sharma ji, and he will be talking about this. And with this, I really congratulate Dr. Vibha Tandon to bring all the mentors and teachers at one platform globally, from India, from outside the India, to really share their knowledge that how we can take it forward in our country, so tomorrow we should not be dependent on somebody else. So with this, Jai Hind, Jai Bharat, and this session is open for a discussion with Dr. Sunil Dutt Sharma, please.
Thank you very much, sir. And I am really thankful to you for a very nice introduction. And it is my pleasure to present this talk under your chairmanship. And I hope I will bring some good information for the participants. So I would also like to thank the organizing team, and especially Professor Vibha Tandon, for inviting me. It was on a very short notice. I got the message, and somehow I thought that I will also like to participate here. So I will start the presentation now and try to give an overview of the radiation therapy, various aspects. In fact, Madam has given me a very long title, which can usually be covered in 20 lectures in our courses. But here I have to do this within 2 to 3 hours, so I will try my best to cover everything.
Yeah, Professor Sharma. I will request Dr. Anil Mishra to stay with us. I just wanted to, if you allow me, then I can just.
Yeah, please, madam, please.
Yeah, so we have time. Just give me 2 minutes. So because GIAN program has one more objective, that we need to collaborate with each other, and his director, he may disappear. So I just want to him tell few things to our say participants. We have lot of faculty from Sabdajang, from Gangaram. Some clinicians are here, and we have students here. So I just wanted to inform all of you that Professor Anil Mishra has created a state-of-art infrastructure of at the INMAS, and we call it the radio pharma. That center is called as the Molecular Imaging and Research Center. So this center talks about the translational research, and his major area is the development of radiopharmaceuticals. He's a chemist who has become a biologist, who has become who interacts with the clinician. So I would say that he has created a center which has a paired cyclotron, and so he's an institution builder also. And INMAS, he has a center which is equipped with NMR, LCMS, HVLC, molecular modeling facility, synthetic chemistry facility, nanotechnology, advanced radiochemistry, and preclinical animal facility. So people who want to collaborate with him, he has almost 300 publications. So, but I would request with Dr. Anil Mishra, and with this introduction, I just want to put more burden on him so that he stay with us till Professor S.D. Sharma at least finishes his first lecture. Sure. With all these things, I just wanted that the people who want to collaborate there, because there were some queries yesterday from the participants that where are the radiation biology is being, a lot of queries I'm getting in email. So that I'm very sorry, Dr. Sharma, I stopped you in between because I wanted to tell the students that so now you will learn from SD Sharma also. So BARC is also another pioneer institution. So today you have two people together, and who are pioneering in the area of say radiation, and they work in all the area of the radiations. Say they also work for the soldiers also who face a lot of radiation. So a lot of things are there. So with all these things, once again, I would like to welcome Professor S.D. Sharma for delivering his lecture. Thank you very much.
One thing is, Bibha, that I never take it as a burden. It's my pleasure, and I will be always happy and more than happy to welcome anyone wants to do anything in the field of radiation sciences for clinical application, either application in basic sciences. So what I see here is that Professor Kale is there, Professor Dwarkanath is there, G.K. Rath is there. So they are all our mentors. So we will learn from them. So with this, it's my pleasure. It's not a burden. Thank you very much, Dr. Bibha, for saying this word to me. We'll certainly see that anything is required. We'll be always there. We'll be the coming forward.
Okay, sir. Please, Dr. Sharma.
Okay, madam. Thank you very much. Thank you, madam. And now, so good morning to all. And I also see that there are many seniors. I have got guidance from them in my so far the long career, and I hope they will also get some information from my talk, and I will definitely request that they should continue. It will be my pleasure that they are there during this presentation. So thank you, madam, once again, and now I will start. So I will be, the topic given to me for the first lecture is current status and practice of radiotherapy. And my introduction is already given by director in mass. So now before going in detail, I just want to give some gist about the radiotherapy. It is radiotherapy is a growing in prevalence, and we know from the global data that more than 60% of all cancer cases receive radiation treatments either as a single mode of therapy or in combination with other modes of treatments. Treatment intent is curative as well as palliative depending on the case. Radiotherapy is in fact a non-invasive treatment technique, and inoperable patients can even receive radiation. This mode of treatment does not require any recovery time for the patient. So if the patient is moving and walking, so they can continue their productivity and can undergo the treatment. Radiation therapy in today's time with technological advancement is thought to be having minimal side effects, and it is flexible to eradicate the disease tissue and to sterilize the microscopic disease. So this is basically a gist of the radiation therapy. Now, before going in detail, I hope this curve might have been shown by earlier speakers also. This is the basis or basic principle of radiation therapy. So if the curve for the tumor and normal tissue or organs at risk is having a very good separation, it is very beneficial for us to plan the treatment and deliver the dose. So our intent is to minimize the side effects to the normal tissue or organs at risk and deliver tumor-cidal dose or escalated dose to the tumor. So now, if we need to classify radiation therapy, there are two broad categories. One is called beam therapy or external beam therapy, and other is called brachytherapy. In case of beam therapy, usually the radiation beam is at certain distance from the patient body. However, in case of brachytherapy, the source is either inserted inside the natural body cavity or through surgical incision, or it is placed over the patient body. So beam therapy has now gone through a very long phase, starting from conventional 2D radiotherapy to 3D conformal radiotherapy. In today's time, clinicians are practicing intensity modulated radiotherapy. Even image guidance are also provided. And then if the IMRT is done with rotational mode, then it is called modulated arc therapy. Either it is volumetric modulated or single beam modulated. And then finally we have osteotactic radiosurgery, radiotherapy, and even osteotactic body radiotherapy. In case of brachytherapy, there are various ways of classification. So one way of classification is as per the clinical application. So the technique is called intracavitary brachytherapy. It is basically related to the treatment of gynecological cancer, interstitial application, intraluminal applications, for example, esophagus and nasopharynx, intravascular treatments for the coronary arteries or other veins, and surface mold treatments for the tumors on external surfaces. So now I will start with one by one. Now I will give you a glimpse of beam therapy, and before going for beam therapy, we should be aware what are the varieties or a spectrum of sources and equipments are available to us. So if we see the whole technology and sources available to us, a large variety of radiation beams starting from electrons, gamma rays, X-rays, protons, neutrons, heavy ions are used for treatment of varieties of cancer cases. Medical electron linear accelerators are the mainstay of the treatment today, and usually they are basically electron accelerators, but bremsstrahlung generated by the medical linacs are commonly used for radiotherapy. Both conventional and technologically advanced medical accelerators are now available, and they are used worldwide for clinical application. Even proton and heavy ion accelerators are also being used in radiotherapy. So in our country, one proton facility is working, another one is just on verge of commissioning, and as per my knowledge, one more accelerator is under the process of installation. In recent day beam therapy technology, it is fully technology driven. So now we have varieties of imaging equipment. We have varieties of options for beam shaping and monitoring. Even in some situations, if by the way we are dealing with lung tumor, there is a problem of internal organ movement, and that needs to be corrected or taken care of. So we have devices to take care of these movements and deliver the dose in a localized manner to the tumor. The techniques of beam therapy, as I told earlier, is now IMRT is thought to be the main technique for treatment of many cancer cases. Sometimes it is supported by image guidance, then it is called image guided radiotherapy. Osteotactic mode of applications are also used. Osteotactic applications can be used for either intracranial region or lesions outside the extracranial lesions. So there are other modes, some of which I will discuss later. In case of IMRT, which is talked to be a common treatment technique today, here it is somewhat different from the basic philosophy of radiation therapy. In the past, we were using a beam of uniform intensity pattern and trying to achieve the uniform dose distribution inside the tumor. But in case of IMRT, the photon frequency is varied across the region of treatment, and then the uniform dose distribution is obtained. In nowadays, the flattening filter free photon beams has also been increased, which has given further options for executing other advanced mode of radiotherapy. So now, before going in detail, I will just give you what are the equipments available to us which can be used for using various treatment techniques. So first, we have a very standard medical electron linear accelerator, which is having jar type of collimator for beam shaping, as well as multi-leaf collimator for beam shaping. And as far as radiation beam is concerned, usually we have 6 MV X-rays and 15 MV X-ray or 18 MV X-ray. This is the choice of the user. And generally, these accelerators are having 5 different electron beams. The energy starts from 4 MeV in some accelerators and 6 MeV in other accelerators, and it goes up to 18 MeV. So this is just the head design of the accelerator, where one can understand this is the accelerating tube, and it is coupled with electron gun. The accelerating electrons are injected by the electron gun and then accelerated up to the required energy, and afterwards they are extracted. So this is the bending magnet which guides the electrons to move in a particular direction, and then finally it strikes the target. And after production of X-rays, or if we do not require X-ray, then target has to be removed and a scattering foil needs to come into the picture, and finally the beam is need to be collimated as per the geometry of the tumor. So this is the basic principle of working of the accelerator. In a standard accelerator, we usually refer that we are using a flattened beam. A flattening filter is used to give uniform intensity pattern at the plane of requirement or observation. So this is one of the example of the beam profile which has the flattened beam, and uniform intensity pattern is required within a variation of plus minus 3%, and symmetry of this beam is required within variation of plus minus 2%. So this is called the use of flattened photon beam for treatment of cancer cases. But nowadays we have both. A single accelerator can generate either flattened photon beam
No voice.
as well as, excuse me, as well as
in between there was no voice, so I thought maybe something is wrong.
Sorry. So are you able to hear me now?
Yeah. Now it's okay. Okay, please go ahead.
Sorry. So now we have accelerators which can generate both flattened as well as unflattened beam. So this is one of the accelerator which generates flattened beam, and its further version, which is called true beam from one of the supplier variant, is now having option of generating both flattened as well as unflattened beam. If we want to see the radiation, then it is basically forward peaked bremsstrahlung spectrum. Dose rate is substantially affected because of the flattening filter, which is thought to be a major drawback of operating the accelerators in the flattened mode, because we are losing a large amount of beam intensity which could have been utilized for delivering the dose at a higher dose rate to the tumor. So this is the similar accelerator from the other vendor, that is Electra. Now you can see here the onboard imaging systems are also available. So now this accelerator is basically versatile accelerator which has got option for mega voltage imaging, that is called portal imaging, as well as the KV imaging. So this KV imaging is used for image guided radiotherapy. Other mode of accelerator which is called a specialized radiotherapy accelerator is tomotherapy. This is the working principle of this machine is basically like a CT scanner, but only difference is rather than having 150 kV X-ray tube, it is containing a 6 MV accelerator which rotates on the ring gantry. And the most ultimate advancement in the technology of the accelerators is currently in the form of Cyberknife. Cyberknife is having a 6 MV accelerator and it can approach the tumor from different directions, and because it has got 6D options of movements. Here, the tomotherapy and Cyberknife generates unflattened photon beam. In the past, the Siemens, which was also one of the player in the market for giving therapy accelerators, they have introduced a version which is called Artrist, and they were also having a CT scanner which is called CT on rail. So now you can see that the couch of the accelerator as well as couch of the CT is placed on a rail which was able to move here and there, and it was not required for the patient to move from one couch to another couch. Rather, imaging, planning, and treatment is delivered when patient is lying on the same treatment couch. This is the recent version of the accelerator, which is true beam of Varian medical system. If we see the architecture of this accelerator, this also contains the components whatever is available in flattened beam accelerator, but the basic difference is the waveguide system has been modified slightly. Carousel assembly now do not contain flattening filter. Beam generation and monitoring control systems are also modified because they have to it has to deal with high dose rate. Photon energy, which is X6, means it is a flattened beam, and X6 triple F means unflattened beam. So it has options for giving 6 MV flattened as well as unflattened beam and 10 MV flattened as well as unflattened beam. The major advantage of removing the flattening filter, as I told earlier, is now we were getting the dose rate up to 600 monitor unit per minute. You can take it as a 600 centigrade, that is 6 gray per minute. But when we have removed this flattening filter, dose rate has gone up to 14 gray per minute in case of 6 MV flattening filter free beam, and 24 gray per minute in case of 10 MV flattening filter free beam. The multi-leaf collimator of this accelerator is also somewhat improved. It contains 120 leaves high definition multi-leaf collimator, which has 32 central pairs projecting 2.5 millimeter width at the isocenter, and the peripheral 28 pairs projects the 5 millimeter width at the isocenter. So this is just for understanding. This is the beam profile of unflattened unflattened photon beam. Now you can see here that intensity pattern is no more uniform, and when we are doing intensity modulation or we are delivering the treatment by other advanced treatment modes, this uniform intensity pattern is not a requirement. So this option is suitable for the clinical application. As I indicated earlier, multi-leaf collimators are now the mainstay, the beam collimating system. Multi-leaf collimators of different makes, models, and variabilities are available from different vendors. So this is just for giving you a feeling that if we would have used only 4 blocks for shaping the beam, we could have either gone for a square field or rectangular field. But if we have divided this square or square blocks in multiple small blocks or bars, if they have been provided option for moving with independent motors, probably they are able to give us the field shape up to complex like this, whatever has been projected here. And this is the location of the multi-leaf collimator in Varian accelerators, that is a tertiary, and here in case of Siemens or Electra, it is a secondary multi-leaf collimator. The recent advancement in the telecobalt based or cobalt 60 based equipment is the ViewRes system. It is basically a magnetic resonance image guided system. It contains 0.35 Tesla MRI. It is a 70 centimeter bore treatment unit. It contains 3 cobalt 60 heads placed 120 apart with divergent multi-leaf collimators. This device can deliver the treatment either by 3D CRT, that is called nowadays as conventional treatment mode, IMRT, and can also deliver Sbrt. So I will discuss about this technique in somewhat more detail later. Monte Carlo based dose calculation is only possible because it includes a complex dose calculation formalism. This device has ability to track tissues at 4 frames per second using MR system, and on couch adaptive radiotherapy is also possible. So this is cutaway view of this system, and now it is working in few centers in USA, and the outcome of the treatments have been reported very good so far. The another device is tomotherapy. It is basically helical tomotherapy machine. It contains 3 MV X-ray beam for imaging and 6 MV X-ray beam for treatment. Source to rotation center distance is about 85 centimeter, and source to detector distance is about 145 centimeter, and the maximum field size which can be defined using this machine is 40 by 5 centimeter. And other details are here. I do not want to read all these. Here it is using a binary multi-leaf collimator which is continuously closing and opening, and during treatment gantry rotates continuously around the patient, and the table also segments depending on the requirement. One of the beautiful aspect of this machine is that it also contains a beam stopper which minimizes the shielding requirement for the housing where this device has to be placed. This is just a cutaway view of the tomotherapy machine. It contains many components, whatever required for whatever required for operating an accelerator, and this accelerator tube has to rotate. So this is the LINAC tube, and it is rotating in a circular trajectory. This is cutaway view of the tomotherapy machine. This is you can see the linear accelerator, then it's collimating system, multi-leaf collimator. This is the beam, then it is a detector for imaging, mega voltage imaging, and ultimately this is the location of the beam stopper. This is the photograph of the binary collimator system. So you can see that there are 64 leaves. The odd leaves are arranged in one of the block, and even leaves are arranged in other block, and these leaves are continuously moving whenever the machine is operated for the clinical use. Even it has been thought that this device can be used as a standalone system with its own imaging system even for planning, because the images taken by this device can be transferred to the planning system through DICOM mode, and planning can be done. But so far as I have gone through literature and find that the quality of images are not so good which can be used for treatment planning. So still we require help of the CT scans for the patient whosoever undergoes the tomotherapy treatments. I will skip this slide because I do not want this much detail for this audience. The beam profile of the tomotherapy, because now here is you see that there are two dimensions. One is having maximum 5 centimeter and another is up to 40 centimeter. So for 40 centimeter, the beam profile looks like this because this is an unflattened photon beam, and for A small, if I take the beam profile along the smaller direction, 5 centimeter, then beam profile looks as good as a flattened photon beam. So we have to deal with these two situations if we have to approach for the dosimetry. The next device in this series is Cyberknife, which is basically a robotic radiosurgery device. The linac is mounted on a robot and it is capable of producing 6 MV photon beam. The distance between target to isocenter can be varied between 60 to 120 centimeter, but for the purpose of dosimetry and other QA related issues, 80 centimeter is taken as a pseudo isocenter. Available treatment field sizes with this device is circular, starting from 5 millimeter to 60 millimeter, but the vendor has come with improved version of the collimator system now. So they have got this circular aperture shaping as well as multi-lip collimators available as a choice for the user. The beauty of this device is it does not require any immobilization device for the patient because it has got a continuous patient monitoring system and the accelerator on off is guided and controlled by the signal received from these devices. So it has got two X-ray device available in the room as well as this position sensor for the patient, which controls the treatment of the patient and on off position of the. So these are the details about the devices. Now I will come to the different radiotherapy techniques. So first and foremost, earlier in the very beginning, we were dealing with 2D, but now nobody talks about 2D or everybody talks about 3D in today's time. So 3D conformal radiotherapy was the further modification in 2D approach, and it was thought on those days a complex process that begins with the creation of individualized 3D digital data sets for patient tumors and normal adjacent anatomy. The data sets are then used to generate 3D computer images and to develop complex plans to deliver highly conformal, which can also be called as highly focused radiation to the tumor, and sparing of the normal tissues are provided as per the requirement because higher dosage of radiation can be delivered. Sorry for interruption. So because higher dosage of radiation can be delivered to cancer cells while significantly reducing the amount of radiation received by surrounding healthy tissue, the technique increases the rate of tumor control and also helps in decreasing the side effects. 3D CRT is used to treat tumors that are close to vital organs and structures for radiation therapy like head and neck tumors, which helps in minimizing the dose to a spinal cord, optic nerve, salivary glands, and other important structures. But I would like to tell you with the introduction of IMRT, now the 3D CRT has, this IMRT has almost replaced this technique. So the 3D version of this option is hardly used in any of the centers nowadays. So even 3D CRT is thought to be a conventional approach now, and IMRT and other techniques are thought to be some advanced approach. So in case if we have to compare conventional RT and IMRT, there is one basic difference between these two approaches. In case of conventional RT, field shape conform to the outline of the target, and we deliver uniform intensity across the pattern, and whatever we see confirmation, that is from geometric point of view only. But in case of IMRT, non-uniform intensity is delivered across the field to obtain the uniform dose distribution in the target, which fulfills the requirement of the radiotherapy. So then I will talk something about the IMRT as well as conventional RT. For example, if we have to treat a tumor like this is the picture. And if I am adopting the conventional treatment approach, that is 3D CRT, then I have to use a uniform intensity beam and deliver the treatment. So finally, if you plot the fluence pattern, you will see like this, because this is the tumor to be treated and this is the spinal cord needs to be protected, for which usually we place a block to minimize the dose to the spinal cord. So ultimately, the fluence pattern will be visible like this. Now, if we, so this is the beam arrangement for the conventional treatment. You can see there are 3 beams used for this treatment, and there is a shielding provided for a spinal cord in all these 3 beams, and accordingly the fluence pattern was obtained, whatever we have seen earlier. But in case of IMRT, if I have to treat the same tumor and we have to protect this structure, then here the large single informed field is divided in multiple small fields, which are called beamlets, and the 3D geometry of these beamlets are called voxels. So here we deliver dose to each voxel depending on their extent and size and location. And finally, if we draw the fluence pattern, here you can see that this fluence pattern will be visible like this. So when fluence pattern is converted to dose, then it will be looking like a uniform dose distribution to the tumor. Usually the IMRT is delivered requires the sophisticated beam shaping system. So multi-leaf collimators are available nowadays of various makes and model, which helps in delivering the IMRT by 2 different techniques, either a step and shoot or sliding window. In case of a step and shoot, the gantry is rotated and brought to the angular position, whatever is required, and a beam pattern is created, and then the accelerator delivers the beam. However, in case of sliding window, the gantry rotates continuously, and the collimator system also moves continuously and shapes the beam as per the requirement of the tumor. So this is the technique. If I have to see the IMRT workflow complete process, it is requires the patient immobilization. Then we require images for planning and as well as for verification. Even later on, this contour, target, volume, and normal structure needs to be delineated appropriately. Then select beam geometry and energy as per the need of the patient. Planning can be done either by forward planning algorithm or approach, or inverse planning algorithm or approach. But nowadays inverse planning algorithms are used, and they are also used for even optimizing the plan. Then plan evaluation is done by more generally by the approach of dose volume histograms, and if it is found suitable, it is given the approval that this plan can be used for treating this patient. Then patient is brought to the treatment couch and undergo the required setups. Then treatment is delivered. After treatment delivery also, a mega voltage image is taken of the patient so that this can be taken as a record that this patient has been treated and this region has been irradiated. Then patient dose verification is another aspect, which is either done in phantom or post-treatment through the images obtained by mega voltage system. And finally, we have to do the machine-related quality assurance also, because the performance of the accelerator has to be verified with every treatment. So this is the complex exercise when one has to approach the IMRT treatment for a given patient. The IMRT treatment plans typically involve a steep dose gradients near critical structure, for example, a spinal cord. So if we are approaching for fractionated treatment, the reproducibility of patient positioning is one of the paramount requirement. For that purpose, we use a patient immobilization system which brings the patient or set up the patient at the same location for reproducing the treatment or delivering the same treatment to same geographical region. And this enhances the probability of tumor control and minimizes the dose spillage to the unwanted regions of the patient. As far as imaging is concerned, a spiral CT scan or a MR scan of the region of interest is required. In doing this, usually slice thickness of 3 mm or even lesser is preferred, because when you take larger slice thicknesses, probably it is not going to serve the purpose. So typical slice thickness of 3 mm is thought to be optimum choice, because we need not deal with large volume of imaging data, because it requires computer space, as well as we should not minimize the spatial resolution, which do not give the optimum plan for this patient. So treatment plan is done for the patient. So either, as I told you, either forward planning algorithms or inverse planning algorithms, but inverse planning is one of the important choice. Now even a stochastic approaches are also available, which is called iterative approach and hybrid methods. So people are preferring nowadays hybrid methods are thought to be one of the methods of choice for plan generation as well as plan evaluation. The plan evaluation, as I told you, is done by dose volume histogram. So in case of plan evaluation, we have two approaches. One approach could be, we usually review the dose distribution in different slices of the patient or different regions where tumors and some of the secondary spirits are available, and then decide. Afterwards, we want to see numerically what is the volume of the tumor getting informed irradiation. So you can see here, this is the dose volume histogram for the tumor, and this is the dose volume histogram for the organs at risk. So here you can see this is a yellow line is for the bladder and the green line is for the rectum. Ideally, this line should have gone like this, which is an ideal requirement, but it is impossible to obtain in practice. But in case of tumor, this seems to be a very good plan, and this dose volume histogram gives confidence that how this plan can be executed on patient while giving tumoricidal dose at the same time maintaining the tolerance doses to the nearby organs. The dose delivery is also a complex exercise here. So here we have to translate the calculated fluence matrix to deliverable treatment matrix. And there is in every planning system, there is a this leaf position calculator, which is transported to the console of the beam delivery device. So now here you can see, finally, say for example, if we have to generate the geometry like this, so this whatever data obtained from the leaf position calculator, it is executed by the control system of the accelerator. It also the MLC position calculators also takes care of the leaf end shape, because there is a larger transmission at the edges of the leaves because they are rounded leaves, and because of that there will be larger geometric penumbra. So this is taken care in calculation. Leaf transmission is also incorporated. Tongue and groove effect, because when these leaves are assembled one by one, they have to have by some mechanical arrangement. So this arrangement is called here tongue and groove arrangement, and there, because of the tongue and groove arrangement, the shielding along given ray of radiation is somewhat lesser than the total body of the leaf. So this is called tongue and groove effect. So this is also taken care by the leaf position calculator, and leaf speed and acceleration is also decided by this calculator. So what I mean to say, it is a fully computer controlled system which helps in delivering the IMRT. And since this is a fully computer control system, we do not know exactly what is happening. Because of that, there is a provision for pre-treatment dose verification for the patient as part of patient-specific QA. And we also do a machine-specific QA for testing the functioning of different control as well as mechanical systems. As I told you, this dynamic multi-leaf collimator is also used for delivering the IMRT, that is called sliding window technique. So in this technique, we have to move the MLC in small steps, and gantry can also move depending on the requirement, or gantry can be even stationary. So as it has been worked out by the computer system, it delivers the radiation as you can see here, and these intensity patterns visible are looking like this. That is, those pattern with time is looking like this. Now VMRT is another technique which has been added in radiotherapy. So VMRT, that is volumetric modulated radiotherapy, or sometimes it is called IMAT also, intensity modulated arc therapy. because these names have been coined by different vendors to suit their requirements. So the Varian also delivers this type of treatment, but the name of that technique is Rapid Arc. So what I say, if IMRT is executed by the use of rotational approach, this approach is classified as volumetric modulated arc therapy. And here, this can be executed either by tomotherapy machine or by a standard accelerators, whatever we have seen. And and for Electra, they have their own approach, which is called VMAT, and Varian, it is Rapid Arc. So treatment planning process for this IMAT or VMAT is similar to that of IMRT. So here we need not do much different work. Only thing is gantry is rotating here. Even dose rate is also managed depending on the requirement of the tumor. Helical tomotherapy, but if we are doing this approach by helical tomotherapy machine, here the planning different slightly. So we have to give a special attention. So now we move on to osteotactic radiosurgery. Osteotactic radiation is the term used to describe focal radiation techniques that deliver a prescribed dose of ionizing radiation to pre-selected and osteotactically localized lesions. The total prescribed dose are typically 10 to 25 gray. Planning targets are a small with typical volume in the range of 1 to 35 centimeter cube. It was first introduced by Lexell in 1950, and historically 200 kbp X-ray was used. Later on, gamma rays was used through a machine which is called gamma knife, and nowadays 6 MV X-rays is used from the medical electron accelerators. So these X-rays, these machines are called X-knife when it is used as a osteotactic device, and Cyberknife is also used for this purpose. Now, protons and heavy ions are also used for the delivery of SRS and Srt. Osteotactic radiation, as I told you, is a single fraction radiotherapy process for treating intracranial lesions using a combination of osteotactic apparatus and narrow multiple beams delivered through non-coplanar isocentric arcs. When this procedure is used for delivering dose through multiple fraction, it is called Srt, that is osteotactic radiotherapy. But when it is given in only one fraction, it is called osteotactic radiosurgery. The word radiosurgery is coined because it is thought to be as good as a surgical exercise over the tumor by means of radiation. SRS or Srt uses 3D imaging systems like a CT scanner to localize the lesion and deliver treatment that concentrates the dose in the target volume, sparing the normal brain. Probably you may be aware that CT does not give very good soft tissue contrast. So that's why usually we take MR as well as CT images. And these two images are fused together to identify all the points or regions, whatever we are trying to aspire and wherever we wanted to deliver the high dose. So SRS or Srt is requires accurate determination of target volume and its location with osteotactic techniques, calculation of 3D dose distributions for both target volume and outside structures, calculation of dose volume histograms for the target and specific sensitive organs, target shape confirming dose distribution and sharp fall of outside, because this is the beauty of SRS, and direct superposition of isodose distributions on images showing anatomical location of the target and the surrounding structure. So this is the requirement for executing SRS, Srt. Then we also require accurate knowledge of the total dose and fractionation scheme, accurate positional and numerical delivery of dose to the target, reasonable treatment time, low skin dose and low eye lens dose, and low or negligible scatter and leakage dose to the radiosensitive organs. So this can be achieved by a device which is called gamma knife, because gamma knife is thought to be a device which has got mechanical precision of about 100 micron. So it is one of the beautiful device which executes the SRS with high accuracy. Now the SRS can be used for variety of intracranial lesions, starting from AVM, meningioma, acoustic neuroma, glioma, brain metastasis, pituitary adenoma. So many examples are there, and we have data for treatment outcomes of these tumors. Even from our Hinduja hospital, they have published data of more than 1,500 patients, and their results are very good using gamma knife. So this is the device which delivers SRS treatments, and this is basically a high precision mechanical device. Sources are fixed here, but in other versions of this device, sources have been made movable without compromising the mechanical accuracy. So now you can see here the lesions available head of the patient needs to be treated. So some positioning and localization devices needs to be attached to the patient. And finally, when the patient is allowed to move for the treatment, you will see that this localized lesion is targeted from different angles because the gamma knife has got 201 cobalt-60 sources in its 4B and 4C model, and other less number of sources in other versions, but they are, each source is focused to a converging point, and this point is called unit center point, and the tumor is usually located at the unit center point so that all the beams can deliver the dose to this point. So this is the description of the gamma knife. It contains 201 cobalt-60 sources. Total activity of the source inside the machine is about 6,000 curie. The tertiary collimation is by this device, which is called Collimator Helmet, which is in the earlier version was a replaceable helmet, but it is very bulky and heavy. It needs manual movement and replacement, which was a cumbersome job. So now in newer versions, they have been put inside the machine, or the collimators are fully modified to take care of the aperture requirement for the clinics. So in earlier model, it were 4, 8, 14 or 18 millimeter circular collimators, and now it has been changed to some other devices. So now in case of X-ray based stereotactic system, usually we use a standard medical electron linear accelerator. The linacs of Electra, Bharin, all are capable of delivering and the treatment, but some of the linacs has been manufactured as a dedicated SRS linac as well. Both flattened and unflattened X-ray beams can be used for the SRS delivery, and circular collimator based collimator system or multi-leaf collimator based collimator systems can equally be used. A specialized medical electron accelerator like Cyberknife delivers the SRS by filter-free beam, X-ray beam, as well as by circular collimator. But in case of Cyberknife also, the collimator system has undergone multiple improvements, and now they are coming with iris or MLCs. So depending on the requirement of the user, they can go for this. Just to have a feeling, now this is the outline of the treatment of intracranial lesion. You can see this multiple gantry positions are treating the tumor or delivering the dose by means of a conical collimator. And this is another figure just to have a feeling of this type of treatment. This is another picture which shows the different circular collimators of a given machine. Then these are the complete accessories which is used for delivery of SRT system. In fact, this SRT has to be finished in one shot, so it is a very lengthy process. It requires placement of all these frames and then imaging, then treatment planning, and then dose delivery. So it requires very long duration for the patient to. But after treatment, the patient is thought to not to be even admitted. The other improvement in the SRT is the introduction of micro multi-leaf collimator. So this is this collimator gives very can shapes the fields at very high spatial resolution, and one can conform the geometry of the tumor as has been shown here. Now you can see the beam shape, so it can match with the beam shape in 3D, and the treatment can be delivered. These are other accessories of Srsrt system. So micro multi-leaf collimator enable different SRS planning and delivery technique. Intensity modulation based SRS delivery is also possible, which is called intensity modulated osteotactic radiosurgery. And these are the modern day accelerators which is used for delivery the SRS treatment to the patient. These are once again further advanced devices used for treatment of patient by Srsrt. So now if we have to see the workflow, this is you might have seen. First we have to fix the frame to the patient, then fixation of localizer, because we have to localize the tumor in through 3D coordinate system, then angiography, then CT with localizer, then after localization, the reconstruction of then we have to treatment planning, and then we have to go for dose delivery. So this is the whole workflow of the osteotactic radiosurgery treatment. So now I will have a few description about the Sbrt. This is also an upcoming technique, and I have brought it here from the second lecture because somehow it is connected with osteotactic radiosurgery. So I thought it will be better to discuss in continuation here. So Sbrt is the treatment of lesions of the body. That is, as I told you, extracranial lesions. This means tumors outside the head or of the patient. Here also we use all radiation beams, whatever we have discussed for Srsrt. This, but with here we require advanced immobilization device and relocalization, employing osteotactic and image guidance approaches, also called as extracranial osteotactic radiotherapy with image guidance. Sometimes it is called radioablation, body radiosurgery, body radiotherapy. So all these names are famous for this technique. Srsrt for extracranial tumors is usually used for thorax. This Sbrt used for thorax, abdomen, and pelvis. Use advanced immobilization system, as I told you, non-invasive body frames or masks. Accurate repositioning of patient or tumor. By the way, this technique is used in fractions. So hypofractionate treatment regimes usually to deliver dose of the order of 15 to 26 gray is used, or sometimes it can be used in a fractionated manner, and it can go up to 3 to 5 fractions to deliver total dose of about 72 gray. Osteotactic conformal radiotherapy with image guidance is also required. Geometric accuracy relates to interfraction and intrafraction setup error and organ motion. So here sometimes even we take use of 4D computed tomography scans, but that process is complex. For moving targets, large target motions due to the inherent movement of patient physiologic or respiratory motion needs to be controlled. The magnitude of target motion is variable and unpredictable. So some devices are available which are used for doing this. It necessitates higher level of precision in target localization, and to attain higher degree of accuracy and precision in target localization, positioning and delivery, osteotactic approach is the ideal approach. So demerits of SRS and merits of Sbrt: the conventional radiotherapy may fail to achieve a cure in localized tumors due to radioresistive cells, and because here we require a escalated dose delivery. Dose to nearby critical normal structures may limit the escalated dose to the tumor. So the diagnostic modality may have failed to yield the true extent of the tumor, and there may be inaccuracies in dose planning and delivery, and lack of treatment verification system. So in all these situations, Sbrt is thought to be a superior option over the SRS technique. For early and advanced stage lung cancer, a standard dosage of 60 to 70 gray is delivered. 30 to 69 local failure rate for early stage disease has also been observed. Histopathological tumor control in less than 20% cases. Local failure is associated with distant metastasis rate and death. conventional RT fails to achieve cure for early stage lung cancer. So RTOG retrospective study of NSCLC patients demonstrate that every 10 gray increase in BD results in an 18% decrease in the risk of the deaths. So these are the early days observations of executing this method. So here the limited surgical approaches are a standard of care. So we can use this type of technique. So now considering the time, I will move forward and not discuss much because this slide I will share later on with the Professor Tondon. This Sbrt can treat thoracic tumors like lung, mediastinum, and breast, retroperitoneal space and liver, abdominal cancers. Excuse me.
Can we break and discuss? There are a lot of questions, and then we.
Just a minute, madam. So I'm just finishing this.
Okay. Sorry.
Okay. So now I will skip all these slides. Then finally go to brachytherapy. Within 2-3 minutes, I will finish this because brachytherapy, this is a historical technique and it is basically clinical use of a small encapsulated sources, but thought to be inherently conformal approach for treatment. And the beauty of this treatment technique is a rapid dose fall of and it is capable of delivering selectively very high dose to the tumor. The sources commonly used nowadays is cobalt-60 and iridium-192 by high dose rate brachytherapy system. The seeds of iodine-125 and palladium-103 is also used. The brachytherapy is classified on different approaches, as I told you, on the method of application of these sources. It is called interstitial, intracavitary surface, mold, intraluminal, ocular, vascular. On the basis of time of treatment, it is temporary implant or permanent implant. And on the basis of the rate of dose delivery, it is called low dose rate treatment, medium dose rate treatment, high dose rate treatment, and pulse dose rate treatment. Pulse dose rate treatment is also the example of low dose rate treatment only, but high dose rate treatment has almost replaced all other approaches which was based on the basis of dose rates. So here if you can see that these are the different, this is just information in nutshell in a compact manner. So we have varieties of tumors and sources which can be treated, and we have even beta emitters which are used for brachytherapy application. And historically, BRC was also supplying cesium-137 source and iridium-192 buyers for this intracavitary as well as interstitial application. Nowadays, remote afterloading system containing single source is used for all such treatments. The intracavitary brachytherapy, one of the most important approach for treating the brachytherapy application. And even this integrated brachytherapy suite is also available nowadays, so that the patient can stay on the same couch. Imaging, planning, and treatment can be delivered without moving the patient from here to there. Even these ocular tumors are treated by the sources made by vendors as well as BRC. So there are varieties of ocular tumors which is treated by the ocular ruthenium-106 plaques made by BRC as well as BEBIC. So majority of, now this is my concluding slide, majority of nuclear radiation, nuclear particles are used in medicine. A number of high-tech equipment are available. However, there is always a scope of further development of equipment, devices, and techniques. Safe use of these radiations and particles are equally important. Radiotherapy treatments are now fully technology oriented due to recent advances in technology of radiation sources and beam delivery devices and treatment techniques. So thank you very much for listening me for such a long duration. Thank you very much, madam. You can proceed for the questions.
Very good afternoon to all of you. Good morning to all of you. You all will agree with me that such a difficult topic he has taken in a very nice way, starting from very classical to having a very advanced person where that they are walking through voxel by voxel to use artificial intelligence by having the hyphenated technology of imaging and to do the treatment. So you can see that how he has really taken us from very classical to very advanced tools and technique, having utilization of AI also. So you can see that how they mark the area and how they do the treatment using different type of radiation sources and doses. So with this, really, thank you very much, Professor Sharma, for your kind lecture, which is very informative, and we learn a lot out of it. And certainly, this is very beneficial for whosoever is practicing in this area for treatment of the different type of cancer. Thank you very much. Let's give a big hand.
Thank you, sir. Thank you.
Vibha, you can unmute yourself to ask the question.
Oh, sorry. Yeah, so I was muted and asking. So can I ask Antara to ask yourself? Antara, please ask yourself.
Good morning, sir. My question is, when we use this 3D confocal radiation therapy, I mean, to treat which tumors we use this technique?
3D conformal radiotherapy, as I told madam, almost it is outdated. Nobody likes to use this when we have the option of IMRT. So before advent of IMRT, 3D CRT was the choice of treatment, and mainly for head and neck tumors.
So is there any advantage of using 3D CRT over the new techniques, or is it like outdated already?
Yeah, and actually it has the advantage of using 3D CRT when we were accustomed of using 2D treatment techniques like a single beam treatment, parallel opposed beam treatment, 3-field technique, 4-field box techniques. So those days only jaw collimators were used for defining the field size, and a large amount of the large volume of the normal tissues was receiving very high dosage. In those days, 3D CRT was thought to be a very advanced approach, but now when further advancement in techniques has been introduced, so this 3D CRT is not thought to be advanced in today's time.
And sir, I have one more question, that why we call IMRT more accurate radiation therapy technique as compared to 3D CRT? What are the features in
here I
IMRT?
will tell you. Now, if you analyze the tumor from different angles and different directions, their thickness and extent is not same in anywhere. So we want to deliver a fixed amount of energy inside the tumor. So if I am delivering the same amount of intensity of photons, whether the tumor extent is larger or smaller, definitely it was not going to help us. So we are now delivering a different varying fluence pattern. Fluence pattern is the number of photons per unit area. So if we are delivering varying fluence pattern to get the highly informed dose, and moreover, this IMRT is delivered by means of the sophisticated beam shaping devices. It is thought to be conforming to the geometry of the tumor in 3D as well. So it has got the very good uniform dose distribution inside the tumor, plus dose outside the normal tissue region is also somewhat lesser than what we had in case of 3D CRT. So that's why IMRT is thought to be a better option.
Okay, thank you, sir. It was an informative talk. Thank you.
Yes, sir.
Hello.
Thank you, Dr. Sharma, for that wonderful exposure of the participants to radiotherapy at large. My question is, with excellent treatment planning system, for the IGRT, image guided, with several, which can be done with different images, that's your choice. One can think of doing a very good dose painting to different regions of the tumor based on what is the image that you have. For example, if I do a hypoxic imaging, then I can plan so that I put more dose to the hypoxic region as compared to the oxycontin. and also spare the OAR, the organs at risk, especially in critical organs, very well. That being possible, how you think this compares and contrasts with Sbrt? Where,
Yes, sir. Thank you very much, sir. In fact, dose painting is one of the choice available to radiotherapy also, and even people are practicing. But, sir, it depends on the clinical case. Now, say, for example, if you are looking for prostate tumor, then probably it may not be possible to go for Sbrt because, but if we go for dose painting or IMRT, that could be relatively better possibility. So depending on the case, one can opt either it is the case of dose painting or it is the case of Sbrt or any other approaches.
are you covering in your next lecture, besides flash, grid, and a little more of Sbrt here, are you also covering particle
therapy, grid therapy, and flash therapy?
Oh, very good. So that includes both proton and carbon?
Yes, sir. Yes.
Oh, okay. So then I'll hold back my nerve for a while more.
Yes.
We have a lot of questions here. So there is another question that from Sangeeta Chaudhary. She's a clinician from say Gangaram. So she's asking that is age or physiological hormone levels, for example, estrogen, a risk factor for radiotherapy?
Here, madam, I may not be able to answer this question.
And she asking if few patients show long-term effect, is it lead to cognitive dysfunction, especially for brain radiotherapy? Does a particular type of radiotherapy overcome such side effects?
Yes. Some studies has indicated that a particular type of radiotherapy definitely minimizes the side effect, but it is the judicious choice of the clinician what technique will be. But however, it should be a collective decision, because from technical point of view, a medical physicist can tell what will be the conformity and what will be the dose to the nearby region. So because side effect or secondary malignancies are related to the amount of doses delivered. So definitely the consideration should be given to the technique and technological availability for minimizing the side effects. But as you know that I'm basically not a clinical person, so I may not be able to answer the highly clinical questions.
Okay.
May I add here?
Yeah, sure.
The cognitive, if not impairment, cognitive attenuation or cognitive compromisation following radiotherapy is probably not a very major issue in the treatment of adult patients. Of course, it is true, it's mainly for the intracranial lesions. However, it's more of an issue in treating the young children for more than one reason, that there is more time for the manifestation of the damage that would have occurred due to exposure. Number one. Number two, as Dr. Sharma indicated, I'm also not a clinician though, it depends on the precise anatomical location of the lesion which you are treating and the nature of the tumor, and therefore how much you are obliged to include in your treatment volume with all the very focused treatment, with the conformal treatment that is currently available. And in order not to leave out any possible tumor, which are already indicated by the imaging techniques with allowed boundary, how much of normal tissue you include in your treatment volume would decide the consequences. And more so, as I said, in younger individuals, the children. It's probably relatively, I'm not saying it's not an issue, it's relatively probably less issue in treating adult patients.
Yeah. So, sir, another question is that what is the difference between the radiotherapy and stereotactic radiotherapy?
Radiotherapy, madam, in general, now radiotherapy and osteotactic radiosurgery, SRS and SRT. In case of SRS, it is a kind of single fraction treatment, means the whole prescribed dose may be of the order of 10 to 25 grays delivered in one sitting. But in case of SRT, the total dose is remains same, but it is delivered in fractionated manner. Say, for example, maybe same 25 gray can be delivered in 3 fractions or 5 fractions. So this is the just a change in nomenclature. So fractionated treatments are called radiotherapy, and single fraction treatments are called radiosurgery.
There is another question that how successful is stereotactic radiosurgery, and in which disease stereotactic radiosurgeries are done?
Yeah, actually, madam, osteotactic radiosurgery, I told you, it is mainly for intracranial tumors. And particularly, I was somehow connected with Hinduja Hospital. They have treated large number of arteriovenous malformations, and they have got a very good control over this disease. And they have been even published this data. There is a publication from Dr. B.K. Misra. So it is a I can say unique approach for treating the intracranial lesion by SRS. So usually gamma knife based SRS or this X knife based SRS, both are thought to be equally effective.
So is that Komal, you want to ask something?
Sir, actually, I have a confusion. In the starting, you have mentioned about the flattened beam and the unflattened beam. So my confusion is that is these beams are the protective beam or they are the radiations?
No, they are the radiation beam. Flattened means now I am delivering a photon fluence or photon particles at a given plane. So there could be two possibilities, because in the older days we were requiring photon of uniform intensity pattern at the plane of observation. So that is called flattened photon beam. But nowadays, with the advent of advanced techniques like IMRT, VMAT, even intensity modulated stereotactic treatments, for uniform intensity pattern is not a requirement. So now we have started using unflattened photon beam. And I will tell you what is the basic advantage. In case of flattened photon beam, we were losing large amount of photons because we were putting a shield inside the head of the accelerator. But here we are not putting any shield, and we are allowing all the photons, whatever has been generated, to come out and go wherever you want them to go.
Sir, about the symmetry also you have mentioned in your presentation. So I didn't get about the symmetry also.
Symmetry is a quality assurance process. So now you can see symmetry means if there is a big block and there is a center line. So I want that left hand side body part should be looking equivalent to right hand side body part. So this is the concept we have. So if photon beam profile of left hand side from the central axis is looking as equal as right hand side, it is called symmetrical arrangement.
So, sir, it's totally depend on the tumor condition of the patient that if we are giving the flattened or the unflattened beam of radiations.
Yes, yes, it depends on the tumor, but now we have both the options. I will tell you, for example, we are approaching the treatment intent is either curative or palliative. And in our country, you know that 70 to 80% cases are advanced cases. So usually they are tried for palliative approach only. Palliative approach means clinician wanted to remove the pain and distress of the patient so that she or he can live a comfortable life, whatever is available for the person. But in curative approach, we apply our all the knowledge and we use our all the available technology to make the person free from the disease. So depending on the approach, we select the beam, we select the technique, we select the equipment.
Sir, if you want to give the radiation therapy, so what should be our 3D planning?
Like 3D planning, we have a computerized planning system, and we take help of that planning system. And there, As a medical physicist, we know what is the calculation algorithm, what is its merit, what is its demerit.
So, sir, is there any benefit to that particles over the photon radiotherapy?
Yes, there are some benefit. I will talk about the advantage of proton and even heavy ions like helium and carbon ions in the next lecture.
Okay, then last question I'm just mentioning, then we'll move to, because there are other questions also, but we will have it during after next session. But one more question, that they're asking that do they affect the normal tissues also over tumor tissues?
Can you repeat the question, madam, please?
How these machines affect, how much means it affect the normal tissues over the tumor tissues?
Yes, actually, now you know that the machine does not identify whether it is normal cell or cancerous cell. It is we are the people who are using this approach, so we have to identify which cell is normal cell and which cell is this cancerous cell. So we have to accordingly target the cancerous cell and try to minimize the exposure or dose to the normal cells.
Okay, so yeah, here it is written, but although you have answered that, do we need to select beam geometry and energy? How do we decide upon the beam energy?
Yes, it depends on the tumor. Say, for example, if I am dealing with a tumor of head and neck region, 6 MV X-ray will be the ideal choice. But if I am talking about the thoracic region, abdominal region, where thickness is more and tumor is deep-seated tumor, so definitely one has to switch over to either 10 MV X-ray or 15 MV X-ray.
Okay, so fine, so there are more questions, sir, but I think you can have it the next session, and then we can ask. And Dr. Mishra, do you have any comments? We should go ahead.
I think go ahead. So he has taken all the question, and also that whatever question is left out, he will be taking in the next session after giving the talk. And of course, I hope that he will be talking about little bit about the internal PRRT that we talk about, peptide receptor radiotherapy, either radioimmunotherapy, if possible. So then certainly.
Yes, sir. Yeah, thank you, sir. Immunotherapy I have left, sir. Because I thought you are there, so you will speak.
Okay, so we will call him on 31st and tell him about the immunotherapy.
Yes,
because
sir.
a lot of questions were there on immunotherapy. Dr. Chaudhary asked for the very first day. And 2 more clinicians asked about the immunotherapy.
And Mishra Saab will be the better expert than me to talk on that. So please give him some time or invite him on that.
Yeah, so I'll invite him in valedictory. Okay, sir. So you can
Thank you
start.
very much, sir, for such a elucidative and then very informative. Even it is a learning for us that many things I was not knowing. So thank you very much for your kind lecture, sir.
नहीं है यार, मैं उधर उनको बोले वहीं पर रुको, हमारा को फॉर्मल समझ जाऊंगा.
So Vibha, I'm signing off.
Okay, thank you.
Madam, I will start the next lecture.
Sure.
Okay, thank
If
you.
you want a bio break or something, you can take.
No. Actually, I have another selection committee meeting, so somehow, so just I want to finish and go, madam, at the earliest.
Okay.
So, thank you, madam.
There are so students are asking questions from you. Okay.
Yes, madam. Can you see my slide now?
Sure.
Yes, sir.
Yeah. Okay, sir. So now this topic given by Professor Vibha Tandon, madam, upcoming approaches in radiotherapy, but somehow I have mixed here and there. So I will talk here about the particle therapy, then grid therapy and flash therapy. So this is the main type. So I will start with particle therapy. Probably just for historical information, Robert Wilson was the first to propose the use of protons for therapy in 1946, and first patient was treated in 1954 in USA.
Yes.
Since then, proton beam therapy has been applied for treatment of various disease sites, including paranasal sinus tumors, chondrosarcoma, meningioma, prostate and lung tumors. Proton radiosurgery has also been used to treat large arteriovenous malformation, that is AVM, which we have discussed earlier, as well as other intracranial lesions. Although the number of patients being treated by proton beam therapy is steadily increasing, it is still only a small fraction of total radiotherapy patients treated by proton due to high installation, operating and treatment cost. Proton and heavy ion usually helium and carbon ion beams are increasingly being used for treatment of varieties of cancer cases. In comparison to photon and electron beams, proton and heavy ion beams present a superior spatial dose distribution, which we will see later, near zero dose distal to the target volume, and the resultant capability of confirming the planned dose more closely to the specified target volume. Among the proton and heavy ions, carbon seems to be having additional advantage because of its higher biological values. So in contrast to protons, and heavy ions and particularly carbon ions provide a promising treatment options for tumor with limited radiosensitivity and critical location. So these are the basic introductory remarks over the proton beam therapy. Proton and heavy ion therapy equipment contains. So now I will go first about the equipment and then about the delivery approaches as we have discussed in other methods. So proton and heavy ion therapy equipment contains three main components, namely a particle accelerator, generally either cyclotron or synchrocyclotron, and a beam transport system and a treatment delivery system. Particle energy is employed in radiation therapy to deliver dose to superficial, intermediate and deep-seated tumors are ranging in case of proton between 80 to 250 MeV. In case of helium ions, it is 30 to 250 MeV per nucleon, and in case of carbon ions, it is 200 to 500 MeV per nucleon. Now you can see a comparative dose distribution of different radiation beams, whatever we use. For example, we have cobalt-60 gamma rays, which is used historically for beam therapy, and you can see it is a Dmax is located close to the surface, and now exponential dose fall off. Then we have 10 MV X-ray photons. Then we have electron beams of energy 20 MeV. Then we have neutrons, fast neutrons, because boron neutron capture therapy is also used. And finally, we have proton beam. So in case of proton, you can see there it is called a pristine beam, that is single beam profile for the proton. And now, because we have to deal with the larger dimension of the tumor, so we have to create a larger extent of the proton beam, that is called a spread out Bragg peak. So this I will tell you how it is created. So finally, this, if we compare the surface dose, that is thought to be a parameter to qualify different radiations. So we see here that in case of proton beam, surface dose is coming closer to 58%, but in case of other beams, it is going much higher than that. So proton beams are thought to be a relatively better option, at least when we have a graphical overview of this plot. Now, very specifically, if we compare 15 MV X-ray and a spread out Bragg peak of 200 MeV proton beam, you can see that this is the exponential depth dose curve of X-rays, and this is the SOBP curve of the proton beam. So now you can see here, this shaded region is called overlying 2C region, which is getting heavily irradiated in case of X-rays, and this underlying region is also getting heavily radiated. But in case of proton, the underlying dose to underlying tissue is almost zero. That is, we say in other terms, exit dose from the protons are almost negligibly small. However, in case of overlying tissue, some dose are delivered, but it is much lesser than the dose from the photon beam. So this is the main advantage of using proton beam, and this is the basis of using proton beam in radiotherapy. So now some further description about this is called Pristine Bragg peak, and this was discovered by Professor W.H. Bragg, for which he got Nobel Prize in the year 1915. The increase in energy deposition with increasing depth, leading to a maximum near the end of the range, which is called. So you can see that when we go deeper and deeper, finally we get this peak. So this is called Bragg peak. So mechanism of this Bragg peak is when protons moving through the tissue slow down, losing energy in atomic or nuclear electrons. So this is the reason for getting this type of pattern. Maximum interaction with electrons occurs at the end of the range, causing maximum energy release within the target area. So this is the explanation for getting such a curve from the proton. Now, monoenergetic proton beams exhibit a relatively flat low dose entrance region, as we have seen earlier, but they are not useful because we cannot use such a narrow beam and leave other part of the tumor untreated. So usually, as I told you, we go for creating SOBP, and SOBP is normally defined by the width of the 95% dose levels. By varying the number of peaks, the extent of the uniform dose region can be varied. The dose proximal to uniform dose region is relatively lower, which results in a lower integral non-target dose, that is dose to normal tissues or critical organs nearby. This characteristic of proton beam allows for a larger flexibility in selection of beams and provides larger flexibility in distributing the non-target dose. Interaction of protons with the matter is important for understanding their energy loss. So they usually suffer ionization and atomic excitation by electrons, and this can be expressed by a stopping power relation. So a stopping power in this case is inversely proportional to the velocity square of the proton. So this means larger is the energy, lesser will be the stopping power. This is the meaning of this expression. In addition, the proton also suffer multiple Coulomb scattering with the nucleus and inelastic nuclear reactions. So these are the three different interactions proton undergoes when they pass through the medium. So now here you can see that this is the blue line is the stopping power has been plotted against energy of the proton. So here you can see that slow energy loss for most part of proton, and that's why you can see this type of the nature of the range of the proton. This is once again, now we have seen that there is a straggling in the range of proton, and this straggling is because attributed to the multiple Coulomb straggling. So rather we should have got a very sharp line here. Rather than that, we are getting somewhat a spilling, and this spilling is because of the multiple Coulomb scattering. Then diameter of the aperture, which defines or collimates the beam, also plays a role. When you see, when we are dealing with 5 mm diameter aperture collimator, 10 mm diameter aperture, 20 mm, 80 mm, then accordingly you see the sharpness of the beam increases. So now here the spreading horns are also visible when we see the collimator system. So what we feel from here, if we are dealing with the collimation of the beam, then we have to take care of this part while designing the accelerator. So now about 20% of primary protons lost due to nuclear interactions. Particles produced because of the nuclear interaction include secondary protons, neutrons, tritons, helium, and alpha particles. So these are also a possibility. And this is another this range straggling as well as the divergence of the protons while traveling deeper into the medium is indicated. So we have to take care while, if I say, for example, if we are delivering a spot of the proton at a given location, so we have to consider what is the extent of the material over the location. Accordingly, one has to calculate the divergence and decide about the spot size. As I told earlier, protons are accelerated by either cyclotron, and different vendors are having this IBA. They are supplying many accelerators. Sumitomo and Varian is also one of the player in the market. Synchrotron, some of the vendors are there, but in our country we have IBA made accelerator, and they are basically a cyclotron based accelerator. There is some comparison and differences among the cyclotron and synchrotron based accelerator. In case of cyclotron, it consists of dipole magnets to produce uniform magnetic field, but in case of synchrotron, circular accelerating ring which accelerates the electrons. In case of cyclotron, particles injected into it move in a semicircular path and acquire energy at the caps. However, in case of the synchrotron, electromagnetic resonant cavities around the ring accelerate the particles which moves in the same radius. In isochronous or synchrocyclotron and semi-conducting cyclotron options are also available, but in case of synchrotron, the magnetic field strength is increased with increase in particle energy, and magnetic and electric fields are in synchronization. So this is just a cutaway view of the schematic view of the cyclotron which is used for accelerating the proton. And this is just a view of the proton housing. So this is the cyclotron. You can see the shielding thickness for the cyclotron of energy about 230 MeV works out to be about 4 meter concrete. And these are the transport lines, and this is the gantry for treatment. So one cyclotron can have few gantries of treatment. So you can, this is one gantry, this could be another gantry. And now for your information, as you may be aware, whenever we treat patients by proton, the patient becomes radioactive, and we have to leave the patient inside the treatment room for about 20 to 30 minutes. So if a facility is having only one gantry, it will be a severe underutilization of the facility. So it is better to go for at least 2 gantry or 3 gantry options, so that the cyclotron could optimally be utilized, or its full potential can be used for treating a number of cancer patients. This is just a photograph of the cyclotron which we have at our Apollo Chennai Center. So this is the, you can see the dimension of the cyclotron. It is a very giant cyclotron. And here, the through electrolysis, protons are taken from water and injected into the cyclotron, which accelerates proton to nearly the speed of light. The protons are guided through the beam line to go to a right direction. The protons travel through the beam line guided by electromagnets into treatment rooms. And this is the process of creation of protons. So hydrogen gas is heated here, and then it becomes plasma. Then this plasma is free from electron, and now this proton is available, which is accelerated. This is the ion source of the cyclotron. So this, you can see, it is located in the center, and this ion source is injecting proton as per the requirement of the operation of the cyclotron. Now the transport of the cyclotron is governed by 4 components. One is called dipole, which bends and guides the proton beam. Another is quadrupoles, which focus the proton beam. Third is a steering coil, which fine tunes the direction of the beam. And finally, beam profile monitors with beam stops provide inputs to the magnets. So these are the different components. It is basically a very big facility. And now you can see from here, this is the gantry, one of the gantry of the proton, where the patient is lying and the operator is standing inside the gantry. And this is called the nozzle. See, this nozzle is delivering the treatment to the patient from as per the requirement, clinical requirement, and some imaging devices are also available. So imaging can be done either prior to the treatment or post-treatment, depending on the clinical requirement. So proton therapy is delivered while patient is located on this table. This nozzle is nothing but the gantry of the electron beam accelerator. But here this nozzle contains a variety of the components for doing many things: range modulation, profiler, this reference monitor chamber, laser marker, block collimator, many things, whatever be required to use this accelerator for clinical application. So nozzle of proton beam accelerator is, as I told you, nothing but a treatment head, and we have to play with all the components as per the case. It contains various components for beam shaping and beam monitoring. As far as treatment delivery is concerned, we have different approaches. It is called double scattering beam technique, single scattering beam technique, inform scanning or bobbling, pencil beam spot scanning. This is the approach majority of the hospitals are using. Then selections performed in treatment nozzle, either dedicated nozzle or inversion nozzle. So, but these are there are some problem with nozzles also. So you have to consider what type of cases we are going to treat, and what is the use of this accelerator. Accordingly, one has to select. So mainly nowadays, the pencil beam spot scanning is thought to be a economical choice within the given expenditure for installing this facility, and this is thought to be a easily implementable as well. So it is a very common approach. But even multi-leaf collimator based approach is also used, and for specifically for intensity modulated proton radiotherapy and radiosurgery. Now, as I told you, this is a pristine big Bragg peak, but we usually require a spread out Bragg peak. For this purpose, we have many options. One of the option is to use the range shifter. That is basically sometimes called ridge filter also. It is basically this graded carbon filter, which allows the proton beam to move, and they reduce the range of the proton as per the requirement of the spread out Bragg peak. So if you see, this is the ridge filter, it rotates like this, and it then gives proton beams of different intensity. And finally, if we calculate the resultant, then it gives the spread out Bragg peak. So this spread out Bragg peak is calculated as per the need of the each patient. So accordingly, one has to do this. This is another approach of proton beam therapy is to use this cutouts. This is called aperture or cutouts. So it is fixed in the snout, and this aperture is created as per the requirement of the patient. But the main drawback with this aperture is it requires to be stored for a longer duration, because it gets this radioactivity is induced in this, and it becomes a radioactive material. So in the early days, this type of beam delivery choices were used, and people have stored it for a long time. And whenever such facility was installed, there has to be a provision for storing all these apertures. But nowadays, with a spot scanning, hardly anybody goes for this type of aperture creation and beam delivery. Beam penumbra of protons at larger depth is comparable with that of high energy photon beams. So people thought that why not to move on to further higher particle. So helium ion was thought to possess sharper beam penumbra at all depths. So a more pronounced Bragg peak and a steeper dose follow beyond the Bragg peak. So this was the consideration for introducing helium ions in the practice of radiotherapy. And another requirements consideration was the higher atomic number of helium ions compared to protons can result in a breakup of primary beam particles, resulting in a fragmentation tail. Due to the lower atomic number of helium compared to carbon, but because carbon was thought to be choice later on, only a small percentage of the total dose is deposited beyond the Bragg peak. So use of helium ions results in further reduction in dose to the surrounding normal tissues in comparison to proton, but it was not better in comparison to carbon ions. So though it was introduced for radiotherapy, but it has not sustained, and more or less it has been discontinued from the practice. Carbon ion beam is nowadays thought to be a better choice among proton and heavy ions due to higher LET value and better dose localization. Carbon ions are heavier than protons and have beam, and it has been shown to have effective in the treatment of many radio-resistant tumors. It has been shown that the differential radiosensitivity between poorly oxygenated, that is radio-resistant, and well oxygenated, that is radiosensitive cells, is reduced with high-rate radiation. Tumor sites that are prone to hypoxia gets benefited most from the high-rate radiation. And so examples of such cases are a squamous cell head and neck cancer and non-small cell lung cancer. These are the two good examples which qualified for such treatments. The compact beam carbon facility has been proposed, and this facility is working on one of the institute in Japan. The energy of this carbon beam facility is 380 MeV per nucleon, and you can see there are many components. It is just a schematic diagram. It is beam monitor, wobbler magnet, then a scatterer, ridge filter for range modulation, then range shifter, multi-leaf collimator, then range compensator, and finally this is the ISO center definer, where the dose will be delivered by this. And you can see from here, from wobbler magnet to the ISO center, the distance is more than 7 meters. So it is such a huge facility used for cancer therapy. Here, these accelerated carbon ions are laterally spread out by wobbler magnets. Then ridge filter modulates the beam energy to form a spread out Bragg peak of carbon. Then multi-leaf collimator reduces extra dose to normal tissue around the tumor by giving a conformal shaping. And the range shifter and range compensators are used to adjust distal fall of the SOBP to the target volume. So this is the whole process of dose delivery by carbon ion accelerator. If we need to compare how it compares with X-rays, so now you can see here, X-ray treatment has been delivered by X-ray like this. So now you can see that this whole region, wherever the beam has gone, it has in this region the dose, this color bars is showing that this red part is getting higher dose, and if intensity of red is decreasing, it is lower dose. So you can see that this region of the patient body has got very high dose up to here. But in case of carbon, even surface dose is less, as well as after the tumor center dose is very, very small, and it has given a localized very high dose to the tumor. So if we plot the curve just to compare this, you can see this is the target in case of X-ray, and this is the target in case of carbon ion. Now you can see it is looking like this. So definitely these tissues are getting very high dose radiation. But in case of carbon, only this portion of the tissue, including this part, is getting high irradiation. So we can see that a large volume of the normal tissue has been spared, which will minimize the normal tissue toxicity from this consideration. So if we have to compare proton beam and carbon ion therapy, in case of proton beam, the cost is relatively less, but in case of carbon ion, it is 2 to 3 times higher than proton beam. It is able to deliver the treatment via gantry, allowing multiple beam angles. But in case of carbon, still it is a fixed beam accelerator. It is a more narrow range of radiobiological effectiveness. In case of proton, it is reported that it has got the RB value of up to 1.1. That is 10% increase in RB value in comparison to photons. But in case of carbon ion, we say that it is as a thumb rule, it is having RB values up to 3.4 to 4. This means if I have to deliver the same photon equivalent dose and say, for example, a tumor requires 100 gray for treatment from carbon. So probably about 30-35 gray will be sufficient to produce the same clinical effect, whatever we are getting from the photon beam. RB is similar to photon radiation in case of proton, but here it is higher. So this is one of the advantage of using the carbon ion therapy. So now I think this was the brief I have prepared. Now I will move on to the grid therapy, which is technically called as a spatially fractionated radiotherapy. So here Sbrt is basically used for very large tumors, and basically historically it is used by the name grid therapy. And almost 100 years ago, this approach was utilized for treating certain kind of tumors and mainly this secondary malignancies. It is characterized by highly non-uniform dose distribution. It is used to treat the total tumor with a non-uniform dose, keeping normal tissue dosage within the tolerance. It is used for treatment of bulky malignant tumors with a radiation dose in the range of 10 to 25 gray per fraction. And now in the early days, 200 kV X-rays were used, but nowadays mega voltage X-rays produced by accelerators are used. Treatment intent here is now both curative and palliative. Earlier it was palliative alone. In almost all types of cancers are treated nowadays by this mode of therapy. Large dose gradients can be achieved using a sieve-like filter, which is called the grid filter, creating a grid pattern. So now you can see this is the historical grid which is used for with low kV X-ray, but nowadays in some situation used with high energy X-ray as well. So delivery of high dose to the tumor through a specially designed block which is called grid. That's why the name of the treatment was grid therapy. The grid blocks half of the treatment field and delivers the radiation through pencil-shaped beam. And it has been reported in literature that the diameter of these apertures are optimum dia is about 1.5 to 1.7 centimeter through Monte Carlo simulation. So earlier it was not so optimized, but with theoretical approaches now this has been optimized. As this approach spare much of the skin while allowing a higher dose of radiation to be delivered to the tumor. And this is the dose distribution. You can see here, especially fractionated. So now you can see here dose is delivered, but this part is not receiving anything. Then it is delivered here, but this part. So this type of pattern is created, which is called a grid pattern. That's why the name of the technique. These are the trials conducted or practiced at different centers world over by different groups of the people. And now you can see that this is dose is of the order of 10 to 25 gray by different groups. Even in some cases, it has gone up to 66 gray also. And they have reported a good outcome from all these clinical studies. Now, the grid therapy, how it can be implemented, what are the ways? So earlier in the early days, 2-day grid therapy was utilized, whatever picture I have shown you of that grid blocks. But nowadays, with the advent of advanced techniques, lattice radiotherapy is used in clinics, and it is designed to modernize a 2D grid therapy and to improve the conformality with the tumor. So 3D lattice radiotherapy creates a small high dose spheres. These spheres are called vertices within the tumor and keeps lower dose regions close to tumor periphery to spare healthy tissues or critical structures. These vertices are spaced strategically depending on tumor size, shape, and location in normal tissue. So 3D lattice therapy has been used clinically and has resulted in improved local control with no increased toxicity. So this is the advantage, and now this is thought to be an alternative over the historical 2D therapy. Sorry for a minute, please. So sorry for interruption. So this is just a dose distribution. and even DBH for the grid therapy. So now you can see this is this pattern is giving the name here. So it is these are the patterns in axial, coronal, and sagittal planes, and it is taken from the planning system used for implementing the grid therapy. Now this is the comparison of lattice configuration and the 2D grid configuration. So you can see here that somewhat it gives better dose distribution than this configuration. So lattice therapy is thought to be a relatively better approach of delivery the grid therapy or Sbrt. Now, if we see what was available in the past, what is today, and what will happen in what will take place in tomorrow as far as the implementation of grid therapy is concerned. So in the past, we were using ortho voltage therapy with grid block and all X-ray machines. Then even cobalt 60 was also used. Fractionated approaches were used as well as single dose treatments were used. But nowadays we are using mega voltage therapy with 2D grid or lattice approach. Even tomotherapy, particle accelerators, all are used. So here nowadays we have available with us 3D CT based planning, and we can apply this approach either by the approach of 3D CRT, IMRT, VMAT, Sbrt. In future, it is thought that many beam will be made available, and flash radiotherapy will also be available in clinics, and it will be radiomics guided mini beam or flash beam therapy to achieve the grid radiotherapy. The grid radiotherapy is used for many cancers, including colorectal cancer, sarcomas, melanoma, larynx, tonsils, adenocarcinoma, maxillary sinus, base of tongue, nasopharynx. So these are the cases. So this was a brief overview of the grid therapy. Now, finally, I have few slides for flash radiotherapy. So flash radiotherapy, basically it was reported in the year 2014. So it is a very recent development. And the term was coined by two group of researchers to demonstrate that it possesses normal tissue sparing capability while maintaining tumor cytotoxicity. So the process includes delivery of a radiation dose at a ultra high dose rate of the order of 40 gray per second, which is several orders of magnitude higher than dose rate of current clinical radiotherapy, where we generally give treatment at the rate of 5 gray per minute. So this flash irradiation induces flash effect, which reduces the normal tissue toxicities commonly associated with conventional radiotherapy while maintaining local tumor control, and it has the potential to revolutionize the future of cancer treatment. But as on today, this therapy has been practiced or tested with electron beam only. However, proton-based approaches has also are also being tried. So we have to see larger spectrum of radiation beams which can be used for flash therapy in coming years. Then it will become a good approach which can be used routinely in radiotherapy. The prominent, as far as radiobiology is concerned for flash radiotherapy, the prominent role for oxygen tension and reactive oxygen species production is the most current and valid hypothesis, and this is called oxygen depletion hypothesis. Most of the studies into flash radiotherapy have used electron beams, as I told you, which has very low tissue penetration. So probably it can we need to use other beams which can penetrate deeper to deal with deep sitting tumors. A promising alternative, and here proton can also be used. So now this is just a schematic diagram showing the flash radiotherapy. This is the dose rate and this is the pulse duration. So you can have a feeling what is the meaning. So in flash radiotherapy, understanding is very simple. If dose rate, the rate of dose delivery is very, very high, then it will be called flash. Otherwise, it is conventional or advanced radiotherapy treatments. So the current hypothesis to explain the flash radiotherapy is the oxygen depletion hypothesis, which suggests that the ultra-high dose rate modulates the immediate radiochemical events that occur in the irradiated tissue. In this short exposure time, local oxygen is depleted faster than reoxygenation can occur in normal tissues, leading to a transient state of radiation-induced hypoxia, and therefore radio resistance and protection of the normal tissues due to flash irradiation. Flash may offer an improved immune response due to the fast exposure time, leading to less irradiation of circulating immune cells, although this effect may be reduced for fractionated flash radiotherapy. Even though I can tell you that it is not, nobody can tell with certainty what is the mechanism involved with this, but these are the theories proposed, and it is for timing adopted by the research groups. So this is just a schematic interpretation of the same oxygen depletion hypothesis. You can see normal tissue and tumor. Now, normal tissues are thought to be containing large amount of oxygen. That's why they are thought to be radiosensitive, but the tumors are definitely having hypoxic conditions. So, but flash irradiation induces temporary hypoxia inside the normal tissue, and it helps in protecting them from the radiation-induced damage. So this is the hypothesis available in the literature as on today. So with this, now I conclude this presentation, and thank once again to all of you and to the organizing team as well as to the chairpersons for giving me this opportunity and interacting with all of you. Thank you very much.
So wonderful job, and I can see Professor Dwarkanath for there, so I have no worry. He will ask the question. Yeah, then I'll ask other questions. Yes, sir. Please go ahead.
Oh, I don't have any specific question. Now, I wanted to congratulate Professor Sharma for doing a wonderful job. I was very keen when Dr. Biba was trying to put this together, that besides discussing whatever is widely seen and used, we should have in this course what is coming, what is projected, a lot of things. So from that point of view, I'm so happy that you gave this talk, sir, and we're very, very thankful to you for this excellent exposure. I do have a question though.
Yes.
Now, in the mini beam irradiation, particularly with the proton beam, what do you think should be the optimal mini beam size? Because the whole idea in the mini beam therapy, which is a part of the grid therapy, is at the entry, you have separation from irradiated area, unirradiated area, irradiated area. But depending upon the beam characteristics that diverge at the tumor, that is after a distance, and therefore where the tumor is located, it is expected that it will cover good part of the tumor, but at the entry, it will spare good part of the en route normal tissue. To fully achieve this, you think beam sizes much smaller and more number of beams are better, or an intermediate compromisation with a little larger mini beam and less number of beams will be better?
Yes, sir. Thank you for all good words, and in fact, it was my pleasure to interact with you. Here, as on today, whatever technology available to us, ideally, if you say 100 micron beam spot size will be a good option, because ultimately we are going to have the divergence. But with the current spot scanning technology, whatever available with the proton accelerator, it can also be utilized with the approach of dose painting, so that we can get the grid type of dose distribution, whatever we have seen in even lattice approach also we have seen like that. So this could be one of the possibilities, but many groups are working. I have gone through some literature. Many groups are working in this area, and they are proposing varieties of collimating devices, variety of treatment approaches with proton beam to achieve the practice of grid therapy.
Would you also like to comment on the raster
Yes,
pencil beam
Raster
scanning?
scanning is also possibility, sir. But that is a magnetically driven system. So you need to have a very high stability of the magnet system.
Correct.
That's why it is not thought to be a good approach as on today, because you might remember this Therac accelerator, which was introduced in 70s, has failed because of the Raster scanning approach. So people do not want to take chance now, but definitely it is a very good means a good concept. If it is introduced with highly stable magnets, can be a possible approach.
Yeah, because most of the current systems for proton and carbon at the same place, I think are now coming with raster scanning, isn't it? So I guess this issue of limitations of the magnet is overcome, you think, or is it still an issue? I don't
No, it is slowly it is going to be overcome.
Okay. Thank you so much, Dr. Sharma.
Thank you, sir. Thank you.
Yeah, so Dr. Sharma, there is a question that from Pragya. Pragya, would you like to ask yourself? Hello, okay.
Yes, ma'am.
Ask us.
So just now you have said that flash radiation induces temporary hypoxia in normal cells. So can you a bit elaborate on it?
Yeah. Actually, now you see this flash radiation creates oxygen depletion. Means it removes. Now you know that this cells contains large amount of water. So this it creates radiolysis in water, and where oxygen is consumed. So as I understand, because I am not a radiobiologist as well. So I have gone through literature, and finally they have concluded that when flash radiation is given in a very short duration, it creates hypoxic condition inside the normal tissues, because it creates the oxygen depletion, and this helps in protecting the normal tissue. So this is the basic principle of the flash therapy.
Okay, sir. And I wanted to ask one more thing. In the beginning of the presentation, you introduced the external beam radiotherapy and internal beam radiotherapy. So on what basis it is decided whether to give the external beam or internal beam, that is brachytherapy, to the patient?
It is brachytherapy, not internal. Internal is another approach, immunotherapy. So Misra sir may talk sometime. So in radiotherapy is classified as external beam therapy or beam therapy and brachytherapy. Brachy is a Latin word which means short distance. So it is a short distance therapy. So here we use brachytherapy. I will tell you, it is a very cumbersome approach. Nowadays, nobody likes to even practice because of the volume of work involved. So though brachytherapy is thought to be a mainstay treatment for gynecological tumors like cancer of cervix, then uterine, endometrium, even for either post-operative or pre-operative breast tumor, but it requires the surgical incision, that is called interstitial application. Even cancer of esophagus was treated by intraluminal brachytherapy, cancer of nasopharynx, and even many cancers on skins has been treated by brachytherapy. So in today's time, sometimes particularly for gynec application, a part is delivered by external beam therapy, and rest is delivered by brachytherapy. So there is a combination, and it depends on the case and depends on the choice of the clinician.
Okay, thank you, sir.
Thank you.
So there is a question here from, you have time, I think, we can ask.
Okay.
Yeah. So there is Dr. Sangeeta Chaudhary has asked, will IORT be more applicable in operable case, that is resectable cases?
Yeah. Yes, madam. Yes, IORT with 50 kV X-rays. Now it is available nowadays, and with particularly for breast tumor, with mammocyte catheter, it can be one of the choice. But now, as I told you, we have 7 different eating items, so it is the choice of the eater what you want to use. So it depends on the availability as well as depends on the choice of the clinician. IURT is one of the option, but not very popular because it requires once again the surgical approach.
So there are 2 questions. Antara, would you like to ask?
Yes, ma'am. Sir, you have explained the carbon ion therapy. So this therapy has a high LET.
Yes.
Then you have also mentioned that carbon ion therapy has a reduced
We lost you. Okay, I will ask. If carbon ion therapy has reduced differential radiosensitivity
Yeah. Yes, madam. Yeah, yeah.
among radio-resistant cells, bracket mein she has written poorly oxygenated versus radio-sensitive cells, well oxygenated, why do we use carbon ion therapy over proton beam therapy?
Yes, madam. Now you can see here, as I told you, this RB is the main driving factor. So usually in case we wanted to deliver escalated dose if the very high degree of confirmation is possible. So that is one option. Other option could be if I am trying some other particle which has got a very high RB value. So say for example, if a treatment of a prostate cancer, just for example, requires 100 gray to be delivered. But if I deliver it by carbon, this dose could be equivalent to 35 to 40 gray only. So what I mean to say, the normal tissue damage will be definitely much lesser than that. And it because the dose fall off outside is also very less, and it will enhance the tumor control probability.
So largely we are using, so now this is my question, but there is question here also. Why we are not using the helium ion therapy?
Helium ion, yes, madam. As I told you, helium ion is in between carbon and this proton. So as I told you, helium ion are having some drawbacks, that there is a some spillage of dose because of the range straggling, which is not possible in case of carbon. So this is one of the drawbacks. Secondly, this it was showing just some superiority over proton. So just to have some superiority over proton, it was not thought to be a good option. So better to go for somewhat further heavier particle, which will satisfy all our requirements.
Sir, then there, this is my question also. That is there any of these machines are being built indigenously?
No. Proton accelerator and carbon ion accelerators are not built indigenously. We have telecobalt machine and we have electron accelerators available from our indigenous vendors.
So are these particle beam machines are available in any of the?
Yes, madam. Yes, one proton beam accelerator is working in Apollo Hospital, Chennai from last 3 years and almost 4 years. And one is almost under commissioning in Tata Memorial Satellite Center in New Bombay. And third one, as per my knowledge, in Jhajjar, AIMS campus.
Okay.
But we do not have any carbon ion accelerator.
We don't have?
No carbon.
No carbon.
And there is no functioning carbon ion radiotherapy center in the entire United States today.
Yeah. It is only Japan. Japan is doing all this.
No, there are about 14 centers: Japan, China, Austria, and Germany. Yes. These are the 4 places.
It is a new technology or some?
No, it is very costly, madam.
No.
For your information, one proton accelerator requires the expenditure of the order of 500 crore.
God.
And also
So,
maintenance. It's not just the
yeah,
installation.
maintenance is also. So it is the installation cost, operation cost is additional.
And carbon is even much higher.
It is
And
1,000 crore plus.
and the complexity of making it continuously work vis-a-vis any of the Linux, which are now very much improved, that to the benefit ratio is what one has to see. As Dr. Sharma in the initial part of the lecture mentioned, the number of patients that you can treat with any of these in the particle therapy centers is way below what you can treat with the conformal therapy. In fact, even that is less compared to the conventional therapies, but still it is better. But if you go to particle therapies, then you have to look at how many patients will benefit by installing and maintaining at such a huge cost. And again, this resource disproportionately distributed in the society. Here it's the cancer cohort society becomes unreasonable. That's the reason.
Yes.
So Dr. Sharma, thank you very much. And
thank you, madam. Thank you very much.
But I have a request to you that just tell the students about the your research interest and
Actually I am basically working.
You are a president of a society, so all these things, if you tell them, that will be beneficial.
Right, madam. So I am basically a medical physicist by education and profession. I have done MSc Physics and then post MSc Diploma in Radiological Physics, and then worked in hospital for few years and then moved to BRC. So I have almost total about 30 years of working experience as of now. Then my research interest is the development of different radiotherapy devices. For example, I was involved in development of telecobalt machine, its multi-leaf collimator, imaging radiotherapy simulator, then remote afterloading brachytherapy, its iridium-192 source, and then ocular ruthenium-106 plaques, then iodine-125 seeds. So I have contributed, and we are still continuing with such programs.
So if one has to apply for the BARC research program to reach up to you.
Yes, madam. Definitely, we will like to interact with them, and whatever be possible within departmental norms, we can definitely help some of the people.
Okay, sir. So thank you very much, and Pragya.
Thank you, Dr. Sir.
Yes, sir. Namaste, sir. Namaste. It is a nice that I could see you here. Yes, sir. In SRR, we both are there. So through Dr. GIAN Pandey.
Yes, sir. Yes, sir. So nice.
It is nice, sir. And my thanks to Mishra, sir, also. Probably he has left, but I thank all of you for giving me this opportunity of having interaction in this way. Thank you very much, sir. And madam, thank you very much.
Okay, thank you.
So heartfelt thanks to the chairpersons for their excellence, and special thanks to, yes, sir.
There was a question regarding, I don't know whether it is by Pragya or someone else. Why is carbon still used if it is not good for the hypoxic tumor cells?
Antra. I opened that.
Can she ask that again? But I think it probably was not clear.
Antra, you ask it.
No, I think she got it wrong. It is the other way. And is she there?
Yes, sir.
Okay. You asked the question, if carbon is not useful in treating the radioresistant hypoxic tumors, why is it still used? Was that your question?
No, sir. My question is that because it has a reduced differential potential between the radio-resistant and sensitive cell, it should be having a more adverse effect over the surrounding normal tissue. So it is more toxic to the normal tissue. That is why I'm asking why we use it over proton.
All right. Okay. Firstly, when you say it has less differential between radio resistant and sensitive, That is, you are linking that to radio resistance linked to hypoxia vis-a-vis resistance linked to eoxic. Okay.
Yes,
when we come to eoxic, it could be eoxic tumors and it could be normal tissue. And therefore you extrapolated and said, since the differential is not much, it should also be toxic to the normal tissue, right? That was your question.
Yes.
Why do we still use it? Now, firstly, to reiterate that it is equally effective against eoxic tumors and hypoxic tumors comes from the fact that the RBE and LET and OER, oxygen enhancement ratio. Higher the LET, the oxygen enhancement ratio is minimal. It doesn't make a difference between a lot of oxygen or minimal oxygen, because bulk of the damage is oxygen independent. That's why hypoxic tumors and oxic tumors can be treated quite well. Now, coming back to the most critical aspect of the question. Therefore, it should also be toxic. It should be effective to the normal tissue. Why are we still using? And that comes from the physical and ballistic properties rather than solely by the biological effect. What do I mean? Because we are able to deliver maximum dose to the tumor, sparing to a very great extent the normal tissue as compared to the photon therapy, which is X-ray or gamma ray photon therapy. The carbon ion therapy is very useful. And you are absolutely right. In making small errors in treating volume, you could probably end up in a lot of normal tissue damage as compared to even photon therapy, because it's very effective. And therefore, treatment planning in delivering the carbon ion beam for radiotherapy is extremely critical, important, and it's paid always a lot of attention. If you make a small error and include the normal tissue within the treatment volume, then you are going to treat the normal tissue like anything. Even such small error in case of photon therapy probably is not as grave as with the carbon ion therapy. He showed you SOBP, the tumor area dose and the entry area normal tissue, that gray area, two places he was showing, gray entry and gray exit. And most important thing in carbon is after the tumor, if the beam is coming from here and your tumor is here, after the tumor, the dose is almost nil. Whereas in photon, the dose continues to be there even after the tumor. Therefore, sparing of the normal tissue after the tumor from the beam entry is much better in carbon ion, also in proton, but even much better in carbon even compared to proton. And therefore, you spare the normal tissue predominantly from the physical and ballistic properties. Okay?
Okay, thank you.
Yeah.
So also we are thankful to Dwarkanath sir for continuously staying with us in the discussion and helping
I have
us
a lot
all
to
out.
learn. Better stay.
So there is like now, if there are no more questions, so we have one video of one of the students that how to perform the micronuclei or some assay. So just to, yes, yesterday we have shown you one video.
Can I sign off and join you at the time? What time is the...
Yeah, you have to, Vikram will be around 4, but 2 o'clock. Next session is 2 o'clock.
No. Our time 4 o'clock, Vikram is going to talk, no? So by...
Before that, your talk.
2 we should start and stop before 3:30. I mean 3:30. And with the
yours is 2 o'clock.
Sure,
yeah,
sure.
Sure, you can work. Yeah.
So I will log in around 1:55. Will that be okay with you?
Yeah, sure.
Thank you. Thank you.
So I'm talking to the all participants who are here. So we are going to run one particular video over there, and please don't run away. You will learn out of that. There is a video where we will be presenting. कल मैंने कौन सा प्रेजेंट किया था, तो कोई मुझे हेल्प कर सकता है? कल हमने कौन सा किया था कल?
मैम ग्रोथ काइनेटिक्स से।
ओके, ठीक है। तो हमने ग्रोथ काइनेटिक्स किया था, फिर अभी माइक्रोन्यूक्लियाई वी कैन रन. So we will run the micronuclei essay, and this is around 27 minutes video. And after that, we will be here. And if you have any question, but please listen to it and try to learn to it, because we have specifically prepared this video for you. It is not that it is being.
Hello everyone, my name is Humyo, and today I am going to demonstrate an.
I have to stop it. So it was started displaying.
No, ma'am.
अच्छा, ठीक है, तो मुझे शेयर करना है स्क्रीन. So wait for 2 minutes.
Hello everyone, my name is Humyo, and today I am going to demonstrate an assay called micronuclei assay. Micronuclei assay is one of the in vitro assays used for toxicological screening for potential genotoxic compounds. It is an assay that detects the chromosomal damage in mammalian cells in the form of nuclei. So today I'm going to use HeLa cells, which is a cervical cancer cell lines. So I have taken two sets of condition. One is the condition where I have to give radiation treatment alone, and the other one is the condition where I have to give drug plus radiation. So in this, this is the X-ray irradiator machine where I have to give my cells for radiation. So inside the fill area, I'll keep my cells. And I'll choose the program number 2, where I can set up the desired radiation dose. So in this set dose, I'll give 400 centigrade radiation dose, and after setting the radiation dose, I'll press the continue button, and then I'll start the radiation. The radiation has started, and once the dose rate it reaches 400 centigrade, it will automatically turn off. So I have taken 4 sets of conditions. One is the drug treatment, another one is the drug plus radiation, and the third is the radiation alone, and the fourth one is the control without any treatment. And I have seeded 1 into 10 to the power 5 cells in 35 mm dishes. So the first thing I did was to remove the media from the cells. I washed the cells with 1x PBS. And then I trypsinized the cells with trypsin. And then I incubated the cells for a few seconds. I have collected the cells with 2 ml PBS. And make up the volume to 5 ml. the cells are collected, I am going to give this for centrifuge. So I have to give the cells for centrifuge. The cells will be centrifuged at 900 RPM for 3 minutes. So after centrifuge, I have collected the cells and I have to discard the supernatant. So I have collected the cells in centrifuge and falcons, and I'll discard the supernatant. And after this, I have to fix the cells with this fixative, which the composition of this fixative is 3:1 amethano acetic acid. So I dissolve the pellet in 100 microliter of the fixative. After dissolving the pellets with the fixatives, I have taken pre-chill glass slides. One for the control, one for the radiation alone, and one for the drug alone, and the other one for the drug plus radiation. And I have to put the cells in the glass slide.
तो तुम्हें अब बोल रही हो तुम भी मुझे?
नहीं चल रहा था, अभी आपने दोबारा शुरू किया।
मैंने इसलिए किया क्योंकि मुझे प्रज्ञा का फोन आया कि वो चल नहीं, वो चला खा गया, मुझे ये नहीं समझ। Sorry, I'm sharing it once again. Wait it.
Hello everyone, my name is Kumyo, and today I am going to demonstrate. I have collected the cells and I have to discard the supernatant. So I have collected the cells in centrifuge in falcons and I will discard the supernatant.
कुछ तुम्हारा खुद का प्रॉब्लम है, पता है?
में भी नहीं आ रहा मैम लैपटॉप।
नहीं वहां आ रहा है, मैं देख के आई हूँ। लोग खुद का प्रॉब्लम है। ऐसे कैसे अपने आप वॉल्यूम बंद हो गया? कोई आया यहाँ पे म्यूट करके गया, किसी ने मुझे म्यूट किया?
कोई आया ही नहीं मैम।
वो वहां से उन्होंने CIS ने मुझे म्यूट कर दिया।
Hello everyone, my name is Kumyo and today I am going to demonstrate an essay called
कुछ नहीं समझ आता तुम लोग सिस्टम। 15 मिनट बाद मुझे बता रही है वो फोन करके कि आपकी आवाज नहीं है।
micronuclei assay. After dissolving the pellets with a fixative, I have taken pre-chill glass slides. One for the control, one for the radiation alone, and after dissolving the pellets with a fixative, I have taken pre-chill glass slides. One for the control, one for the radiation alone, and one for the drug alone, and the other one for the drug plus radiation. And I have to put the cells in the glass slide. After putting the cells in the slice, I have to put the piece. Since it is a light sensitive, I have turned off the lights. After putting Chabi, I have to put cover slips. And after putting the cover slips, I have to incubate this at 4 degrees Celsius overnight. And after incubation, I have to view this under the fluorescence microscope to check the formation of micronuclei and then count the micronuclei for the response. So after overnight incubation of the slides, I check the result in the fluorescent microscope using the P filter, and the micronuclei fraction form will be calculated accordingly. After calculation of the microfraction percentage, we will plot the graph accordingly.
Hello, प्रज्ञा
Yes, ma'am.
कहाँ पे से छूटा था, दोबारा प्ले करना है या हो गया?
मैम हो गया पूरा.
अच्छा, ठीक है. So now you can close it.
Yeah. So thank you everyone for staying with us, and now we'll be taking lunch break and we'll be coming back by 2 p.m. to proceed with today's program. Thank you.
Thank you. Just a minute. I have one thing to say to the Ayurveda biology students are here. Can I talk to any one of you? Hello.
Yes, ma'am. We are here.
May I know your name? Who is there?
Komal Kumari, ma'am.
Komal, you, how many of you are registered to this course?
I think everyone has registered.
No. Achha, anyway, fine.
Yes, ma'am.
Everyone is not registered, so check it and register. Fine. A. Number 2, tomorrow we will conduct the practicals in tomorrow and day after. So you have to reach to this molecular medicine by 1:30. So you are 13 students or 12 students?
11, ma'am.
So all 11 of you have to come to the center. And if you have not registered, please register today also, you can register. So you immediately register. Whosoever has not registered should register.
Okay, ma'am.
Okay, and then you require, then when you will come here, rest of the thing we will talk. So 2 days after 1:30, there will be practicals, but for the online participants, the other lectures will keep on going. Okay, so other participants have to attend as they are attending, but all of you, there will be a practical class over here. Okay.
Okay, ma'am.
To reach here at 1:30 and contact Palak and Antra. You come to my lab in molecular medicine and then you contact me. Okay.
Sure. Thank you.
Or you can come at 2 also.
Okay, ma'am.
Sharp at 2. Fine.
Okay.
Thank you. Thank you.
Thank you so much, ma'am.
प्रज्ञा ये हटाओ स्लाइड.
Yes, ma'am.
नहीं हटा है. अभी वेट कर लेना जरा 2-3 मिनट.
Okay.
तुम बोल दीजिए कि
नमस्कार सर.
Dwarkanath ji, am I audible?
Yes, sir.
Okay, okay.
Namaskar, sir. That's why I first said I saw you, but you are now unmuted. You were muted earlier.
Okay, okay, okay. So,
कैसे है सर?
मैं ठीक हूँ, आप कैसे हैं?
बहुत बढ़िया सर. Thank you.
So you can start then. If
Oh, is it okay?
Professor
Because
Biba,
said a few minutes. I don't know for what. Can we get started, Dr. Biba? Oh, she has muted.
okay, so let me see.
Should I go ahead and start?
Just let me confirm it.
Yeah.
And I think we are waiting for another chair. I see my name is there, and then.
Oh, I'm muted and I'm speaking. Sorry. So, yeah, so we are waiting for Dr. Santosh Kumar Sandur. And just give me a few minutes. Maybe he will join late. He has a meeting. So, but let me check that whether he's joining or not.
Huh.
Because he said that he may join
late.
Latest update is not there. So, just few more minutes.
Sure, sure.
राणा जी, अभी आप ज़्यादा fresh लग रहे हैं. You are now free from all tensions. Few tensions. Administrative tensions. So Pragya, you can start now because he may, because they don't take carried mobile. So
Oh,
we
okay.
can't talk to them. Landline is not catching. So Pragya, you can take a start and then.
All right, ma'am. So welcome back, everyone. Certainly the post-lunch sessions need more attentiveness. So let's start our next session with full energy. And I would like to invite Dr. Santosh Kumar Sandur, although he's not here right now, Division of Radiation Biology and Health Sciences, Bhabha Atomic Research Center, Mumbai, and Professor Rana Pratap Singh, School of Life Sciences, Jawaharlal Nehru University, New Delhi. Dr. Sandur has his expertise in medicinal chemistry, natural product chemistry, study of radiation-induced DNA damage, and oxidative stress. Professor Rana Pratap Singh has been rector of Jawaharlal Nehru University. He has also been a visiting faculty at University of Colorado, Denver, USA. Professor R.P. Singh has his research expertise in carcinogenesis, cancer chemoprevention, radiation biology, and anti-cancer drug development from natural agents. He has several international publications and more than 2,000 citations. I request both the chairpersons to chair the session.
Not 2,000, 20,000. So
20,000,
0.
sorry.
Thank you. Thank you. Thank you, Bivaji, for organizing such a wonderful program. And under GIAN, I see many of the participants who are connected with this course and they are getting educated in the area of radiation biology, and cancer biology, and other disease biology which are associated with the cancer, as well as radiation. So now it is my privilege to introduce Dr. Dwarkanathji. I think anyone who is working in the area of cancer biology and radiation biology or radiation biology per se, all of them are aware of this name. And the contribution what Dr. Dwarkanath has already made to this field is phenomenal. So we are here to witness the research expertise as well as the thoughts behind the work was he has contributed through his whole life. And this is going to be delivered as lecture number 11. The topic I see is a modification of cellular and systemic responses to radiation. So in this, the focus is going to be on radiosensitization and radioprotection, and the applications of radiosensitizer and radioprotectors in radiotherapy. So these two topics are very much close to even many of our researches which are being done in JNU. However, we know that in MAS, where Dr. Dwarkanath has contributed immensely, these areas have contributed in the development of several products as well. And those products are now, I hope it will be in the use, and we are going to hear much about that from Dr. Dwarkanath, that how he has gone through these concepts and find out various mechanisms for radio protections as well as radiosensitization. Only just my brief remark is here that when we talk about radiosensitization and radioprotection, as per my understanding, both may be different. However, in some cases, the pathways may be similar. So what Dr. Dwarkanath, I hope he is going to also talk about and make us more clear that how these two worlds, which looks like very same, are opposite to each other, but they are very different in terms of how cell responds to these stresses of radiation. So again, it is my privilege to have Dr. Dwarkanath for this lecture. Sir, over to you.
Thank you very much, Professor Singh Saab. And let me start sharing the slide. Oh, it is disabled. Can you enable sharing for me?
Yeah, you did not made him a co-host.
Yes, sir. Yeah.
Host has disabled, it says.
No, actually,
yeah, it's now available. And I guess
make Dr. Rana sir also co-host.
Ma'am, he is the co-host.
Okay.
okay. Is my screen visible?
Yes, sir. Please.
Yeah, on my okay. So what Dr. Vibha has asked me to do is talk both the approaches for radio protection and radio sensitization at large, with, of course, a bias on some of our work done. So I want to be very clear that much, if not all, of the talk would not be our own work. Of course, some of the recent work on the mitigation of radiation damage, which is one of the focus here, will be a part of this presentation, as also, of course, our work on radio sensitization targeting the Warburg phenotype, but that would be the whole presentation. So because this is a regular teaching program which embeds, of course, within a short period of time, I've tried to keep a balance, give a flair of what is involved in radio sensitization and protection, and come back and discuss a few things more biasedly of our own indulgence in this field. So that's what it will be, and you have to bear with me. I've shown all this slide earlier to Professor Singh, as he knows that I've been at several places which has contributed to my understanding and ignorance as I stand, and I've been constantly guided from the inception till today by Dr. GIAN. So much of what I am today, I owe it to him. I have actually, in some part of the presentation, taken things, material from the internet without too much of ado. And since it's only for teaching purposes, I guess it should be fine. So I start off with the bedside problem, which is not confined only to radiotherapy, but also true to chemotherapy, some part of it. They differ in some, they have something in common. The common thing about the limitation of radio and chemotherapy is actually the presence of tolerant cells or efficient cells which are resistant to any given modality. Now, in case of radiotherapy, the hypoxic tumors pose an additional challenge. Both of them, of course, are severely limited in our ability to use higher doses or combinations of drugs and radiation due to the normal tissue tolerance. So we need to keep a balance between killing enough tumor cells, no matter which pathway. That's part of the therapeutic approach, including sensitization, but to be able to preserve normal tissue. That's in the therapy domain. Both of them also have in common the tumor-linked immune compromise, as well as therapy-induced immune compromise on the one hand. So we need to keep all this in mind and try and get a good understanding and design mechanisms and therapy protocols so that we can achieve better therapeutic gain. Typically, as I have shown in the cartoon, the tumor and the normal tissue responses do not actually differ very much. They do to a certain extent, but the fond hope is to push the tumor response to the left. That means we can elicit a very good response at lower dose and push the normal tissue response to the right. That's the most ideal thing. Protectors which do not meddle with the tumor response will push the normal tissue tolerance to the right, and sensitizers which have minimal effect, which is theoretically not possible, on the normal tissue push the tumor response to the left. So these are classical approaches of looking at it, but no single agent can theoretically do without influencing the other. which I think is the point that Dr. Singh made to begin with. And equally important is the protection, mitigation, and therapeutic management of radiation damage caused under a variety of conditions, which are either planned, unplanned, accidental, like, for example, the Chernobyl, Goanya, Mayapuri, a lot of things. So, so the whole area of protection, mitigation, therapeutic use of radiation goes beyond their utilization in therapy. Therefore, one has to keep in mind what are the approaches to reduce the radiation damage when the exposure has taken place, and what are the options that we have to reduce the damage before the exposure takes place, which is possible in therapy, which is possible in planned exposure. I think yesterday somebody was talking about rescue workers, so on and so forth. So there are a number of scenarios where we need the support and assistance of modifiers of radiation response at the cellular and systemic level, which have utility. Now, classically and typically, protection domain is when it certainly meddles with the radiation chemistry, if not the physics. The physics part is taken care of by shielding and physical methods. That's not in the ambit of our discussion. If you manipulate the induction of macromolecule lesions, which sets off the biological response, ultimately leading to cell death, tissue damage, and mortality, morbidity, if you can manipulate at that stage, that approach is called the radioprotection. However, when you don't do that, you miss that, and you come back and intervene with approaches using agents or paradigms that can reduce the clinical manifestation of the damage that has already been caused. And that approach is called mitigation. And you can see in the cartoon that starts somewhere after the induction of damage, from the time the repairs processes, molecular responses set in, up to the manifestation of organ and functional impairment, which then manifests as clinical paradigm. Of course, late effects, and these are managed by therapy. So once the clinical manifestation has taken place, you only manage the patient who has been inflicted with radiation exposure. That falls under therapy. So there are several pharmacological, some of them are still to be taken to the pharmacological intervention stage. Some of them are still chemicals, but you have radical scavengers, antioxidants playing a role in the pre-damage induction era, enhancers of repair and recovery processes, modifiers of cell signaling pathways at the mitigation level, and several cytokines, supportive therapies, immune modulation, and so on and so forth, which also overlaps to a certain extent with the mitigation, should have been shown. So the radioprotectors, therefore, are chemicals which bring in their effect when they're present at the time of irradiation and reduce the injury to the tissue. There are ways to improve the protection of normal tissues, among several things, as I said, depending upon the paradigm. If it's radiotherapy, so many physical protections, technologically reduce the dose, so on and so forth. And most important is what I have put in the red bracket is use chemical protectors. So as a classical definition is there any regimen that can provide when this drug is present, so as to manipulate the immediately set in radiochemical processes. So several things need to be in place for a good radioprotector to function very efficiently. That includes protection against various type of damages with minimal damage to normal tissue, and it should not have undesirable interactive complications when used with other therapeutic regimen together with radiation, and so on and so forth. It should be effective even when it is used for a shorter window and not necessarily requiring an extended administration. That's most desirable. And most importantly than not any of these, that it should be able to protect almost all the organs. It should not be tissue specific, because during an accidental exposure, you could have a whole body exposure. In case of radiotherapy, of course, it depends on the location of the tumor. But when you develop a protector, you would like it to be not tissue specific. Several classes of compounds which have different underlying mechanisms have been extensively investigated. I'll only probably build a little background. Sulfhydryl compounds is something that I'll discuss because of one particular reason that I'll come to. Radical scavengers, vitamins, and antioxidants. Metallothioneins have been extensively investigated, either alone or in combination with radical scavengers, so on and so forth. Cytokines and immune modulators, and lipopolysaccharides, basically they modify the inflammatory response and therefore reduce the radiation-induced injury. The DNA interactive small molecules, the ligands, which Dr. Vibha has also done extensive work, have also been considered. Some of them have reached the goal. I mean, one has reached the goal. Many of them are close to the goal. Many have gotten left behind as they went along. So the approaches for protection would be to have a good way of screening to evaluate the potential agent. Typically, it is the survival, especially at the organism level, because the taste of the pudding is actually in eating. If you show that your interventional agent does so many other things, but at the end, you administer and irradiate, if the animal still dies, irrespective of what you give, then that's of little value. And in providing a survival advantage, which is mortality, the focus would, under a variety of conditions, with a supralethal, there is nothing much that one can probably do about, but at moderate and low levels of exposure, the foci would be the hematopoietic system and the gastrointestinal system, which are relatively sensitive. The hematopoietic is the most sensitive, and moderately is the gastrointestinal, which contributes to the morbidity and mortality. Of course, a great deal of mechanistic studies are very essential to be able to place them for clinical approval. So as I said, over the years, it's probably more than with the program at the Walter Reed in the post-World War era, where they scanned thousands of molecules, therefore the WR series. A number of chemicals with similar underlying mechanisms and diversified mechanisms have been investigated, which I have listed on the left, including calcium channel modifiers, functioning calcium channel modifiers. And a good amount of work to begin with was carried out in India, especially by Professor Uma Devi's group on the Tulsi or the Ocimum santum, which has actually progressed to a certain level. We probably need more energy to push it through because it has picked up some momentum, but then met with inertia. So you will see that the mechanisms of action underlying span from radical scavenging to immune modulation, biological response modification, membrane receptor modification, and scavenging and attenuating the activity of macromolecular ligands, like in case of the in case of the benzimidazole compounds, and there are the complex natural products, because of their inherent multiple components, they have multiple actions. That could be it. Now, the rationale for using radioprotectors in radiotherapy would be with a focus to enhance the therapeutic gain or therapeutic ratio. Typically, one would like to have a TCP, tumor control probability, appear at a much lower dose, so that without intervention by any other adjuvant, you can still get a broader window. If not, then you would like to push the normal tissue response to the right, and therefore the normal tissue complications can be reduced so that the therapeutic gain is achievable. As this shown in the cartoon above, so the realm of radioprotectors actually focus on how do I shift my normal tissue response to the right. That's the classical radioprotector approach. Now, several things which I mentioned earlier would qualify anything to be considered for evaluation as a radioprotector, and I think we should probably not spend too much time. So different classes of molecules with their underlying mechanisms have been investigated. Radical scavenger, as I said, one of the ways, especially in case of radiotherapy, is linked to the hypoxic tumors vis-a-vis the normoxic normal tissue. Therefore, paying attention to the modification of normal tissue oxygen levels, wherever it is a limitation, one can protect the adjoining normal tissue with creating transient local hypoxia as well. Epithelial specific growth factors have been shown to be useful in reducing the morbidity and mortality. A work done by the German group for a very long time. And hematopoietic growth factors basically to regenerate, to repopulate the hematopoietic system by stimulating the various constituents of the hematopoietic system in terms basically as growth factors, and modifiers of angiogenic factors and the inflammatory responses. Now we will go and just quickly take a look at this molecule, amifostine, which is also the WR2721, one of the Walter Reed compounds, which was originally intended to be developed for people who go to the radiation area. Just the World War was over, because everybody was wanting to prepare of unfortunate eventualities. So the focus was actually to develop a compound which can be used in field without too much of a complication in the administration, and afford protection to the entire body in a tissue independent manner, and so on and so forth. Because of the enormous amount of mechanisms, radiochemical mechanisms underlying damage induction, which had accrued by then, thanks to Frank Hutchinson's, Jim Raleigh and others' work, Mike Civilla's work, the suggestion from PAD and others was that aminothials, by virtue of their ability to do several things, which we'll come to in the next slide, should be able to reduce the causation of macromolecular damage, although of course they can't stop the generation of radiolysis and the subsequent radiochemical products, but you could intervene before these highly reactive, less stable radicals attack the macromolecules. In that, the aminothials, because of their thiol group at one end and the imidol group at the other end, were considered. Among several things that were investigated, amifostine happens to be the one which withstood the ground and has been taken forward. The reason that I'm spending a little more time is because amifostine is the only radioprotector that has been FDA approved and extensively used for a long time in radiotherapy to protect normal tissue, and also as a cytoprotectant in combination with cisplatin and other drugs which cause DNA damage in a radical dependent manner and responsible for cytotoxicity. It's a prodrug in one sense, processed into an active drug by the alkaline phosphatase, which is also linked to somewhat selective, relatively, not entirely, somewhat selective to, therefore, to the non-malignant cells or the non-tumor cells, the normal tissue, due to variation, due to differences in the alkaline phosphatase content of the neoplastic cells and the normal cells. And then it affords protection. And several other molecules in the same family had also shown that they are anti-mutagenic in one sense, and they afford protection by more than the by more mechanisms than just the radical scavenging or hydrogen ion donation, and so on and so forth, and also stimulate cellular repair and recovery process, which is also true in case of amifostine, which contributes to the systemic protective effects of amifostine. However, its administration prior to radiation exposure is a prerequisite. Although amifostine does modify some of the post-exposure biological responses, but its protective effect predominantly comes from its ability to manipulate the pre-macromolecular damage induction error domain. A meta-analysis concluded that amifostine does not affect the tumor response so much, and therefore it is less likely to compromise the radiotherapy, especially the tumor control effect. And other approaches, as I said, linked to oxygen, because as we have discussed earlier in more than one sessions, I think me and others, that oxygen plays an important role in amplifying the radiation-induced damage, particularly photon radiation-induced damage, which predominantly causes damage by the indirect effect through the generation of radicals from the radiolysis of water, as much as about 70+%. Therefore, oxygen plays an important role, limiting the efficacy of therapy in hypoxic tumors and in the normal tissue as an impediment in making the normal tissue susceptible due to abundant oxygen level. So if you can transiently constrict and reduce the oxygen supply when an exposure is likely to take place, somebody goes to a contaminated area, if you can administer some agents which will reduce transiently, modulate, attenuate, not stop the flow, then relatively one can probably expect a number of compounds that have been investigated, which includes some of the drugs that are belonging to the monoxide group, the cyanide, the serotonin, epinephrine, and so on and so forth. Of course, the scavenging of free radicals and compounds which can do hydrogen atom donation and then reduce the radical mediated damage to the DNA in causing strand breaks in this glutathione. And that's where the amifostine, a part of the Walter Reed compounds, comes into picture. I think we have discussed some of them. And 1607 is actually the active moiety, and amifostine 277 is the parental one, which is a predrug. I think we have discussed this. So there are very good results in the preclinical models and number of cell systems. Shown here is the example from CHO 3T3, and 3T3 has been investigated. A number of human fibroblasts have been investigated, the WRDR stages. They all show enhanced survival when the compound is administered. Now, amifostine has its own advantage and it has limitation. One of the limitation, the greatest limitation, is amifostine is almost, if not to a very large extent, ineffective when administered orally, because in the gut it is readily degraded and it's practically of little value when you give orally. This is number one. Number two, even when given, and therefore it limits its use in the field and as a field radioprotector in case of accidental exposure and in case of large scale exposure. That's of little value. And that's one of the reasons as to why Walt Reed, although they were interested in field effective radioprotectors, when this was developed, it was shifted to the spin-off application in the clinics, where it progressed and became one of the FDA-approved radio and cytoprotectant in the clinics. So one of the limitations is oral effectiveness. The other one also is that the LD50 to ED50 ratio of amifostine is not very favorable. It is not exactly 1 or less than 1, but it is certainly not a desirable value of like 5, 6, 7. 7 is very ideal, but it is not so. And therefore, amifostine is always administered under medical care, which probably is of limited use in case of population exposure, accidental exposure, military exposure, so on and so forth. So there have been a great deal of interest. One of our sister labs in Gwalior, DRDE Gwalior, who are chemists and then toxicologists, have been, and this lab has been interested in countermeasures against chemical damage. They synthesized a number of derivatives of amifostine to overcome the limitations that amifostine had on the one hand, and because some of these chemicals have underlying biological mechanisms similar to mechanisms underlying cellular and molecular response elicited following radiation damage, their interest was to synthesize analogs of these which can protect against chemical damage and also be effective when administered orally. On the right bottom of the cartoon, 3 analogs designated as 7, 30, and 35, which are ethyl phenyl sulfide, propyl sulfide, butyl sulfide modifications to the amifostine at the indicated place were synthesized, and the lab had already shown their effectiveness against sulfur monoxide and other chemical-induced toxicity even when administered orally. Therefore, we got interested and said, basically, amifostine is a good radioprotector which has been well established, and if these analogs can offset the limitations of amifostine being not effective orally, then I think we have a radioprotector which is also effective when given orally. So these are the things, and this was orally effective against sulfur mustard. So we got interested and started looking at the efficacy of this. Even when given orally, we found one of the analogs was effective, let's say almost 30% survival as against 0 against the whole body irradiated mice. So different analogs have been taken forward for different things. One of we have, I do not want to, as I said, I do not want to occupy with only our results. We have done extensive work showing that it protects against hematopoietic injury, acute hematopoietic injury, gastrointestinal injury, liver damage, kidney damage, so on and so forth. But only one I will share, which is against the radiation-induced lung damage. The paradigm we used was a high-dose thoracic irradiation. This is not whole body irradiated, high-dose thoracic irradiation, and then looking at several things, the inflammatory processes besides other parameters like structural and so on and so forth. So as you will see, I have summarized, we have looked at the effect of these analogs. This is DRD30, which was orally effective in modifying the oxidative damage, the RNS and damage to the endothelial cells. We've looked at the VEGF, so on and so forth, the inflammatory responses and tissue responses, and including the tissue extracellular matrix, which play a role, ICAM, BCAM, which play a role in tissue damage and recovery from tissue damage caused by radiation. And this cartoon summarizes it all. There's a clear lung. When you irradiate, it goes through all these processes that contribute to the lung fibrosis. Now, if you intervene with DRD30, then you will attenuate to a very large extent the lung damage caused by radiation. The other paradigm that we looked at was a mitigation, which, as I said in the classical radiobiology definition, is an intervention or an agent when administered post-exposure to radiation before clinical manifestation can reduce the injury, ensuing injury, and the clinical, the morbidity and mortality. And this is the mitigation window. Yeah, this is the mitigation window. So we investigated a class of compounds which are actually basically, again, antioxidants in one way. They're polyphenols. Most polyphenols, of course, are bestowed with antioxidant properties. What we did together with two groups in Delhi University, a chemist who synthesized a lot of compounds, and they made a large number of derivatives of certain classes of molecules like quercetin, coumarin, and so on and so forth. They're all different polyphenols. And together with Professor Raj, who had interest in looking at the biochemical effects of these, we got interested because all these molecules are basically, the basic molecule is an antioxidant, but the engineering that they did on these molecules was to put acetyl groups, which could be harnessed, which could be cut and made available intracellularly. And this, from their own story, was cal-reticle independent, which is a work that we have done in another field that I don't think I want to discuss. So we opined that if we use these molecules, due to their antioxidant nature, they should be good, but their ability to donate acetyl groups in the cells should be able to modify protein acetylation, which amongst several post-translational modifications that regulate the molecular responses to radiation damage, should be able to modify the protein activity and therefore modify the molecular and cellular response. The question was, fair enough, it would do that? Would it result in a better recovery, less morbidity, less mortality? In other words, can it protect and or mitigate the radiation damage? So we were targeting here a parental moiety, which is an antioxidant in nature, and ability to donate acetyl group and modify cell signaling linked to damage response, hoping that we will get a better reduction, better mitigation. We were looking at both protection and mitigation. Kavya did all this work to begin with, give before irradiation, 4 hours before, an hour before, 24 hours later, and at different doses, and showed that indeed they can function both as a protector and as a mitigator. But a thiocoumarin, similar to the thiol compound, the aminothiols, when these coumarins were also manipulated for the thiol content, when a thiol group was put, the diacetoxy coumarin vis-a-vis diacetoxy thiocoumarin showed that it is a very good mitigator, while the thiocoumarin was a moderate protector. That means effective when given before irradiation. But the thiocoumarin, which we call as the DAMTC, diacetoxy-methyl thiocoumarin, was effective even when administered 24 hours post-irradiation only once. The paradigm was you irradiate, come back 24 hours later, give 1 dose of DMTC and do all the observations. Again, in this, we completely worked out the hematopoietic injury mitigation, gastrointestinal injury mitigation, and showed that it does several things that is linked to restoration of the blood counts, reduction in the DNA damage, cytogen damage, stimulation of the remaining stem cells following the damage induction, and then mobilization of the stem component, both in the hematopoietic system as well as in the GI, and reduction in the apoptotic death. That means both mitotic as well as interphase apoptotic death. And this was paralleled by modifications in the acetylation of several proteins, including the proteins in the nucleus, suggesting that these modification in the radiation response by DMTC and DMC, of course, had a strong relationship with their ability to acetylate proteins. So this is an example of the bone marrow damage, and I think this is the macrophagic stimulation which contributes to the recovery following radiation exposure. In summary, the DMTC, when administered post the irradiation in the bone marrow and in the blood and spleen, does several things in reducing the damage development, because in case following radiation exposure, the damage, at least the biological damage in terms of cell death, doesn't happen instantaneously. That develops over a period of time through a hierarchical set of signaling events that follow one another. And all these are attenuated, resulting in building up of the blood cell pool in the center that you will see, and then also modifying suitably the inflammatory status, and both the Th1 mediated immunity induction and also the humoral immunity. And in the spleen, the macrophagic reprogramming that contributed to the mitigation of hematopoietic injury. Similarly, we also carried out the gastrointestinal injury and showed the structural damage is reduced, intestinal structure is reduced, reduced apoptotic death, and stimulation of the stem cells, regenerating the intestine, and reduction in the leakiness of the gut, and all these things were worked out. And to summarize, it had antioxidant defense, enhanced antioxidant defense, enhanced ability to proliferate the remaining cells to repopulate, and M2 macrophagic phenotype induction, and attrition of the DNA damage, resulting in activation of pro-survival signaling, and restoration of inflammatory and tissue repair processes, reducing, of course, the cell death, and which then resulted ultimately into mucosal architecture reconstitution and the regeneration of the epithelium. We had the privilege of this work deserving its due recognition. We were fortunate enough to be writing an invited review for this journal, where we summarized the mitigation by DMTC through hematopoietic and gastrointestinal system actually facilitates rescue, reconstitution, and restoration of the tissue function. Pawan has been investigating again a mitigation paradigm, looking at somewhat similar to the DMTC, but using classical modifiers of protein acylation, the HDAC inhibitors. And as shown, when these HDAC inhibitors are administered post-exposure, anywhere from 4 to 24 hours, they lead to better survival, that is reduced morbidity and mortality. That again includes a better damage response in favor of survival, reducing the cell death, and stimulation, most importantly, the stimulation of the respective system by the recruitment of the stem and the progenitor population. And many growth factors in tune with this in the past at several places, combination of growth factors which manipulate very many processes that cumulatively contribute to the radiation injury have been investigated. One of them is granulocyte stimulating factor and the IL, the interleukin, which actually stimulate various populations in the hematopoietic and other immune system. And they all have been shown to facilitate the recovery from radiation damage. These are typical protocols where administration is done after irradiation and survival is. They all similar to the work that we did with DMTC, contribute to the stem cell mobilization, progenitor expansion, and leading to the generation of mature cells and functional restoration of the different organs. And some of the upcoming mitigators include the GCSF, IL-11, which is probably going to be introduced, or they're all probably under FDA approval, and they'll probably soon be available for the clinical usage. So an overall overview of the current status of protectors and mitigators is, besides amifostine, the CBLB 502 has been approved, has been submitted for approval. It's at the advanced stages of evaluation. This is from the Cleveland Biolabs, from Andrei Gutkov's group. Srrt is from the Onconova group, which is a sulfone, and shows DNA repair enhancement and prophylactic and mitigative effects. And corticosteroids and several other chemicals like silver nitrate and sulfatrate have been looked at. Sbrt, Mimitex, and aloe vera have all been at different stages of evaluation. Herbal radioprotectors, as I mentioned to begin with, have also been at different levels of clinical evaluation. Although some clinical trials were done at ACTRAC, we are yet to make significant progress. So what is already available as a FDA-approved management of the radiation exposure or damage is the aminoethyl is the amifostine, and several antimicrobial as a supportive therapy, and growth factors also as a recovery agent has already been in use. But as we will all appreciate, there is a great deal of challenge in developing newer protection mitigation agents, because it's easy to develop a drug for a given disease. You could, whatever you develop from preclinical models can be evaluated very decisively in a clinical setup, because you have a disease and you have a development. You can go do the clinical trials and see whether that disease has been addressed. But in case of radiation damage, mitigators or protectors of radiation damage do not have a disease, and you cannot have clinical trials to advance your drug by saying that volunteers will be exposed. Therefore, there is a great deal of challenge. There are therefore commensurate regulatory relook. One of them happens to be the two-animal rule, and many of these, including the surrogate markers and so on and so forth. So all these things pose a big challenge in developing countermeasures against radiation as compared to developing a drug for any particular disease. Now I will switch gears and move to radiosensitization of tumors with a focus both on We keep always hearing hypoxic tumors are difficult to treat with radiation, like that. So what are the hypoxic and non-hypoxic sensitizers that we have? And the other one is, irrespective of the nature of the tumor, what are the approaches where we can manipulate the biological response and obtain a better tumor cell kill and therefore a therapeutic gain. Radiation as well as drugs meet with a great resistance by the hypoxic cells in their ability to achieve therapeutic efficacy. And therefore, there has been a great deal of interest. A lot of work was done in the Stanford University way back to develop cytotoxins which are specific to hypoxic cells. The rationale was when you combine these, pirazapamine is one of them. The rationale was if you use the hypoxic specific cytotoxins and combine it with radiation, then with the hypoxic sensitive cytotoxins, you address the hypoxic tumor, hypoxic component of the tumor, and with the radiation, the eoxic component. You would expect, if they work almost independently, an additive effect, but if there are interactions, a marginally sensitive effect. If they antagonize, you probably will have a subadditive effect. So the main pathway of radiosensitizers again started with oxygen as the focus, similar to oxygen as the focus using radical scavengers and others with a thiol group for the radioprotection. Here, the other way. If availability of oxygen limits the efficacy of radiation-induced cell kill, simply give oxygen. And you could sensitize the tumor with a simple strategy. Indeed, that has been investigated. In vitro, excellent results, and you can do these experiments very well. You can create hypoxic levels to varying degrees, irradiate cells, and show they become resistant. Now use certain agents which will abolish this and come back and show you sensitize these hypoxic cells. And the clinically hyperbaric oxygen as a therapeutic modality was tried. Clinical responses were not encouraging, coupled with very difficult patient compliance due to a number of reasons. So the hyperbaric oxygen used in radiotherapy has not been a stay. Alternatively, breathing oxygen and subsequently mixing this with some amount of carbon dioxide, called the carbogen, has been investigated. The clinical responses have not been overwhelming. Vasodilators, those agents which enhance the supply of blood and therefore the associated oxygen to the tumor, is expected to turn the hypoxic tumors into at least partially oxic and turn towards eoxic. So a number of vasodilators are agents which modify the oxygen delivery to the cells, erythropoietin and others, have been investigated with varying degrees of success. And another class of compounds which have received a great deal of attention, at least a few decades, which is FDA approved but not extensively used, is the electronic affinic compounds. One, as I said, is if oxygen is the limitation, give oxygen. The other one is give a chemical which behaves like oxygen. What oxygen does in enhancing the radiation damage in cells is to function as a sink for electrons. The short-lived radicals would like to give these electrons to any acceptor. Oxygen is readily there, gets accepted, and then gets excited. Then, because of its long life and diffusibility, interacts with the macromolecules. If oxygen is limited, give some compounds that will now take the electrons from the free radicals and toss it onto the macromolecules. With that approach, a number of electronic affinic compounds have been investigated and shown that indeed they can enhance the radiation response. This slide should have come a little later, but that doesn't matter. If you give the imidazole, which is an electron affinic compound, and it can mimic oxygen, then you see that the survival of this group is better. Now, a number of, as I said, this should have preceded the previous one. A number of imidazoles and other compounds have been investigated: nitrimidazoles, etranidazole, nimidazole, and so on and so forth. Again, their preclinical responses have been excellent, especially in vitro, also in animal tumors, as you will see that the TCD50 for the tumor, which was almost like 44 gray, goes down to 24 with a dose and a sensitizing enhancement factor of all close to 2, 1.88 to be precise. But a meta-analysis Jens carried out some time ago by Jens Overgaard in about 10,000 patients from various trials pooled together showed that the benefits are not overwhelming. And therefore, some of these things have not been a mainstay in the radiotherapy. Besides the hypoxic cell sensitizers, there are also other classes of sensitizers, simply because not all tumors are resistant to radiotherapy because they're all hypoxic. So hypoxic as well as non-hypoxic tumors are resistant, of course, hypoxic to a little great extent. But indeed, due to a number of reasons, inherently, the tumors are also resistant to radiation. Of course, the degree varies. So besides targeting only the hypoxic tumors, there have been interest in developing sensitizers that will elicit a stronger response to radiation in the tumors. Amongst the non-hypoxic cell sensitizers, the ones that enhance the damage induction has received a great deal of attention. They are typically the halogenated pyrimidines, analogs of the thymidine, 5-bromodioxyuridine, iododeoxyuridine. The mechanisms I have written in the blue here, the mechanism underlying this is when these are incorporated in the DNA, then the strand containing these halopyrimidines are more susceptible to radiation-induced damage because of the underlying chemistry. And the second advantage is these get incorporated only when the cell is synthesizing DNA. Therefore, if you give it in a system, predominantly, not entirely, to a very large extent, it will go to the proliferating tumor cells, much less to the surrounding non-proliferating normal tissue cells. And this was considered very ideal for brain tumors because you have hardly any proliferative activity in the normal brain, unlike other tissues which have varying degrees of proliferation with minimal to some amount of proliferation in some of the tissues. And of course, the amount of sensitization linked to the amount of enhanced DNA damage is linked to the amount of halopyrimidines that you can incorporate. In vitro studies have shown at least 2 to 3 cell generation times these need to be present in the culture so as to load enough of these halopyrimidines to cause appreciable increase in the damage. Since they enhance the DNA damage, with the existing repair, the residual DNA damage is still high as compared to the absence of these halopyrimidines, and therefore all the consequences ensue, resulting in more mitotic and interface death, and therefore cell kill. And they also interfere to a certain extent in the processing of DNA lesions. Typically what they do is they enhance the SSA and DSA, single strand breakage level and double strand breakage level. When you do the dose response with and without these halopyrimidines, you will see that the slopes for the halopyrimidines are up as compared to the absence of halopyrimidines. A number of other small molecule chemicals have been under various degrees of clinical evaluation. That means in phase 1-2 trials in different malignancies. We are yet to see the outcome of all this. And similarly, at the preclinical level, a number of cellular processes and their regulators using small molecules and antibodies have been under investigation, including targeting the microRNAs, which play a role, which are established to play a role in the radiation response. They're all at preclinical, different levels of preclinical stages. Now I'll switch to the work that we have been indulging in, the area of radiosensitization of tumors, which also, of course, comes with the sparing of normal tissue, if not protection. And the rationale is from a host lot of data available from different cell lines generated under different conditions of reprogramming of metabolism. Maybe I should, yeah, I'll put this slide and then come back to that slide. The rationale was many of the tumors show an altered metabolism. All tumors show reprogramming of metabolism. The reprogramming is precisely, of course, besides other things, dominantly and profoundly in the form of enhanced aerobic glycolysis. That means to be able to consume and utilize glucose more, even in the presence of oxygen, as compared to normal cells, the counterparts, usage and consumption. And this is called the aerobic glycolysis. Enhanced glycolysis, even in the presence of oxygen. And several studies in the last few decades have shown tumors which have both OXPHOS as well as enhanced glycolysis are actually more resistant. Warburg was of the opinion that it's because of the compromised OXPHOS that the glycolysis goes up. And that's where he probably erred to a certain extent. But then that tumor cells have an enhanced glycolysis, has withstood the ground, and have as also the basis for the FDG PET scan in identifying and grading the tumors. So much so that the reprogramming of metabolism is driven by several factors, including oncogenesis. Concomitant to oncogenic transformation, you have changes in the glycolysis, as well as several environmental compulsions, including in case of solid tumors, the hypoxia. The hypoxia leads to HIF buildup, and HIF is a transcription factor which controls several genes in the glycolysis and therefore enhances glycolysis. Of the several things that it does, we will probably see in the next maybe 1 or 2 slides, that it confers resistance by reducing both interface and mitotic death. Let me go back. And as I said, we looked at the relationship between the glycolysis status and response to radiation damage. What we found was lesser the glycolysis. On the x-axis is the glycolysis. Therefore, towards left is decreasing glycolysis. Towards right is the increasing glycolysis. On the y-axis is the manifestation of damage, either in terms of loss of clonogenic ability or cytogenetic damage induction, so on and so forth. What you will see that more the glycolysis, the cells are protected or conferred resistance against radiation damage. Lesser the glycolysis, they are sensitized to radiation damage. Now, using inhibitors of glycolysis, you could achieve sensitization. By stimulators of glycolysis, in principle, you can confer resistance to them. And Anant and his group are looking at permissible ways of transiently manipulating the metabolism to be able to protect the normal tissue from radiation-induced damage as a strategy for radioprotection or blink mitigation. Some of the things they are looking at is the IL-6 mediated stimuli. IL-6, by the way, stimulates glycolysis. Several other things which, when translated into a practical approach, can probably be exploited to function as a metabolic reprogramming based modifiers of radiation response. I will probably not touch upon some of these things later. We'll come to that later. Reprogram. Right. Because tumor cells have more glycolysis, there was a great deal of interest in using them as primary antitherapeutic, which did not stand ground due to a number of reasons. Because as a therapeutic, it is not efficacious, because in the pancreatic and other tumors, it did not elicit good response. But because of the need for continuous infusion, it created problems in the excitable tissue, which depends more on oxidative phosphorylation in a glucose-dependent manner, typically the brain, and also the heart with the diaphoresis and cognitive disturbances. Therefore, using glycolysis inhibition as a therapeutic strategy had to be abandoned. Now, we then opined that instead of continuously disturbing, suppressing glycolysis, what we can probably do is disturb the glycolysis only during the time when the cell is engaged in damage response pathway that kicks in soon after irradiation. You don't give it continuously. You irradiate, then the damage response pathway is operative for some time. In that period, you modulate the glycolysis, then the consequence could be altered. This is the underlying biochemical basis for the disturbance of glycolysis metabolism by 2DG, and likely difference between a normoxic cell and a cancer cell, or a normal cell and a cancer cells, because cancer cells have more glucose uptake and utilization, and therefore the metabolic block created by this analog after its phosphorylation should be more profound in tumor cells as compared to the normal cells. So therefore, we opined under these conditions, they should be more effective. Indeed, this was investigated in a number of model systems containing several human tumor cell lines as monolayers, organ cultures, and also spheroids, which I have not listed here, in animal tumors and in normal animals, and also clinical studies, which showed indeed when you administered this glycolysis inhibitor, compromises the repair in the tumor cells, enhances both mitotic and interphase death, that is mitotic and apoptosis, leading to better local tumor control, minimal effect on the normal animals, and very good tolerance and minimal toxicity when combined with radiation in the clinical scenario. The mechanisms underlying modification of cellular radiation response as well as chemotherapeutic response has been understood to a very large extent, goes beyond just the repair and the cell death. It can cause the cell death due to a number of signaling pathways affected. One of course, including oxidative stress, because more glycolytic tumor cells depend on glycolysis-linked oxidative stress defense through the NADPH predominantly, as well as pyruvate, which also functions as an antioxidant, lactate, which functions as an antioxidant. So between the now in the non-antioxidant system, the glutathione, the thyroidoxine, and others, plus the glycolysis-dependent antioxidant defense adds, and during the development of this phenotype, somehow the dependency on glycolysis-linked antioxidant defense goes up. So when such cells are suppressed with glycolysis, they become more vulnerable to damage caused in overcoming the lesions. So the thing therefore includes glycolysis and energy-dependent repair modification, the oxidative stress enhancement, and in case of 2DG, as a modifier of glycolysis, besides its glycolysis-dependent effect, which comes from the accumulation of 2DG6P, it has a bonus. 2DG also modifies the cellular response in a glycolysis-independent manner, that is through the generation of UPR response, unfolded protein response, because it interferes in the glycosylation of proteins and therefore the protein folding. That also contributes to the interface death, and therefore we have necrotic death, maybe regulated necrotic death, apoptosis, and mitotic death altogether leads to loss of clonogenicity. All these things have been extensively worked out. We then were examining the in vivo responses of tumors, only to find that in any tumor, we have worked with early societies, Dalton's lymphoma, sarcoma, 180 tumors, and we always found that out of a n number of animals given the same treatment, that is combining certain amount of 2DG with focal irradiation of the tumor, at a given dose of radiation and 2DG, the maximum that you can achieve, only a part of the tumors show a good regression, and some of them survive for almost their normal lifetime. But half of them, or something like 40% of them, sometimes 60% of them, do not elicit a response. We opined that this difference, although these tumor cells, when you query in vitro as cellular models, they're all equal. So we opined that these stem from differences in the host tumor interaction following irradiation of the tumor, typically the immune response. The ability of focal irradiation of the tumor plus 2DG in eliciting an anti-tumor immune response leads to better tumor control. In such of those animals where this doesn't happen to a certain extent, it does not elicit a good local tumor control. We pursued this and showed indeed enhanced anti-tumor immunity contributes to the radiosensitization. And we have now shown the immunosuppressive network consisting of Treg, MDSC, and so on and so forth are all attenuated to a very large extent. And then this happens also because of the repolarization of the macrophage towards M1 phenotype that facilitates the acquisition of the anti-tumor immunity. This is an overall summary figure showing that the tumor, because of the M2 phenotype and immature disease developing, and with a predominant Th2 and Th7 mediated functioning, develops immunosuppression, as also driven by mainly by T regulatory cells that increase with the tumor growth, that is induced T regulatory cells that suppress the immune response, together with the dominance of Th2 and Th17, leads to the progression of tumor growth and also resistance against radiation. Now you intervene with 2DG, then you alter many of these. And as I showed in the previous slide, it switches to Th1 domination from Th2 and 17 and macrophagic polarization, and then the reduction in the T regulatory cells, both at the tumor site as well as in circulation, that contributes to the sensitization. This is macrophagic polarization. We then went on to examine that if this happens, then, as was originally proposed by Warburg, which has not been tested, that the interplay between the altered metabolism and the development oncogenic process actually takes place, so much so that the altered metabolism drives the complete process of tumorigenesis. So we then said we should be able to attenuate this if we have these animals on the diet after initiating the tumorigenesis, either using chemicals or inflammatory response or high fat or radiation to this in the skin model. You initiate this or implant the tumor cells, initiate the tumor cells by chemical or radiation or from inflammatory process, then come back and systemically modify the glycolysis by put in 2DG as a component of the diet. And we showed that the growth of implant tumor is compromised by contribution from a number of underlying mechanisms, and it inhibits inflammation and chemical and radiation-induced tumorigenesis, shown here, 3-methylcholanthrin, including leukemia and skin tumors. The DMBA impedes papilloma, and radiation-induced angiogenesis and tumor-induced angiogenesis are compromised when the animals are on diet. And therefore, if you have completed a course of therapy and there are some remnant tumor cells that were not killed by the entire course of therapy, which will then now bounce back, facilitated by the tumor microenvironment and the systemic interplay, could be attenuated if these animals are put on 2DG containing diet, which will compromise the angiogenesis besides other things that I showed in the previous slide, and therefore attenuate the regrowth of these tumors. This is something that we are moving forward to establish this with tumor growth and contributing factors that were hypothesized to establish before contemplating designing of clinical protocols. This is an overview of the clinical trials where we, a classical radiotherapy protocol, but altered fractionation. The daily fraction, the classical radiotherapy is 2 gray per fraction, 5 days a week to 6-7 weeks, depending on the tumor. We came up with an altered fractionation, which is only once a week with 5 gray to the tumor. This is done in brain tumors. Combined with 2DG, we phase 1, phase 1B, which is dose escalation for optimizing, and phase 2 single arm efficacy studies were all completed. And all of these show a significant improvement as compared to radiation alone, as compared to 17, 15, 21 that you see here with radiation alone, which was the standard of care when we did the clinical trials 10, 15, 20 years ago. The median survival was only 9, maybe 10, 11 months. With the standard of care today for brain tumors, which is temozolomide plus radiation, the median survival is about 17 to 18 months. But when we probably combine it with the standard of care and 2DG, it should go beyond that. But the most important thing than the survival is an excellent quality of life shown by the brain score. And also this is pharmacoeconomic wise very, very favorable. So this, now there is focus on designing protocols for using this combination in the treatment of other site lesions at other site, including pancreas, maybe prostate, breast, other head and neck, and liver cancer. So soon we should probably be revisiting all this. Now, the taste of the pudding, as I said, is in eating. We had a very good example from one of the clinical trial centers in the phase 2, where Dr. Venkatramana, who is a neurosurgeon at the Manipal Hospital in Bangalore, had a patient who received this combined treatment, and due to some clinical deterioration, he was explored to see if it has anything to do with regrowth of the tumor. To their surprise, they found that it was not linked to that. The re-exploration showed enhanced tumor necrosis, but combined with well-preserved normal tissue adjoining the tumor, which is the preserved choroid plexus. This looks like a very normal choroid plexus. They were so excited and so others. Some of these are published in Asian Journal of Neurosurgery, this particular work, and related findings. If anybody is interested, they can go ahead and look at it. So I don't think I want to go over it again. And I think I'll stop this, and we'll be willing to take questions if the audience have.
Thank you, Dr. Dwarkanath, for such an excellent and elaborate presentation. and we came across several facts and several of your discoveries related to radioprotectors and radiosensitizers. I see there are some questions in the chat box, as well as few participants have raised their hands.
Yeah.
So, Palak, you have any question?
Yes, sir. Good afternoon, sir. Sir, I want to ask, what is the difference between tumor control probability and the tumor control dose?
Tumor control probability
And tumor control dose, that is TCD50.
Like you have to be louder.
Am I audible now?
Yes.
Sir, I wanted to ask, what is the difference between your tumor control probability and TCD50, tumor control dose?
Yeah, TCD50 is as the parameter itself say, it is the tumor control dose 50. That means if you treated 100 animals with tumors, what is the dose that will elicit a good response? That's the TCD50. Tumor control probability is what is the probability of response at a given dose? What percentage of the tumors will respond at a given dose? Tumor control probability will also, what is the probability that you can control the tumor? Control the tumor means what? You have to say, control means I want to control the growth of tumors in all the animals. I want to control the growth of tumor in about 50% of the animals, 10% of the animals, 90% of the animals. You have to define what is your tumor control. The other one is to look at, these are possible only in vitro. The tumor take is something that you can do. You give it a treatment, whether varying doses or different combinations, come back, take the tumor and initiate the tumor and ask a question, what is the dose that will not let the tumors be remade in 50% of the animals? Conversely, what is the dose, what is the treatment at which 50 or more will make the treatment? That is also one way of looking at the control. But clinically, with any of the observable parameters, the tumor control probability is always as a given dose. TCD50 is a dose that will elicit whatever response that you define in 50% of the subjects or animals or in 50% of the tumors.
So, sir, if like I understood the difference. So, if I want to see whether my treatment is affecting the tumor growth, so should I look for the tumor growth delay or the TCD50?
I would, to begin with, yeah, please complete. You had more question, yeah? Go ahead. Continue. You were saying something.
Is
I
the
thought.
voice coming?
Hello?
Hello?
Was your question complete? I thought it was still to be completed. Maybe we lost her or what?
No,
Between you were not, our internet connection is not stable. Yeah.
Like you can repeat.
Sir, actually, in few of the
Yeah.
papers, I saw that there is some function called logit for the calculation of TCD50. Since I'm new to this TCD50 and TCP, so I was not able to understand that how should I use the function logit for TCD50.
This would probably take a little illustration with either a slide or a pen and paper. Can we defer? If this is a question only to you, we will defer this. But your question before you be broke, you're asking whether you should look at growth delay or you should look at tumor control probability.
Yes,
I think that was
sir.
one of the question you had.
Yes, sir. Yes, sir.
To begin with, I would suggest, at least under conditions where you expect, at least some extreme conditions, do a tumor growth response as a function of time following your treatment vis-a-vis a reference treatment. Suppose you are investigating a drug that will alter the radiation response. Let's say that is the paradigm. You are investigating a drug as a good radiosensitizer. Okay. And you would, how do you say that it's a sensitizer? When you compare to radiation alone, it has elicited a good tumor response. The next question is, what is a good tumor response? If you look at the tumor growth curve, that means growth of tumor as a function of time, and you irradiate, following irradiation, after the tumor are palpable, you come back and irradiate. What do you typically observe? You observe that if the dose that you gave, the type of radiation, the dose you gave had hardly any effect on the tumor would continue to grow, overlapping on the curve for the control, right? That's the worst. And in such of those tumors, or under such conditions where it elicited a good tumor response, the response here being death of tumor cells, would then result in reduction in the tumor volume, because what you are going to measure in all this is a tumor volume. Correct? Either using a measurable way if you have implanted in certain places. If it is orthotopic and inaccessible, you will have to resort to several other methods, for example, in vivo imaging, non-invasive imaging, depending upon what is irrespective. If you can get an estimate of the tumor volume before and after treatment for various time intervals, then you can see whether the tumor started shrinking and shrunk completely and never regrow. And if you looked at the animal for a long time, the tumors never came back and the animals were happy. And that is classically a cure. A cure is nothing but a disease-free state. Here the disease is tumor, and if the tumor never came back, whatever tumor was there is gone, that's the cure. What is the other thing that can happen? The tumors may regress and stay regress and then may regrow. And let us say once the tumor reaches a particular size, the animal dies, which is synonymous with tumors growing to a certain size, the patient succumbing due to a number of systemic consequences. Same is true here. Now what you have done, if you did not irradiate or irradiated with minimal effect, a death linked to tumor size will occur at a certain time. When this is deferred, growth delay, let's say the same response will occur now at a delayed time. Typically, the parameter that is calculated is what is the time that is taken for the volume to either increase 5 times or 10 times, depending upon the tumor condition. And you need to keep in mind the permissible ethical guidelines. You should look at the European guidelines that are available when you are working with animal tumors, depending on the animal weight and the tumor weight that is permissible. Therefore, you cannot let the tumor grow till they die. You can establish. So you can either, that's called the partial response. You can get the tumor growth delay. If it is cured, you can ask a question, what percentage of the tumors got cured? Okay. Now, the other one is to look at the tumor control probability. You can now, from these growth delay parameters, under different conditions, if you did this, then plot these values as a function of dose. If you collected these data at different doses or different paradigms that you have, then you can get what treatment elicited a comparable delay response in 50% of the animals. What treatment elicited a cure type of response in 50% of the animals. These are some of these things that you can do. To probably discuss more in detail, you are in Dr. Vibha's lab?
Yes, sir. So
we could probably do this on a more detailed scale later. Would that be fair enough?
Okay, sir. So I have one more question. Sorry,
there is another question.
It's left to the chair.
Okay.
There are some other questions, so you can discuss with Dr. Dwarkanath later, as he has readily agreed that he will spare some time for that.
Yeah.
Komal Rani has written, sir, that amifostine is a prodrug. What is the mechanism of its activation? Is it activated by the interaction with the non-malignant cells?
As I said, it is taken inside through the alkaline phosphatase. I think I had that slide which I can pull up, and then converted into 1065. 1065 is the active drug. Yeah, I did have that, I guess.
Yes, I remember you have shown.
Yeah, I did have this. I would be able to pull that out. But in brief, it actually is, yeah, the active component is the 1065 through dephosphorylation by the alkaline phosphatase expressed on the cells in various endothelial system.
Yes. So I think that answers the question. Alkaline phosphatase mediated activation is there, where active thiol
1065 is generated, and that affords actually the protection. And in case of the analogs that we worked, it appeared that this activation is not a strong requirement. It appeared like that.
So, Professor Bhimatendon, now I think we have.
Sir, I want to ask one more question.
Yes, please.
Sir, you have mentioned that enhanced glycolysis will result in resistance in the tumor cells. And you are also mentioning that we provide the glycolysis inhibitors. So, sir, it will not affect the normal cells too, if we provide the glycolysis inhibitor in the body?
For sure, yes. And I also said at the end that under conditions that it sensitizes tumors and elicits a local tumor control, enhanced local tumor control, which was evident clinically, it also preserved the normal tissue. Your question is, if it also does the same thing in normal tissue, how come you have normal tissue preserved, normal tissue protected? There are several contributing factors. Let us look at only the 2DG and the mechanisms of a differential response, potential difference response between the more glycolytic tumor cells and the less glycolytic or normoglycolytic normal cells. Those processes which lead to compromised cell functioning, cell signaling, sometimes resulting in death or sometimes resulting in altered function, which are all energy dependent processes, their level of dependency is not the same. Different processes have different dependency. Now, in the normoxic cells, the extent of energy fall, besides other processes that are altered, I'm only talking from the energy point of view linked to glycolysis, is different than in a cell which is predominantly dependent on glycolysis. And therefore, the processes sometimes may actually shift to a energy domain where those processes are facilitated than being compromised. This is one possibility which we have shown in certain cases. The other thing is the normoxic cells have their defense mechanisms restored, retained, especially towards oxidative stress and the downstream signaling, as compared to more glycolytic cells which would have evolved during the tumorigenesis, which are more dependent on glycolysis-linked defense system. Therefore, the extent of effect on the normoxic cells is much less compared to the glycolytic cells, more glycolytic cells. The last one, the kind of UPR responses may also not be very identical. So all these things are expected to contribute individually, minimally, collectively, moderately This is number one. Number two, when we talk about radiation damage modification, by appropriate radiotherapy protocols, you can reduce the dose and therefore the ensuing damage to the normal tissue as compared to the tumor tissue, and therefore make it more favorable, less damage and more minimally reduced energy level, and the implication on energy linked recovery processes, which will probably are favorable. If these things were not operating, you would not have less bone marrow damage in normal animals that we have shown, which I showed in that overall photo, overall table of cell cultures, animal tumors, normal mice, and clinical. So we have seen that the bone marrow damage in terms of cytogenetic damage is less in animals receiving 2DG systemically. In the splenic lymphocytes, we have seen that there is marginal decrease in the splenic death. And in the clinics, as you saw, the tumor necrosis was accompanied by preserved normal brain tissue. This could be because of less radiation dose to the normal brain, plus, of course, the effect of the altered signaling in presence of 2DG.
Sir, so you have mentioned that about the defense mechanism of the normal cells. If I am talking about the 2DG mimics not only the glucose but also the mannose that alters not only the glycolysis but also many other processes, glycosylation, causing both energy depletion and cellular stress.
Absolutely.
So sir, through this only defense mechanism, this normal cells are escaping itself from this 2DG?
No, what was your background was excellent, but what was your question at the end?
Sir, my question is this: how the normal cells is sir, I wanted to ask that this 2DG is affecting most of the other processes too. So
yes,
is this 2DG is safe for us?
Yes, of course. The COVID patients have taken, and you are not even having any infection or disease, you should be happily be taking if you are confronted. And I must also mention that studies in the National Institute of Aging have evaluated administering 2DG at very low doses to animals extended over a period of several months, and showed the animals on the whole stay lean, metabolically more active, physiologically more competent, and live longer.
Okay, sir.
Yeah?
Thank you, sir.
Yeah.
Yes, sir.
Okay. Anyone has any other question?
Yeah, sir, even I wanted to ask about the 2DG.
Yeah.
So what were the responses about the 2DG when it was used in the COVID? So did you get any feedback? Because I know that number of patients have taken, but probably no data would have been created because
this probably would be left to Dr. Anand to respond. It may not be prudent on my part, because not because of anything else. The data, they're still over and over what is available on the public domain. The other things are still being analyzed. I think they have very encouraging data that is upcoming. What exactly is it? What level of infection? And what was the exact? It will be prudent on Dr. Anand's part to answer you this question.
So
at least not.
Yeah. So, sir, there is always a query most of the time that which molecule should be called radioprotector, radiosensitizer, and radiomitigator. I know that we give
protector and mitigator. I can easily answer, probably, which I didn't do a good job during my lecture. A protector, by definition, is an agent which, when administered prior to exposure to radiation, can reduce the radiation-induced injury to the biological system. A mitigator is an agent which, when administered post-exposure to radiation before clinical manifestation of the consequences reduces the injury and the consequences. This is mitigator. Now come back, protector and sensitizer. You're asking about protector and sensitizer.
Yeah.
Right?
Yes, sir. Yes.
I thought you had the best example. I mean, not the best. You had one of the very good examples.
I have, but I'm asking for me also and for the students also.
No, one of the good examples,
I
I can take two examples. One of the good examples is the compound that you worked with, which due to its ability to modify the radiation, underlying radiation chemistry that causes the macromolecular damage, would afford protection. However, because of its undesirable biological consequences, may compromise that very protection that it affords. When this biological undesirable effect outweighs the desirable radiochemical manipulation, you had sensitization. As we showed in case of sensitization of Ehrlich ascites tumors, same ligand sensitizing tumors to different doses of radiation. While in vitro, at low doses of radiation, still the induction of damage was reduced, but the repair of damage was compromised. This is one. The second thing is, independently of its manipulation of the damage response, in case of the ligand, it interfered with the functioning topoisomerase that compromised several things, including the DNA transaction, your RNA transcription. Your life depends upon the integrity of DNA transaction. If that is compromised, eventually, although you reduce the radiation damage, which was only for a short period of time, you have sustained biological consequences. Together, the overall outcome probably could be undesirable. Where you did not get into that realm, you would realize the protection. As we showed, in normal mice, low levels of 33342 can enhance the survival. But again, if you go to a little higher dose, it starts compromising, suggesting that you are embarking on the biological realm where it is compromising the outcome.
Okay.
Vivaji, any other question?
No, sir, I have.
Okay. So, thank you very much, sir. I think now
pleasure.
You have clarified all the doubts related to radio protection and radio sensitizers, and nicely explained with the various examples and facts and findings from your lab as well. And I also came to know about the contribution of Professor Uma Devi. You rightly mentioned about the Tulsi, and now how we have forgotten that, we are not working on that. And the plant is having very great potential to.
Probably it is not forgotten. It's like it's in it. I would say it has gone to dormancy. I do not know when it will come out, because Pawan and ourselves did this work, including some industries roped in, to be able to make capsules from this to be evaluated. As I said, it has, like Rudiji was also think maybe some other disease would come and then it would kick the Tulsi thing into the fore, and maybe it will pick up, sir. We probably should wait for another pandemic, maybe.
Sir, related to the questions which were asked.
There's one question. Dr. Badrusen is there, but Komal is, we should welcome him, but Dr. Komal wants to ask one small question more. Should we allow her?
No, but Dr. Vikram is there. I think we should probably go ahead.
Okay, Komal, let us ask it later. Dr.
Tomorrow I'm here anytime.
Yeah.
So thank you very much, Dr. Singh.
Thank you, Dr. Dwarkanath, for an excellent lecture and your time as well. Thank you very much.
My pleasure, sir, always. Thank you.
Thank you, sir.
Dr. Badrusen, he opened his video, then he's here. Hi, very good morning to you. We cannot hear you. You are muted.
Okay, how's that?
Great. Can
you hear me now? Yeah.
Yeah.
Yes.
Okay.
So we have here as a chair of your session, Dr. Rana Pratap Singh, who's a oncologist and radiation oncologist, and your old friend, Dr. Dwarkanath. Can you see him?
Yes, of course.
Namaskar, sir.
Namaskar.
So nice to see you after a very long time, sir.
Yes, COVID has made traveling very difficult.
Very difficult. I know it has made everything very difficult actually. Is my sharing stopped or is it still going on? I don't know.
No, it is not stopped.
Oh my God, this is something that I always have a problem in. Pause share. I will. Yeah, now I can find. I hope it is stopped now.
Yeah.
Okay. Good enough.
Thank you.
So before Dr. Rana Pratap Singh will actually he will do the honor, but I just wanted to inform Professor Rana Pratap Singh that in the GIAN program, the foreign faculty who is like approved is Professor Vikram Bhadrasen, and so he could not come physically because of the pandemic and all those things. So he was very kind enough to agree a couple of lectures. So he is the one of the approved faculty by the there, and it's honor to have it here. So now Dr. Rana Pratap Singh can do the honor.
Dr. Bhadrasen, it is an honor for me to welcome you here at the GIAN program. And this is a wonderful effort by Professor Viva Tandon, that many of the participants from JNU as well as from other universities and institutions, they are getting exposed to this very important topic which we are discussing. And now we are here to witness as well as gain some knowledge from your expertise. As you said that you are supposed to come here, but we are missing your lecture in person. Otherwise, the interaction will be very lively. That was what the participants were expecting. But this online program is a breather for us that we are able to continue and conduct many activities through this platform. So now it is again my privilege to welcome you for this 12th lecture, which is on radiation medicine, past, present, and future. And I think we are supposed to end it by 6 p.m. So we'll have some time for the question answer by the participants. So thank you very much, sir. Over to you, sir.
Okay. So the first surprise is that I'm not going to show any slides. Dr. Tandon was kind enough to give me 2 hours. When I accepted this, I did not know that at this moment I will be in California. So I'm 12 and a half hours behind you. So in fact, the time is...
Oh my God. Oh my God.
So the time is 3:30 in the morning.
3:30 in the morning. You're in California. Okay.
So anyway, a 2-hour lecture, I think, is a good way to put most people to sleep. And so I think what we'll do is I'll keep it short, but I'll open it up to questions so that at least I don't fall asleep if you keep asking me questions. How's that? Okay.
Yeah, so you can first tell a few things about you and your research. That would be better. Then you can start.
So first clarification is that in my professional career, I'm known as Dr. Vikram and not as Dr. Bhadrasen. And it's a long story how my name came to be switched. And it will cost any of you a cup of tea or a glass of beer. I'll tell you the story in person sometime. But I am known in my professional circles as Dr. Vikram. So I grew up in Delhi and went to Maulana Azad Medical College. That is to remind me to wake up. My alarm just went off to remind me to wake up. Okay. And I then went to England, where I got interested in oncology. And after 2 years in England, I joined my residency in radiation oncology at Memorial Sloan Kettering Cancer Center in New York, where I finished my residency and then stayed on the faculty for about another 10 years, following which I joined as a professor at Mount Sinai College of Medicine, subsequently Albert Einstein College of Medicine, where I was chair of the radiation oncology department, until September 11, 2001, when it was a very traumatic time in New York, as you might imagine. At that point, I decided to go out and save the world. So I decided to go and work for the United Nations, and the agency that I was fortunate to be able to join at that time was the Atomic Energy Agency in Vienna. And so I was working there for a few years to help build cancer clinics in less developed regions of the world, particularly sub-Saharan Africa and Central America, East Asia, etc. And since 2006, I have been at the National Cancer Institute in just outside Washington, DC, where I oversee clinical trials involving radiation and multimodality therapy. So I'll talk a little bit about the past of radiation therapy, as Dr. Tandon asked me to do. And I'll talk a little bit about the present, where I think we are a little bit stuck. And the future is up to you, the students. We need some fresh ideas. You heard some from Dr. Dwarkanath, and I think we can use many more fresh ideas. So let me go through, some of the points that I wanted to make, and then we can, as I said, I would like to make this an interactive session and have mainly question and answer kind of format. So there are people who are lumpers and splitters. I'm a lumper. And so cancers I broadly divide into 3 categories: small, medium, and large. Okay. And most of the talk will be about medium-sized cancers, that is more technically called locally advanced cancers, where radiotherapy has played an important role and continues to play an important role. For the small cancers, in fact, we are able to cure quite a few of them. Medium-sized cancers, we can only cure a few of them. And by large cancers, I mean the cancers that have already metastasized to other parts of the body, and where the role of radiotherapy has been just basically palliation of symptoms, and cure has remained elusive. So generally, you give drugs for those cancers, and radiation is used just for spot radiation to relieve pain or to stop bleeding or obstruction, but no real expectation of cure. So as I said, most of the talk will be dedicated to early and medium-sized cancers, but it is worth pointing out that for the advanced cancers, the widespread cancers, one of the first curative treatments was in fact involving radiation, and that's for leukemias. The leukemias are widespread. They involve the whole bone marrow. And back before there were effective drugs for leukemia, Donald Thomas, back in the 1960s, started thinking about, how about if we radiate the whole body? And of course, we had already learned from the experience in Hiroshima and Nagasaki that radiation to the whole body, is not is fatal. But he tried to push the limits, and he came up with the concept that you could actually destroy the whole bone marrow by giving supra-lethal doses of radiation deliberately. So you would destroy the leukemic cells, but you would also destroy the normal bone marrow. And of course, the patient would then die unless you were able to rescue the bone marrow by providing an allogeneic bone marrow transplantation. Now, of course, we know a lot more about stem cells, but back then, a lot of this was not known. The immune suppression was still very much in its infancy. But he took this bold step of giving high doses of radiation to the whole body and then rescuing the patient from death by giving a bone marrow transplantation. And in fact, he was able to cure some patients, especially children with leukemia. And for this, he received the Nobel Prize eventually. So there is a history of using radiation for widespread metastatic disease, such as leukemia. And I'll come back to that in some of the hopes for the future, that radiation maybe in the future can play a more important role even for widespread disease. Whereas in the past and for the present, we are largely limited to early and medium-sized, locally advanced, but not metastatic tumors in terms of what we can do. Now, the whole body radiation, as you might have heard from some of the other lectures, produces hematological toxicity. If you can manage to survive that, there's also gastrointestinal toxicity, and supportive care can guide people over that. And if you survive that, then you develop other kinds of toxicity. And particularly in the case of total body radiation for leukemias, the next limiting toxicity was pulmonary fibrosis. And that is a problem that we still haven't been able to overcome. And the dose of whole body radiation at this moment is largely limited by the tolerance of the lungs. So even it is used still in bone marrow transplantation programs for leukemia and some other diseases, but the doses to the lung has to be severely limited. And that's where some of the current innovations, a group at City of Hope that we are funding, for example, they are looking at total marrow and lymphoid radiation using modern techniques of conformal radiation therapy to the whole body, but avoiding doses to some critical organs like the lungs. So this is an area of active research. As I said, there are many more drugs now available for leukemia, so this is not used as much. But certainly for some kinds of leukemias, particularly acute myeloid leukemia, failure to control the leukemia still remains the major cause of death. And there is still room for innovation there in terms of how we protect the normal tissues like the lung and how we increase the dose to the bone marrow that is housing or the source of the leukemic stem cells. Okay, so much about leukemia, and as I said, we'll come back to metastatic disease towards the end with regard to some of the future potential applications of radiotherapy. So let's talk about localized disease. So when a cancer is localized, there is the possibility of curing it with radiation. But it's amazing the range of sensitivity that cancers exhibit. And to make a long story short, we have no idea why some patients can be cured with a relatively low dose of radiation and other patients cannot be cured even with a very high dose of radiation. So a good example of cancer that we can cure is early lung cancer. For a cancer which is the size of a rupee coin or smaller, I would say today with stereotactic radiation techniques, a single dose of 34 gray can cure most of these cancers. A single dose of 34 gray. On the other hand, for most cancers, you need higher doses than that. And even those are not consistently successful. So the range goes, for example, for seminoma, which is again a highly curable cancer with radiation, or some kinds of lymphoma, which are also highly curable when localized. Only 20 to 25 gray can cure the cancer. For cancers of the mouth and throat, especially of the oropharynx, which are HPV positive, we think we can cure them now with doses of between 50 and 60 gray. That is usually, these are all given fractionated in order to reduce the toxicity to the normal tissues. The small lung cancers are an exception that you can give it the whole dose of the single fraction. and the amount of damage that you will do to the lung tissue is limited because the volume is limited, and the person can survive that and function quite well, even with that amount of damage to the lung. But for most parts of the body, the volume has to be larger, and therefore our ability to give a single dose is limited, and you have to fractionate the radiation in order to protect the normal tissues. So with fractionation, as I said, for seminoma, you can cure them with 20 gray. For HPV-associated cancers of the oropharynx, you can cure them with 50 to 60 gray. But cervix cancer, the uterine cervix cancer, which is also an HPV-associated cancer, here you need doses of 80 to 90 gray. Okay, we have no idea why there's such variation between oropharyngeal cancers and cervix cancer, even though the etiology is the same, which is human papillomavirus. So this is one of the mysteries that you people need to solve in order for us to make further progress. And for prostate cancer, we treated by brachytherapy, and we gave doses of 125, 150 gray. So there's a huge range of doses that we apply, and almost all of these have been empirically derived by trial and error. A lot of patients have suffered side effects in the process. Thousands and thousands of patients have been enrolled in clinical trials. And still, for the other than the very small cancers, our ability to cure the cancer is limited. So some cancers you have 30% tumor control rate, some cancers you have 50% tumor control rate, some cancers you have 70% tumor control rate. And there are cancers like glioblastoma where we have 0% tumor control rate, even though we have tried giving doses of 70, 80 gray to the brain. So there is this huge variation. And frankly, we have no idea why there is such variation. So I think this is one of the great mysteries that cancer biologists and radiation biologists have to solve in order for us to make progress in the future. Now, the driving force behind most of the innovations in the last 100 years, and actually it's more than 100 years because radium was discovered back towards the end of the 19th century. And also X-rays were discovered about the same time by Röntgen in Germany. And people started using radiation pretty soon after. Radium needles were made and stuck into cancers, and external beam radiation started shortly thereafter. So we've been using it more than 100 years. And by trial and error, as I said, we have managed to cure many patients with early cancer and some patients with locally advanced cancers. But we really have no idea of the fundamental biology, why some patients are cured, why some cancers are cured, and others are not. And I think it's important, for the radiation biologists of the future to get out of the lab sometimes and go to the pathology lab and learn to deal with human tissues, because the human tissues live in a dynamic microenvironment. And while animal models have their place, ultimately there is no substitute for in vivo studies in humans. And I think that's tricky, that's ethically challenging, but I think that's where the answers are going to come from. So I hope that the radiation biologists of the future will be trained in dealing and comfortable dealing with human tissues as well as mouse tumors and mouse physiology. So, but anyway, I think we are reasonably certain that any living organism can be killed if you give them enough radiation. Even there are some bacteria, as you know, which are quite radiation resistant, but ultimately you can kill them if you give them enough radiation. And multicellular organisms are actually much easier to kill by radiation. And as you all know, too great to the whole body for a human is fatal. So we know that any living cell can be killed if you give it enough radiation. So the overriding paradigm for radiotherapy in the last 100 years has been, how can we give a higher dose? And this has been driven largely by physicists and engineers. And they have made some amazing advances in being able to focus the radiation beam with different kinds of radiation, whether it's photons or electrons or protons or heavier charged particles like carbon ions. So they have done an amazing job, but it is limiting because all you are trying to do is localize the beam to the tumor area while minimizing exposure to the normal tissues as much as possible. But clearly, for other than tumors which are located on the skin, you have to go through normal tissues in order to reach the tumor. Whether it's in the brain or the pancreas or the pelvis, you have to go through a fair amount of normal tissue. Now, by coming in from different angles, using VMAT and arc therapy, you can minimize the dose to any particular segment, but still, you are giving a fair amount of radiation to the normal tissues. Anyway, so the paradigm has been, let's give higher and higher doses to the tumor, and let's develop more and more elaborate machines. And of course, the cost of those machines has also gone up. Now, a proton therapy unit costs tens of millions of dollars, and a carbon therapy unit costs hundreds of millions of dollars. So all these technological advances, have caused some improvements, and I would say, especially with regard to intensity modulated radiation therapy, things like gamma knife or Cyberknife and protons, the major benefit has been reducing toxicity because you can target the tumor more effectively. It has not eliminated toxicity. The benefits have been incremental, but in terms of curing the cancer, their impact actually has been fairly limited compared to when we were using three-dimensional radiation therapy back in the later part of the 20th century. Now, the push to increase the doses had some success in the early days, but more recently, we have a number of examples where, in fact, it has backfired. So patients who were given higher doses of radiation for cancer of the esophagus or lung, they have actually had a worse survival than the patients who were given a dose of, let's say, 50 to 60 gray. And almost certainly, this is a result of excessive toxicity. That even with all the advances that we have made, our ability to increase the dose to the tumor without increasing the dose to the normal tissues, even with protons, has not been an unmitigated success. So patients who are given 74 gray, for example, for lung cancer, had a worse survival than patients who were given 60 gray in one of the randomized trials that we sponsored. And in esophagus cancer, the patients who were given 50 gray, 50, they lived longer than the patients who were given a higher dose. So higher doses of radiation have been the paradigm for 100 years, but I think we may be reaching a plateau and in fact, even a point of diminishing returns where efforts to push the dose higher actually is harming patients and reducing their survival as opposed to increasing their survival. So I think we may be reaching the limits of what physics and engineering can give us, and we have to look to the biologist to give us guidance with regard to how we make further progress for the patients. So for early cancers, we need to reduce the toxicity. And Dr. Dwarkanath talked about some of the radiation mitigation strategies. I think Ataje Prasanna also talked about that. For the medium-sized cancers, we have been able to cure some patients, but many more patients go uncured. And as I said, at this point, we have no idea why some patients are cured and some patients are not cured. And studying the human tissue, both tumor tissue and normal tissue before, during, and after radiation, I think is absolutely crucial for making progress in order to increase the cure rates for these patients without increasing their toxicity. So, okay, we'll come to the questions later. So one of the, I would say the major advance in the last 10, 20 years of the 20th century was the addition of some drugs to radiation, which increased the cure rates. And the most prominent drug in that regard was cisplatin. There are other drugs, for example, hormonal treatment for prostate cancer and fluorouracil, and more recently, immune checkpoint inhibitors, which are immunotherapy drugs targeting some of the checkpoints. But sad to say, the development there also has been very empirical and not particularly radiation biology driven. So almost all of these drugs were developed by pharmaceutical companies, or some of the early ones were developed by National Cancer Institute. Then the pharmaceutical companies got interested. And they have been developing the drugs that test them in patients with metastatic cancers. And if the drug works in metastatic cancer, then it is combined with radiation.
Can we hear him?
Was
Hello?
there a question?
Yes, ma'am.
Can we all hear him?
Yes, ma'am.
Raise your hands if you can hear.
Hello?
I can hear.
Sir, you are audible.
Vibha, I think you are out. Okay, so I'll continue. So the addition of drugs like cisplatin improved the cure rate. However, we have not been very good at identifying which patients can be cured with radiation alone and which patients need these additional drugs. So we've been giving the drugs to everybody. And of course, that also comes at a cost in terms of toxicity. And in the case of the more recent drugs, at a substantial financial cost to the patient, okay, or the healthcare system. So to give you an example, for some kinds of head and neck cancer, let's say the cure rate was 50%, and then you added cisplatin and it went to 60%. Okay, so that's a major advance, high impact papers and high impact journals. But when you think about it, 50% of the patients did not need the cisplatin in the first place. So for them, adding cisplatin is only adding toxicity and cost. 40% of the patients still did not get cured. So for them, the cisplatin, again, the cost was not worthwhile and the toxicity wasn't worthwhile. So only 10% of the patients actually benefited from the cisplatin. But because we have no way of identifying who are the patients who really need the cisplatin and who are going to benefit from it, we give it to all 100 patients. This is great for the drug companies because they get 10 times more revenue, but it's bad for the patients. And so that is another area where we need help as to identifying the patients and tumors for whom a particular drug added to radiation is necessary and beneficial. So this is an area, again, where I think we need studies with human tissues, and these have been lacking in the past, so that we can target the drug to the right patient and not to those patients who are going to be cured with radiation alone. So why do some patients only need 20, some tumors need only 20 gray versus other tumors are not even cured with 200 gray? Why do some patients suffer adverse events and others don't? We know that patients who have ataxia telangiectasia, their normal tissues are highly sensitive to radiation, but this is a very rare disease. So we don't know for the vast majority of people who don't have ataxia telangiectasia, why some of them suffer worse side effects than others. And obviously it has to be in the genes, but this is an area that I think needs research, and again, with human tissues and not only with animal tissues. So looking to the future, so we have, as I said, gotten very good at developing physical treatment plans for patients. We went from, and the radiotherapy has moved in tandem with imaging advances. And I think you either had some lectures or will have some lectures on radiation for imaging. So the early, X-rays were two-dimensional, and the radiotherapy was also two-dimensional. Then came CT scans and MRI scans. So we were able to visualize the tumor in 3 dimensions. So then we started trying to target the tumor in 3 dimensions from multiple angles and non-clopidograph beams. Now we are able to image some physiology with PET scans, and hopefully that will further refine our ability to target the tumors. But as I said before, I think we are reaching a point where the benefit from physical manipulation in future may be limited. And we can also, at least physically, repeat the CAT scan or MRI scan during the course of radiotherapy. So if the tumor shrinks, we can adjust the radiation beams to conform to the new shape or size of the tumor. If the patient loses weight, and the path length of the radiation going through the body changes, we can adjust that. So this is called adaptive radiotherapy, that by imaging the patient during radiotherapy, you can adapt the beam configuration, etc., to the new reality. But what we are ignorant about still, and we are certain that it happens, is when you give radiation, the biochemistry changes, the physiology changes, and we are not exploiting that. So there may be some tumors which may have been radiosensitive to start with, but the tumor during the course of radiation is adapting and maybe adopting new pathways, so that we need to change strategy. Maybe we need to move from photons to carbon ions, or maybe we need to move from drug X. Maybe we need to move from, can you still hear me? Raise your hands if you can hear me. I just got a weird message. Okay. So we can adapt to the anatomy, but we need to be able to adapt to both the physiology and the biochemistry. And that is where we are still very much flying blind. Almost certainly the tumor at the beginning of radiotherapy is very different to what it is 2 or 3 weeks into the course of radiotherapy or 4 weeks into the course of radiotherapy. So these adaptations, I think in future will make a difference, but will require working with human tissues and not just animal tissues. So 2 or 3 other new areas that are worth touching upon. One of them is radiopharmaceutical therapy. So as I said, with the current techniques, by and large, we have to go through normal tissues to get to the tumor. And in the case of photon beams, the beam also exits through normal tissue after having gone through the tumor. With brachytherapy, we try to put the radioactive sources in the tumor directly, but our ability to identify the margins of the tumor are limited by the resolution of the imaging. We know that tumors are not like a lump of clay. They don't stop where the CT scan shows that it's stopping. I don't know if there's any physicists in the audience, but you should close your ears, because when the radiation oncologist draws a line around the tumor and says, okay, this is the target volume, and after this is all normal tissue, that is complete nonsense, because tumors do not end like that. They always have fuzzy edges, and cancer is called cancer because it's like a crab, so it infiltrates the normal tissues all around. And there are also normal tissues within the target volume. So our ability to protect the normal tissues is limited because of the nature of cancer. So no matter how hard we try, ultimately we will have some normal tissues in the target volume that is going to get the high dose of radiation. So one smart way is to give radiation in a manner that it goes only into the tumor, and that is radiopharmaceutical therapy. The original example of this is radioactive iodine therapy for thyroid cancer. Radioactive iodine was developed in the middle of the 20th century. And because the thyroid gland loves iodine, the thyroid gland loves radioactive iodine. So fortunately, the majority of thyroid tumors are relatively well differentiated. In other words, they have characteristics which are somewhat similar to normal thyroid cells. And therefore, just like the normal thyroid cells, these thyroid cancer cells, particularly follicular types, they are able to absorb radioactive iodine preferentially. So you give the patient radioactive iodine intravenously or orally, and it goes to the normal thyroid cells and it goes to the thyroid cancer cells. And it gives a very high dose of beta radiation to the thyroid cancer. So the classical strategy was that the surgeon would remove the normal thyroid. So the only tissue in the body that was thyroid, or rather iodine avid, would be the cancer tissue. And then you give a high dose of radioactive iodine, and it'll go preferentially to the thyroid cancer cells. And so these patients could live for a long time. And so this is a very unique circumstance where a particular kind of cell has high avidity for a particular element, which happens to be radioactive. So the thyroid cancer specialists were able to exploit that for many years. Unfortunately, the more lethal thyroid cancers are more undifferentiated or anaplastic, and they do not absorb radioactive iodine. They have lost their characteristic of normal thyroid cells. So radioactive iodine does not work for the most aggressive thyroid cancer. But the principle was that if you can find a way to attract a radioactive material to the cancer cells, that should be helpful in controlling the cancer. So another example of this in the last few years was a preparation of radium, which is the commercial name is Xofigo, XOFIGO. So which was developed to treat bone metastases from prostate cancer. So when a metastasis appear in the bone, and it's very common in prostate cancer, at the site of the metastases, there is a reaction of the normal tissues. So that area attracts calcium, and radium in the body acts like calcium. So those tumor cells, the tumor cells don't absorb the radium, but the surrounding bone cells, which are reacting to the presence of the cancer, they absorb the radium. And therefore, you have a high accumulation of radium in the vicinity of those cancer cells, and they are able to shrink the cancer. And in fact, radium, given in this manner, has prolonged the life of patients with metastatic prostate cancer. So that's another example. So these are two elements, iodine and radium, that have been used in the radioactive form in order to produce remissions, and sometimes long-term remissions of cancers. So the bigger advance, I think, in recent years has been.
It's working.
the bigger advance in recent years has been, as you might know, development of monoclonal antibodies of various kinds. And these, along with the discovery of specific tumor-specific targets, they have been successful in many ways for diagnostics and therapy. And now more and more investigators and companies are trying to develop radioactive materials which are linked to these monoclonal antibodies. So the way it works is that you develop an antibody which is attracted to the tumor cells and only the tumor cells, because it's targeting a specific target on the cancer cell. And you using a linker, you attach a radioactive molecule to it. And now the antibody becomes like a transport vehicle to carry the radioactive material to the location of the cancer. And it bypasses all the normal tissues because you inject it into the blood and it goes through the circulation to the tumor area very quickly. And then if it is the right antibody with the right avidity, it'll stay there and allow the radioactive material to give radiation to the tumor in that area. And some of these are beta emitters, which have a range of maybe 1 cell diameter. Some of these are longer than a cell diameter. Some of these are alpha emitters, which have a range of less than a cell diameter, and they have to be internalized. And obviously, in the future, we're going to be trying combinations of the two. But this is actually a very smart way of giving radiation because you're bypassing normal tissues altogether. And the more successful you are in targeting the tumor and keeping the radioactive material in the vicinity of the tumor, the less side effects you have. Now, some of them eventually may break up and then they get excreted through the kidney or through the liver. But those are the technical developments that people are actively working on to improve. And there are also ways to protect the kidneys, for example, by giving amino acid infusions to minimize the amount of exposure of the kidney parenchyma to the radioactive material as it is being excreted to the kidney. So by choosing the right half-life of the antibody, the right half-life of the radioisotope, the nature of the radioisotope, whether it's alpha emitter or beta emitter. So by making these optimal combinations, I think that's a very smart way to deliver radiation, minimizing the dose to normal tissues. So I think that's a very, very promising area that requires additional research. But already we are seeing some successes, particularly for prostate cancer, for some neuroendocrine tumors, where these radioactive drugs have prolonged the lives of patients with very little toxicity compared to the usual chemotherapy, which can be very highly toxic and less effective. So that's a promising area. And because it goes all over the body, these are the drugs which I think may have a major impact on metastatic cancer in the future, where radiation in the past, as I said, has played a very limited role with regard to only palliation. And we may be able to cure some metastatic cancers as this technology evolves and develops over the next 2 years. Another form of smart radiation is what you might have heard about is neutron capture therapy, which has been around for, the idea has been around for many years. But there are some new developments in nanotechnology which make it worth taking another look. And the principle is fairly simple, that there are some materials which capture neutrons and create almost like a mini nuclear explosion within the cell. So if you have boron is one example, the classical example. that if you get boron into a cell and then you expose that cell to neutrons, even a modest dose of neutrons, then you will create basically a nuclear explosion within the cell, and that'll kill the cell. So the idea is very attractive, but there have been two problems. One is that the sources of neutrons were not very available, and these you had to go to a nuclear reactor to expose the patient to neutrons. And so the nuclear reactors are not exactly very patient-friendly environments. They happen to be in physics labs, and sterility, etc., is a problem. But the bigger problem, even bigger problem, has been, how do you get boron into the tumor cells and only into the tumor cells? So that's where the field has floundered for many years. But recently, there are two advances. One is that neutron sources have become available that can fit into a normal radiotherapy department. So you don't have to go to a nuclear reactor to get neutrons. You can get it in a hospital. And with nanotechnology and antibody technology, that it is becoming more possible to guide the boron into the tumor cells. This is still, I think, fairly early days for this new technology, but we are excited about it, and we are hoping that this is another area where low doses of neutrons, which are quite safe for the normal tissues, can be directed to tumors which have a high concentration of boron, and thereby kill only the tumor cells and not the normal cells. Boron is one compound, gadolinium is another one, and there may be others. So I think these kinds of sort of binary, radiation techniques are worth looking at, and the biological mechanisms of how neutrons and the boron lead to the death of the cell, again, are not that well understood and worth exploring. So that's another area that I think may have an impact in the future. One of the most exciting areas recently has been the development of immunotherapy. I think our understanding of the immune system has grown by leaps and bounds in the last 20, 30 years. And especially in the last 10 years or so, a number of immunotherapy drugs have become available. Now, immunotherapy works only on some tumors and not on others. And crudely, people talk about cold tumors and hot tumors. That I think these are rather crude descriptions, but the idea is that immunotherapy needs some kind of changes in the microenvironment to be more effective. And there is certainly preclinical evidence that radiotherapy or ionizing radiation in general can change the macroenvironment in a manner that makes immunotherapy more effective. So some of my colleagues have called these generally we use radiation as the fire to kill the cancer cells, but here the radiation is not the fire, but the fire starter, so that the immunotherapy can do its job better. So that's another exciting area for research. The problem is there are so many different ways of giving radiation in terms of the dose, the fractionation, how much of the tumor to radiate. You need to radiate all the tumor or only a part of the tumor. I think you might have heard about grid therapy or lattice therapy. Is it better to use photons or carbon ions or protons? All these variations, all these variables make these very difficult to study in humans because there's only so many clinical trials you can do. So I think this is another area where we need a lot of help from the radiation biologists and the cancer biologists to give us narrow down the range of options that would maximize the impact of radiation so that the immunotherapy can do its job better. And the immunotherapy area is so active, and I think it's a very, very promising area of research. And optimizing how radiation can help immunotherapy and vice versa, I think that's another very exciting area for the future. So, as I said, these are some of the areas that I'm excited about. I'm excited about the possibility of studying the adaptation, how tumors adapt to radiation, and how we can intervene on the fly during a course of radiotherapy to take advantage of those perturbations in the both in the tumor metabolism and its microenvironment, just as we have been doing for physical adaptation for the last 20, 30 years. I think we need to move into the era of biological adaptation of the radiotherapy. The last thing I want to touch upon before I take questions is the potential of radiotherapy for regenerative medicine. So we started off, talking about bone marrow transplantation. And if you think about it, what Don Thomas was doing, he was destroying the bone marrow cells, but the scaffolding is left intact. Okay. And so when you give the allogeneic or autologous bone marrow for that matter, it has the scaffolding is already there for it to go and attach and regenerate. Okay. So the radiation is making space for the bone marrow stem cells to repopulate the bone marrow with the healthy bone marrow as opposed to the diseased bone marrow. So one of my students, now my colleagues, Chandan Guha at Albert Einstein College of Medicine, did some very exciting work a few years ago where he tried this paradigm for the liver. And he was able to give supralethal doses of radiation to the liver in mice and destroy the liver, and then was able to regenerate the liver by giving hepatocyte transplantation. So this is again, the principle is the same, that you destroy the diseased liver cells, but leave the scaffolding intact. And then you give the liver stem cells, which will go and repopulate and create a brand new liver within a matter of 4 to 6 weeks. So of course, you have to keep the animal alive during that time by supportive therapy. But this has implications not only for cancer, but for metabolic diseases as well. That if the patient has liver cells that are incapable of making a particular enzyme, for example, that you can destroy all those cells and give, or you can genetically modify the cells of the patient's own cells and then give them back after destroying the liver parenchyma, and the new cells, which are genetically modified, will repopulate and basically create a new liver, which now does not have that enzyme deficiency. So in principle, you could apply this to many other organs in the body. So I think the whole field of regenerative medicine is a potential area. You can think of spinal cord injury. You can think of even brain injury. You can replace some people's brains. There are some people who could use a brain transplant, and this may be science fiction right now. But if you can replace the cells of the bone marrow, and you can replace the cells of the liver, maybe in future we can even replace the cells of the brain. So people are not as stupid as some people are. Anyway, so maybe I'll stop here, and let's see what we have in the chat and what people would like to ask questions.
Thank you, Dr. Vikram. Am I audible?
Yes, you're
yes,
audible.
yes.
Yes, you're audible.
Okay, so thank you very much for giving us a clinical side of use of radiation for treating various conditions, including cancer. And I do apologize because of the network, which is down. I have just joined with my mobile, so my picture will not be visible here. Sir, while going through your contributions, it is such enormous and such valuable for the humanity and the society. You have shared the Nobel Peace Prize in 2005, which was awarded to International Atomic Energy Agency of the United States. So maybe briefly, we will also like to hear about that. This will be very encouraging for our audience and the participants, that what went on to get this Nobel Prize. And secondly, by discussions and your talk, as you challenged many radiologists and biologists, especially cancer biologists, about problems which are still there, and we are not able to manage the disease properly. 3 questions which you pointed out very accurately, that why some patients are getting cured, not others. The second one was why some tumors are getting cured or giving response, not other tumors. And third one, why very different doses, ranging from 34 gray for the lung cancer to around 55 gray for cervical cancer with HPV positive cancers, 85 to 90 gray for head and neck and pharynx with the
I think we lost him. Can others still hear me? Yeah, okay.
I can, sir.
Okay. So let's see some questions. I think there's a question about leukemia. So leukemia, question is, what is the regimen of chemoradiotherapy in advanced stage leukemia patients, and how effective is that? So leukemia is not one disease, it's many diseases. I think the broad categories are acute leukemia or chronic leukemia, and lymphocytic leukemia or myeloid leukemia, and then there are many subtypes. And because leukemia is easier to study, because you don't need to take a biopsy, you just need to have blood or bone marrow. So a lot of advances have been made in the genetics of leukemia, and there are many subcategories based upon the genetic makeup of the leukemia cells. And as a result, the pharma companies have been effective in developing drugs, very targeted drugs for specific subtypes. But the broad answer to your question is that for acute lymphocytic leukemia, which is predominantly a disease of children, when I started my career, I would say 80 to 90% of the patients used to die within a few years, and now almost everybody is alive. So childhood acute lymphocytic leukemia has become a highly curable disease. We still have to deal with some of the side effects of therapy for the lifetime of these patients. And the role of radiation in leukemia for childhood has been that the drugs, there are certain sites in the body where the drugs have a hard time getting into, that nature has provided some barriers because they are especially precious. And one is the brain, and the second is the testis. So these children who are getting chemotherapy and going into remission, we found that they were failing, the leukemia was coming back in the brain and the testes. So then we started giving low dose of radiation to the brain and the testes in these children. And that has been effective in preventing relapse of the leukemia in these sites. So this is one success story, childhood acute leukemia, where the cure rate has gone from 10% to more than 90% in the course of a few decades. For the other kinds of leukemia, the acute myeloid leukemia, the results are still not very good. There's one exception. There is a variety of acute leukemia called acute promyelocytic leukemia, where a very interesting pharmacological development has been that it seems to be able to differentiate back into normal bone marrow by the use of a vitamin A analog called all-trans-retinoic acid. So this is a very, it's unique disease. I mean, it has been one of the hopes in oncology has been that instead of destroying the cancer cells, can we make them regress to a normal phenotype rather than a malignant phenotype? So this has been a very intriguing idea for that people have explored for many decades. But I think this acute promyelocytic leukemia is the only example I can think of where the strategy actually has been successful, that we were able to convert highly de-differentiated leukemic cells into well-differentiated normal bone marrow cells by using this vitamin A analog. So, as I said, there are many, many different subtypes of leukemia, and for many of them, very specific drugs have been developed because we have been able to understand their both their genetics and the epigenetics. So the success rate for acute lymphocytic leukemia in children, chronic lymphocytic leukemia in both children and adults, chronic myeloid leukemia in adults, those have been the success stories. The acute myeloid leukemia has so far still resisted. I mean, there have been some improvements, but not as dramatic, with the exception of the acute promyelocytic leukemia, where I think we have made this very interesting discovery about that you can force cancer cells back to a normal phenotype. So that's the only example so far, but hopefully in the future there'll be more examples. So the next question is, after radiation therapy, the tumor relapse may occur and it will become more aggressive. In those patients, what will be the line of treatment? So one of the lessons that I like to teach, and I think we have learned over the decades, is that in cancer, your first chance is your best chance. Because after that, you are only playing catch up. And every successive line of therapy tends to be less effective. There are one or two exceptions. So my advice is, don't give the cancer a chance to grow back. So the first line of treatment should be as effective. Now, this is a little bit, I'm going to make a politically perhaps incorrect statement, that some of the drug companies, they talk about making cancer a chronic disease, which is, but what they mean is that, okay, we give first line therapy and then the cancer comes back, we give second line therapy. So it's that it becomes like diabetes, that you are never cured, but you can live a pretty good quality of life, but you have to take our drugs for the rest of your life. So, that's one way of looking at it. But I think that because we know that radiation can cure cancers, and I have patients I had treated 30, 40 years ago who are still alive, that I think it is worthwhile to try to be as aggressive as necessary the first time around, so you don't have to deal with recurrent disease, because each time it will be more difficult to treat. And so there's no good answer to what the second line treatment should be. I mean, it should be based upon the molecular profiling of the tumor. And radiation very rarely has a role in the curative treatment of second line or a relapse cancer, because you have basically used up the tolerance of the normal tissues the first time. Again, there are rare exceptions, and you can get remissions, but it is always more difficult to treat it the second time around than the first time around. So I think all our efforts should be focused on curing the cancer the first time, so you don't have to deal with recurrent cancer. And by curing the cancer first time, not only that you start out with the best treatment possible, but that you also, using adaptive, both physical and hopefully in the future biological approaches, that during the treatment you monitor how the cancer is behaving and evolving, and you intervene at that point to either prevent that evolution of the cancer into a more aggressive form, or to interrupt evolution into a more aggressive form. So again, my advice is give it the best shot the first time around, because second time is going to be harder, third time is going to be even harder, and so on. What could be the reason for variable response to radiotherapy in patients with HPV-associated tumors as compared to non-HPV, like patients with oral oropharyngeal? Yeah. So this is one of the mysteries that you have to solve. I don't know the answer to that question. Obviously, the etiology is different, that the HPV positive tumors we are finding less in smokers, and the HPV negative are more tobacco related. So certainly, India has the dubious distinction of being probably the highest number of HPV negative cancers in the world, and many of them are related to the habit of tobacco chewing, gutka, in certain parts of the country. So those cancers are much more difficult to cure than HPV positive cancers. So I don't know the answer to why, but I know that tobacco associated cancers are much harder to cure than HPV associated cancers. And also that people who have been using tobacco for a long time, their bodies are not in such good shape. So they suffer more side effects. They cannot tolerate the drugs. They cannot tolerate the toxicity. And more of them die during treatment because of the side effects. So there, I think that's one area where most of our effort should be on prevention of tobacco-associated cancers. Now, with HPV, of course, the good news is that it is also possible to prevent HPV-associated cancers by vaccination. And so there are only a couple of cancers for which we actually have a vaccine to prevent the cancer. One of them is hepatitis B virus, which causes liver cancer. And the other one is HPV, which causes cancers of the oropharynx, cervix, and perianal area. So these are cancers that can be prevented by vaccination. And a country like Rwanda, which is one of the poorest countries in the world, has managed to give HPV vaccination to all its girls, so that in 20 years, Rwanda will have no HPV cervix cancer, and perhaps no HPV-associated oropharyngeal cancer either. They have vaccinated all the girls. HPV cancer in the oropharynx in men is less common than cervix cancer was in women. So they focused on preventing it in women. But I think there is increasing evidence that by HPV vaccination, we can also prevent the development of oropharyngeal cancers. But again, many other countries have not been as successful as Rwanda in vaccination. But I would strongly encourage, that vaccination for those cancers that we can prevent, and tobacco control for those cancers we can prevent, is, I think that's a high priority. Of course, the patients who still develop the cancer, will have to find ways to treat them. but clearly prevention is much better than treatment. So I think those are where the effort should be doubled. How come lung is one of the most affected organ in the radiotherapeutic treatment of acute leukemic patients? Well, as I said, when Don Thomas started doing this and other people started following his treatment regimen, so the acute radiation syndrome, patients die from hematological toxicity, and the bone marrow transplant was able to overcome that. And then the next most sensitive organ seems to be the gastrointestinal system, and you can provide supportive care, intravenous fluids, antibiotics, fecal transplant, et cetera, to overcome the gastrointestinal syndrome. And then we got stuck with lung toxicity, and we still haven't, other than reducing the dose of radiation to the lung, we haven't figured out what to do about it. So I think Dr. Prasanna might have talked about the physiology of lung fibrosis and what drugs are being developed to prevent or mitigate lung fibrosis. But why some organs are more sensitive to radiation than others, again, is one of these mysteries that we haven't solved. We have found ways to overcome them by bone marrow transplantation or supportive care. But I don't think we really have a good understanding of why, just as some tumors are more sensitive to radiation than others, why some organs are more sensitive to radiation than others. And even within the lung, some individuals' lungs are more sensitive to others. Now, we do know that if the lung is already damaged from, for example, smoking, then those patients don't do well with radiotherapy. And if the lung is relatively healthy, those patients do better. But other than that, even, I think, again, it has to, probably has to do with the omics of the individual. So the omics of the tumor are important, but the omics of the normal tissues are also equally important, if not more important, in terms of protecting them. So this is an area for study for some of you to tell us why lungs are more sensitive than, let's say, bone, or why Mr. X's lung is more sensitive than Mr. Y's lung when both of them are non-smokers. So I think these are some of the mysteries that still remain to be solved. Is there any stem cell functional animal models are known to study effects of radiation? I think I'm going to hand that question over to Dr. Dwarkanath. I think you're in a better position to talk about stem cell functional animal models. What do you think?
The effect of radiation. I don't know what oh, wait a minute. Okay.
I asked this question. This was me only.
Well, yeah, go ahead.
So there are like, do we have any kind of like people do have they ever tried to look at the bunch of the stem cell? So they only talk about that they only there are no functional model, like which particular stem cell is doing any function. We only do some kind of a xenograft study with some stem cell, but we never separate it according to their functions. So that kind of a functional models have been ever being studied over there.
Like what do you mean by specific function of the stem cell? Let's give me two examples.
Like
Stem
for
cell
example,
1 does this function,
like
stem cell 2 does this function.
No, like for example, you have taken some number of antigens, antigen marker, the surface antigen marker of the stem cells, and according to that, you have we have done the cell sorting, and then we have taken those stem cells and then we have injected into the mice, and we saw that some of them are making the tumors, and some of them are aggressive tumors, some of them are so that is like not every stem cell will give us a the tumor. So according to that, have we ever looked into those kind of a function that
Oh, your question is, if I had 2-3 stem cells isolated from any particular tumor before therapy or after therapy, and if I characterize them based on some of the phenotypic characteristics of stem cells, and if A, B, C sources of stem cells differ from one another, what is their potential to form tumors and exhibit or manifest aggressive behavior in the host where they regrow? Is that your question? Based on this, can one relate their graftability and the growth and behavior linked to known determinants or phenotypes of these stem cells? Is that what you're asking, Dr. Weber?
Sir, she has been disconnected due to network issues.
Oh, okay.
Well, so I can we can talk about this afterwards also, but the one of the problems with the animal models is that these are not spontaneous tumors.
Yeah.
And so I think Riba is back. So I was just saying that animal models obviously have limitations because the tumors are not spontaneous. And so while Dr. Dwarkanath can give a more elaborate answer on the what models one can use, one of the areas that we are interested in exploring is dogs. That dogs have a lot of spontaneous tumors. And some of my colleagues at NCI have been studying the dog tumors, and 2 or 3 tumors, especially osteosarcoma, glioblastoma, and mucosal melanoma, seem to have very, very similar characteristics from a genomic point of view to human tumors. So we are thinking that these spontaneous tumors with an intact immune microenvironment might be good models for studying these particular tumors, at least where there are genetic similarities between the dog tumor and the human tumor, as opposed to the mouse model, where almost always you're creating an artificial environment and you're using cell lines which may have changed their characteristic over many passages. So I don't know if Vibha, that answers your question, but we can continue this discussion at another time. Yeah.
Yeah, it's fine. So we were, it's okay. I think they let students ask this question, because I'll ask, I can ask even later also. Is there any other question?
Dr. Vikram answered all the questions in the chat box. In the chat box, whatever was there, he answered.
We have made it. We have made host you now, so that the meeting should not be lost in between, because there is some JNU. There is a major internet issue. Okay, so yeah, so.
I'm happy to go back to sleep now.
No, maybe I don't know, but if there is any other question, so. There was one question, I think Professor Rana has asked you about your Nobel Peace Prize. Did you answer? Because I lost in between. Would you like to answer, or maybe, yeah?
Well, it was being in the right place at the right time. So this was, so it's interesting. When I went to the International Atomic Energy Agency, the cancer control program was really very not very prominent. And so I would go to the cafeteria, I would introduce myself, I'm a physician. I would say, oh, you must be doing physical exams on, and people knew are newly hired. I said, no, we actually have a cancer control program. I said, oh, you mean because radiation causes cancer, you're trying to do something about that? So no, we can actually cure cancer. So there was a lot of misunderstanding about what radiation is and what it does. And I was just amazed at how many, not only political leaders, but also scientists had so many misconceptions. So we were able to grow the program. We created this program called the Program of Action for Cancer Therapy, which is now a formal program within International Atomic Energy Agency with its own budget and everything. And we, helped build cancer centers and train people, hold courses like this at a continent-wide level in different regions of the world. And but the main work of the Atomic Energy Agency is, preventing the proliferation of nuclear weapons, and also keeping track of radioactive materials, for example, from nuclear power plants and nuclear reactors. So at that time, there was recognition that the agency was doing good work to prevent the proliferation of nuclear weapons, and also to promote the peaceful applications of nuclear technology, of which radiotherapy was, one. Nuclear medicine is another one. So the Nobel Committee, in their wisdom, they decided to award the prize, and they cited the work that the agency was doing to prevent the proliferation of nuclear weapons and nuclear materials. But they also recognized that we were doing work to promote the peaceful applications of nuclear technology. And so, like I said, it was good to be at the right place at the right time. And I have a nice Nobel Prize to show on my wall to my visitors.
Yeah, good. So there is one question from Antara. I think she can ask. Antara, would you like to ask?
Yes, ma'am.
Jen?
Sir, I want to ask that, is there any radio protector developed so far against lung cancer that can prevent the lung fibrosis during radiation treatment?
So the short answer is no, nothing that has been approved. I think if you look back to Pataje Prasanna's lecture, okay, actually, this is also an interesting story that when September 11, 2001, as I said, was a kind of a pivotal moment, both in my life and the United States and the whole world. When the terrorism attack happened in New York. Shortly after that, there was a fear in the United States Congress, because many members of Congress were sent anthrax in the mail by somebody. And so there was a lot of fear of both this kind of biological terrorism, chemical terrorism, and nuclear terrorism. So I think by now everybody must have heard of Dr. Fauci, who's our COVID expert. So he's one of my colleagues, and he's the head of the National Institute for Allergy and Infectious Diseases. So of course his institute has done, and he personally has done, amazing work for HIV. HIV used to be a death sentence, and now, thanks to a lot of the support that he has given to research in that area, people can take one pill a day and live a normal life pretty much. And he has been, proactive in trying to prepare us for pandemics like SARS and MERS and now COVID and Ebola. But his institute, because this whole scare started with anthrax, and his institute is the Institute of Infectious Diseases, they were given some funding to develop countermeasures against biological agents, but also they added chemical and nuclear terrorism. So countermeasures research was underway when I arrived I left the Atomic Energy Agency in 2006 and came to National Cancer Institute. So at our organization, countermeasure research was going on. And I learned about it, and I said, we hope that these countermeasures will never be used, that there will never be a nuclear attack, that there will never be a chemical attack. And these drugs will be developed, but they'll sit on the shelf. So that's when we thought that maybe we should try to use these drugs for cancer patients who are undergoing radiotherapy to protect them from the effects of radiation. And so Pataje just joined shortly thereafter. And so I put him in charge of this portfolio. And so he's been working with the investigators who have been developing countermeasures to take some of those countermeasures and bring them to the radiotherapy clinic for testing. So, I think he had a list of the various agents that are being tried, what phase of development they are in. And so we are hoping that some of these drugs will become approved for use as radiation protectors or mitigators, and not just sit on the shelf as countermeasures. But those trials are still not complete. And so there's no drug at the moment that has been approved. And so our best strategy at the moment still remains the physics to try to minimize the dose to the lung. So to prevent, and also, to tell the patient to stop smoking, so they're not causing additional injury to the lung. But hopefully in the next few years, we will have some drugs from the list that Pataje shared with you that will become available to prevent lung injury in the future.
Thank you, sir.
Okay, so I will just ask for the benefit of the students one question, what kind of opportunity is there for the students? I'm not talking about the postdocs only, but there are some young researchers, young faculty who want to apply for the grant in this area. Is it that like I know RO and this, so is that there is any specific grant which is internationally available to the say citizens of the other countries also in the area of radiation?
Yeah. So most people are not aware that National Institutes of Health, most of our grants are open for anybody in the world. Most of our grants. There are only a few that are restricted, but most grants are available to anybody in the world. I think the problem is people don't apply. They feel they feel that the field is too competitive. I don't know. But if you just go to the website, you will find that there are plenty of grants that you can apply for. There is some paperwork that is necessary, and it is useful if you have, to give you one example, the reviewers, because most of our grantees are from the United States at this time, most of our reviewers are from the United States, because we pick reviewers from people who already have grants by and large. Okay, so it is useful to say that I have something unique here, which may not be available in the United States. It's not necessary, but it is useful to be able to say that I have something special available here in India that is not available in the United States that will benefit all of humanity. And give an example, for example, this HPV negative head and neck cancer we just talked about. India has the largest number. Unfortunately, India still has the largest number of cervix cancer patients in the world. So, and these are, some of these are diseases that are becoming very rare in this country, in the United States, to do research because there aren't enough patients. So if you pick I think gallbladder cancer is another example, which is very common in India, very rare in the rest of the world. So if you pick a problem where you have some special access to patient material or some technology that is uniquely available to you, I think those are the United States-based reviewers will be more sympathetic than saying, oh, this can be done in Boston or this can be done in New York. Why should we do this in Delhi? But if there is a problem that you can show that it has a bigger impact, I think the reviewers will be more understanding. But like I said, there is no prohibition against people applying for grants from the National Institutes of Health or National Cancer Institute. And the most important is so if you have an idea, you can send just a 2-page summary to Pataje Prasanna or myself with some specific aims and a synopsis, and also, I think, an approximate budget. Are you talking about 2 years, 3 years, 5 years, etc.? So just a 2-page summary will be a good starting point. So send it to us, and then we'll be able to direct you to the specific funding opportunity that might be appropriate. So it does involve some paperwork, but I think it's like if you don't buy a lottery ticket, you're never going to win the lottery. So you have to apply.
So I have another question. Is there any short-term program for the younger students for after doing PhD or something other than like name program, or like earlier we had Corona program or something like this? So is there any short-term programs are available in terms of the radiation there where people can go and get some funding or something like that? Is it available somewhere?
So we don't have that in-house, but we support, hundreds of universities. So, like I said, you can, so you would have to apply to a university in Boston or New York or Atlanta or Los Angeles or wherever. They are independent of us. Many of them have programs for students because our jobs are US federal government jobs. There are many more restrictions on hiring non-citizens or non-residents. So I think the chances would be better in what we call the extramural community, which is all the universities that you hear about, versus the intramural community where you are actually working in Washington in an NIH lab. It's not impossible. Again, so if there's a particular, depends upon the interest of that particular laboratory. If they have, for example, a lab at the NIH is interested in research on gallbladder cancer, and you have some special skills with regard to gallbladder cancer, you have some biospecimens or you have some insight that you can contribute, then they might be interested in having you. But for the most part, I think the chances would be better in the extramural community because there are hundreds and hundreds of universities, and they are looking for bright students to participate in their research. And it doesn't have to be, so our budget, I would say we spend only 10% of our budget in-house. 90% of the budget goes to the extramural community. So, and that can be anywhere in the world, but most of it is in the United States because people apply. So I think your chances are better applying to a particular university where somebody has done the work that you are interested in, that you can contribute something, and there is some symbiotic relationship. It's not impossible at the NIH, but I would say it's more difficult because there's only a few labs, and they are very, very focused on their own area. So we spend most of our budget, we spend outside the NIH and not in the NIH.
Okay, I think you must be tired, but there are one more question. I don't know, how successful is radiation therapy in gallbladder cancer? What sort of radiation therapy is given in such patients?
It's not very successful because it's very rarely diagnosed early. So it's quite advanced by the time it has spread. Many times it has spread all over the abdomen, and that makes the dose of radiation you can give very limited. So by and large, I would say it is used for palliation. In some cases where the surgeon went in thinking that he or she is just dealing with the gallstones, and takes out the gallbladder and incidentally finds a cancer. In those cases, the cancer is small enough that it hasn't spread all over the abdomen. And in those cases, we give radiation to the gallbladder area and the adjacent liver. And some of those patients go on to be long-term survivors. But I would say that if in almost all other cases where the gallbladder cancer is not diagnosed accidentally because the surgery, the surgeon did not think there was cancer, the surgeon thought they were only gallstones and took out the gallbladder. So again, I think the next question was, is surgery successful in gallbladder cancer? It's only successful if the surgeon did not suspect cancer. So if the cancer is accidentally found and removed, then it is successful. But most of the time, by the time the patient has symptoms from gallbladder cancer, the cancer has already spread, and neither surgery nor radiation is very effective. And I think some drugs have been shown to cause remissions. I think this is an area where radioactive drugs may be worth testing in the future. And again, because gallbladder cancer is so much more common in India, I think India would be the place to do the research on these radioactive drugs for gallbladder cancer.
Okay, over to Dr. Dwarkanath. For my side, it's like, thanks a lot, Dr. Vikram, to be there. And after a long wait, we could do it, although we could not get you physically here. I hope next time when are you planning to come here?
As soon as COVID allows. Yes.
So earlier you used to, because you have a family in Delhi itself, I think.
Yes.
So fine, and over to Dr. Dwarkanath if he wants to.
No, I don't have much to add, except to thank Dr. Vikram again. Despite a very odd hour for him, we did not know that you were in West Coast. But the session was, without the slide, one can say that it was so enthralling, and then the amount of discussion it elicited speaks everything. So thank you so much. It was nice hearing you after a long time. And
good to see you all.
we look forward to seeing you here, sir, sooner than later.
Okay, so over to Dr. Anapratap. He was the chair. So.
You have already chaired, so.
No, I didn't chair. I just wanted to ask him several things. So that's what.
Oh, actually, there were so many interruptions. So we do apologize, sir, for so many interruptions from our side, and also troubling you in the early morning, and as Dwarkanath was just telling. And from my side also, there is not much to add, but just I wanted to have your comment on one thing which you said about HPV-associated cancer and tobacco-associated cancer. You said that tobacco-associated cancers are difficult to treat as compared to HPV. So what do you think that since tobacco is having hundreds of carcinogens, and if the cancer is arising because of tobacco, the cells might be having diverse and huge amount of genetic load as compared to those which are coming from the HPV. So this could make a difference in terms of treatment.
I think you are right. I can tell you from the clinical perspective that HPV positive cancers can be cured with a lower dose than HPV negative cancers. So there is definitely a difference in the radiation sensitivity. And paradoxically, even though the HPV negative cancers that are tobacco associated need a higher dose of radiation, the patients are usually in worse shape because of tobacco physiologically. So that's why I think that both they have lower cure rate and higher complication rate. And as a result, the survival of patients with HPV negative cancers is much worse than the survival of patients with HPV positive cancer. So we need to work on both fronts. We need to increase the susceptibility of the cancer cells to the radiation by developing better radiation sensitizers. And we need to reduce the toxicity of what we are giving because the normal tissues in these patients are already compromised and they are more likely to suffer the side effects. Yes.
One related small observation. We have heard about secondary tumor. So what is your take on after radiotherapy, people get secondary tumors after a few years? And usually it is said that it is because of the radiation therapy.
There's definitely secondary tumors after radiation. People who were exposed to radiation in Hiroshima and Nagasaki for many years, they have had higher incidence of all kinds of cancers, starting with in the early years was leukemia and thyroid cancer. And as the decades went on, they found that almost every cancer was increased in these people, including breast cancer and lung cancer and so on. And of course, the relative increase is, it varies from cancer type to cancer type, and is compounded by comorbidities like, again, tobacco use. So smokers had much higher incidence, etc. So there's definitely an increase in cancer by radiation. And that's one of the reasons that you try to minimize the normal tissues that you are exposing to the radiation, because the more normal tissues you expose, the more chances there are of a secondary cancer. So having said all that, radiation-induced cancers are rare. And the most susceptible are children. So growing tissues are more susceptible to radiation-induced cancers. And that's why over the last 30, 40 years, we have minimized the use of both the usage and the dose of radiation for children with cancer. And so for leukemia, for example, we were talking, instead of using whole body radiation, now you use drugs, and you only use radiation to prevent relapse of cancer in the testes and the brain. So you just limit the amount of radiation, give quite low doses and just to very limited volume of the tissues. So that has dramatically reduced the incidence of radiation-related cancers in children who are long-term survivors of leukemia. Now, depending upon the kind of cancer you're talking about, the risk of second cancer may not even be worth. If somebody has gallbladder cancer and the chances of dying are 100% from that cancer, you're not going to worry about what might happen with a second cancer 5, 10, 15 years from now. So it becomes more of an issue when your cure rates actually become higher. So the higher the cure rate for the first cancer, the more then you have to worry about the second cancer coming in 5, 10, 15 years. And therefore, it's always a good idea to minimize the amount of normal tissue that you're exposing to radiation. And I think that's where the physical developments with regard to various kinds of therapy have been helpful, particularly protons. But although the first generation of protons, where they use scattered beams, there was concern that the scattered beam would produce more secondary cancers. But I think now these days, with the different kind of beam, which is much more targeted, this has become less of a concern. So there's always pluses and minuses, and sometimes you don't know about these late effects until the late effects by definition happen late. So the priority is to cure the first cancer, but if the chances of cure are high, then you have to make sure that you do everything possible to minimize the chance of second cancer by reducing the volume of tissue that you're radiating. And increasingly, we are scaling back the dose for example, Hodgkin's disease. When I started out, people used to give 40, 50 gray. And now the dose, many patients with Hodgkin's are given no radiation at all. And if they are given, it's usually 10 to 20 gray. So that, and also the volume is, instead of giving whole mantle radiation or whole paraiotic radiation, you just give to the involved lymph nodes very, very restricted volume. And that has dramatically decreased the incidence of secondary cancers. So girls with Hodgkin's disease who were treated back in the 1960s and 70s, many of them 20, 30 years later developed breast cancer. But those who have been treated in the last 20, 30 years, we are not seeing that at all because we have reduced the amount and the volume of radiation. So, as the cure rate increases, for the first cancer, then you have to worry more about making sure that you're not creating more second cancers. Yes. Okay,
Sir,
I think I'm going to, yeah. Okay, I'll take one more question, then I think I need to.
No, sir, it's not about the question. I guess the chairpersons have got disconnected due to
Yeah.
network issues. And special thanks to Professor Vikram Bhadrasen, sir, for lending us your precious early morning time. And your presence have been really inspiring to us.
Thank you, and hope to see you in person. And I think Dr. Vibha has my email, so if anybody has other questions, feel free to send me questions by email. Okay, I look forward to hearing from you.
Thank you and good day.
Goodbye.
Goodbye.
So by this we and thank you very much, Dwarkanath sir. So you only one right now.
Okay. Sure. I will also leave if you will permit me.
So yes, sir. We are ending.
Okay. Thank you.
Yeah, thank you, sir. So by this we end today's session. We believe that this team was about radiation biology and clinical impact